My name is Dukran Kazanjian, and I'm a
Good morning, good afternoon, and good evening to everyone joining us from around the world. I'm Susanna Mikaelian from OncoDaily, and it is our great pleasure to welcome you to Myelo 2026, the OncoDaily's virtual congress dedicated to multiple myeloma. Today, we're privileged to be joined by outstanding clinicians, researchers, scientists, and healthcare leaders whose expertise spans patient care, innovation, education, advocacy, bringing a truly multidisciplinary perspective on multiple myeloma in 2026. Over the course of today's program, we look forward to a rich exchange of insights, experience, and practical perspectives for our colleagues involved in multiple myeloma care worldwide. And now it is a great honor to welcome Tigran Kazanchian, Professor of Clinical Medicine in the Division of Myeloma at the University of Miami Sylvester Myeloma Institute, Associate Director of the Institute and Assistant Director of Clinical Research Services at the Sylvester Comprehensive Cancer Center to deliver the welcoming speech and officially open the Congress. Thank you.
My name is Tigran Kazanjian, and I'm a professor of medicine at the Sylvester Comprehensive Cancer and Myeloma Institute at the University of Miami. It is my great pleasure to be chairing this session by OncoDaily, the Global Congress on Myeloma, and I'm quite humbled to be among very many excellent speakers for this Congress. It is an exciting couple of years, actually, in the treatment and management of multiple myeloma, and I know we're going to be hearing a lot about this in the upcoming talks. But just to mention some key pivotal new things in myeloma is basically the shift forward to quadruplet therapies for the treatment of newly diagnosed multiple myeloma. There's been in the last couple of years multiple randomized studies showing that the quadruplets are superior to the standard triplet therapies, and this has already moved on to sort of the gold standard in the treatment of newly diagnosed multiple myeloma, at least for most settings. This is only seconded by really the shift forward to earlier lines of treatment in terms of immunotherapies. And as we refine the triplets to the quadruplet story, I think many of these novel immunotherapies have also been tried and will be coming to the earlier lines of treatment and probably eventually to the first line treatment, specifically with the bispecific T-cell engagers and with the CAR T therapies, especially some of the newer ones that are on the horizon and some even potentially close to FDA approval. We can see this with actually the recent FDA drug approval for the teclistamab and daratumumab for the second line treatment, which is excellent because it gives patients who need second line treatment an option between now CAR T immunotherapy or antibody-based immunotherapy. I think the second really pivotal moment in multiple myeloma management has really been the establishment of the importance of minimal residual disease testing, or MRD. We've all been using MRD in research and many of us in the clinic, but the most pivotal moment, I think, was the ODAC FDA 12-0 vote on really establishing MRD as an early intermediate endpoint, at least for accelerated approval. And we've already been seeing that used as primary endpoint in some of the drug approvals that have been approved or are going to hopefully become approved in the relative near future. And lastly, I think another pivotal change has really been the management of smoldering myeloma. Outside of really clinical trials, smoldering myeloma, regardless of the risk of the smoldering myeloma, was mostly a watch and wait scenario. However, we did also see first approval of a therapy for high-risk smoldering myeloma. And currently, there are many new trials using even more of the novel therapies, including the immunotherapies, that would potentially, really lead to significantly improved patient outcomes. I think as our medicines are getting better and better, we're approaching, functional cure, but it's not just about getting our medications better, but also using them at the appropriate time. And it is not a huge leap of faith to think that it's probably best to use some of these therapies that use our own immune system, meaning the immunotherapies in earlier lines, even at the smoldering myeloma stage. On that note, I would like to thank, all the viewers for joining us. And I know you won't be let down with the series of speakers and the topics that will be discussed. On that note, I will turn it back to the Congress.
Thank you, Professor Kazanjian, for such a thoughtful, excellent opening address and for your leadership in opening this Congress. We're moving forward to our next speaker, Yinghui Li, Assistant Professor at Nanyang Technological University, Singapore, whom we're very pleased to have with us today. She will be speaking about how decoding TNFR-driven lung non-coding RNA functions may help design new therapeutics for multiple myeloma.
Thank you. Can you see my screen share? Sorry, just give me a moment. Okay. Good morning, everyone. Thank you, everyone. Thank you, OncoDaily, for the kind invitation to present my work. Hang on now. Got lost. Okay, hang on. Sorry. Okay, let me try again to share this. I can't share. Sorry. My slides got lost. I'm not sure why I can't share. Oh, hang on.
It seems we're experiencing some technical issues. We will resolve it shortly. Please bear with us for a moment.
Sorry. Okay, is this, are you able to see the screen? Hello? Are you able to see? I can't share.
No, we're not able actually.
Sorry. But it was fine. Okay, can you see? Are you able to see now? Hello?
Yes.
Oh, you're able to see? Okay, good, great. Okay, good morning, everyone. Sorry for the technical issue. So I'm an assistant professor from the School of Biological Science in Nanyang Technological University of Singapore, and my lab's research is focused on understanding how inflammation-driven signaling mechanisms can shape the chromatin dynamics that in turn regulate cancer progression. And today I'm very pleased to share with you some of our latest work whereby we have uncovered how TNF receptor driven long non-coding RNA can play a role in the chemoresistance of multiple myeloma and how this can be exploited for the design of new therapeutics for multiple myeloma. So we know for a very long time that inflammation from the inflammatory cells as well as the cancer cells, they can play a major role in regulating tumor progression through various, they can promote multiple oncogenic processes, including the survival, invasion, angiogenesis, proliferation, and growth. However, we know recent studies have shown that beyond this inflammatory gene signature, there are various kind of epigenetic alterations that can be regulated by these inflammatory processes. So my lab's research is focused on understanding how these pro-inflammatory signaling mechanisms can drive such oncogenic cis-regulatory programs and how this regulatory DNA can in turn impact on cancer progression. So in our, particularly for today's talk, I'll be sharing with you a novel NF-kappa B regulated long non-coding RNA, which is regulated through the non-canonical NF-kappa B pathway, and how this long non-coding RNA can interact with major epigenetic regulator PRC2 complex that in turn drives multiple myeloma resistance and progression. So the non-canonical NF-kappa B pathway plays an important role in essential roles in immunity as well as in inflammatory responses, and is activated through a distinct set of ligands from the microenvironment, and it leads to the stimulation of a distinct class of TNF receptors, including LT beta receptor, CD40, BAF receptor, and FM14. And this stimulation leads to the activation of the signaling cascade, whereby you have the stabilization of NF-kappa B inducing kinase, which in turn phosphorylate IKK alpha, leading to the processing of P100 to P52, which forms an active transcriptional dimer with REL-B to induce various processes that can regulate various kind of inflammatory as well as oncogenic processes. So while defects in this pathway have been linked to various immune deficiencies, whereas the aberrant activation of this pathway through genetic mutations have been documented to be important for various kind of hematological malignancies, including multiple myeloma, and also implicated to drive the chemoresistance of such cancers. So we know that multiple myeloma is a very aggressive kind of hematological malignancy that is known to frequently relapse. So it arises from the post-germinal B cell, whereby they accumulate various type of genetic events that leads to abnormal proliferation in the of plasma cells in the bone marrow, where it develops into a malignant kind of cancer. So what is interesting is that we know that it has been previously documented that up to 15% to up to 40% of the myeloma patients, many of them they display this activating NF-kappa B mutations that lead to the activation of the non-canonical NF-kappa B pathway, leading to the constitutive activity of the P52 REL-B transcription dimers. And this increase in the frequency, this frequency of mutations increase in patients that acquire resistance or become relapse or refractory to this treatment. So for our research, we started to ask whether this aberrant activation of the non-canonical NF-κB pathway can have a role in terms of regulating the enhancer landscape of the myeloma to in turn on various kind of genes that are essential for myeloma genesis. So in our recent work, when we tried to look at the NF-κB or p52 regulated enhancers and look at its origins in the patient samples, whereby we screen myeloma patients based on their expression of NF-κB target genes. So here you can see these are the patients that have high levels of NF-κB activity versus those that have low NF-κB activity, as well as the normal plasma blast. We see that across these samples, those p52 regulated enhancers are enriched in the NF-κB enriched activated myeloma samples. Patient samples, and they display high levels of enhancer activation as well as chromatin, open chromatin, accessible chromatin regions. And amongst these regions, we can see that a large proportion of these are de novo or reactivated, meaning to say that they are activated only in the myeloma tumor cells, and they are lost or not active in the normal B cell developmental stages. So what we see is that this type of p52 bound or regulated myeloma specific de novo enhancers are activated heterogeneously in various non-lymphoid tissues, suggesting that this constitutive p52 activity can co-opt enhancers from the normal kind of for other kind of developmental stages, rather than just co-opting kind of enhancers from normal lymphoid development. So it's from other kind of developmental lineages. And interestingly, we find that these enhancers are associated with chromatin interactions to the promoters of various essential genes that are important for myeloma genesis as well as myeloma progression. So amongst these kind of cis-regulatory interactions that we have seen, one of these is a novel long non-coding RNA, which we term as plum after this sweet and juicy fruit here that you see here. So if you can see the chromatin dynamics, this is the enhancer that's bound by p52 in the control cells. It is interacting with the promoter of plum, and upon p52 CRISPR knockdown in these myeloma cancer cells, you can see that there is a reduction in these chromatin interactions along with its transcriptional activation. And this enhancer is enriched in the NF-κB activated myeloma patient samples. So amongst the p52 regulated transcripts, we see that this long non-coding RNA plum is unregulated in majority of the aggressive subtypes of myeloma, specifically the MAS, as well as the low TP53 subtype that express high levels of NF-κB activity. And amongst the patients from the myeloma MMRF COMPASS data set, we see that patients that are refractory or non-responsive to the standard treatment regimen, which is VRD, for these myeloma patients, they significantly express high levels of plum. And when we stain for the expression of plum in our myeloma samples, we see that plum is enriched, is localized mainly in the nucleus, suggesting that it might play roles in the nucleus or in the chromatin. So to try to understand this further, functionally, we overexpress the transcript in myeloma cancer cells, and we see that overexpression of plum results in this increased proliferation as well as the increased resistance to two of the key drugs, bortezomib and lenalidomide, which is used in the standard VRD treatment regimen for myeloma patients. So when we perform further in vivo kind of validation assays, we see that plum overexpressing tumor xenografts, they proliferate more, as well as they show increased resistance to the bortezomib treatment. And you can see compared to the vector control counterparts. And this tumor xenograft, they show much poorer survival when they overexpress plum compared to the vector control tumor xenograft. that we see here, implying that this plum plays an important role in the oncogenicity as well as the resistance of multiple myeloma. So to try to further characterize what is potential functional domains and which are its interacting proteins, what we did was we first performed various in vitro mutagenesis of each of the individual coding exons of the full-length plant transcript, and we overexpress this full-length transcript versus these mutant constructs in myeloma cancer cells. And what we see is that the mutants that are deficient in exon 1 or exon 7, they lose their pro-proliferative effects compared to full-length plant transcript, as well as the resistance to the bortezomib treatment. So to further characterize what are the functions of exon 1 and exon 7 of plant transcript, we perform RNA in vitro transcription of each of the transcripts for full-length plant and del exon 1 and del exon 7 plant transcript, and we perform RNA pull-down assays followed by mass spectrometry analysis. And here when we see amongst the differential binding proteins, while there are no differential binding proteins between full-length plum versus the plum that is deficient in exon 1 transcript, we see that a prominent differential binding protein between full-length plum and del exon 7 of plum is EZH2, which is a major subunit of the PRC2 complex. So as I mentioned, EZH2 is the catalytic subunit of the polycomb repressor complex 2, PRC2, which forms the PRC2 core members together through interaction with the core complex members SUG12, EED, and RBP4 or 7. And this forms the PRC2 core complex. And this is a catalytic subunit. It acts as the histone methyltransferase, whereby it catalyzes the deposition of the H3K27 trimethylation mark that in turn represses the chromatin to repress, for example, the tumor suppressor genes. And the overexpression or aberrant expression of our activity of PRC2 has been implicated in various cancers in the treatment resistance as well as the progression, as well as including also inflammatory diseases. So interestingly, when we perform FISH immunofluorescence staining assay as well as RNA immunoprecipitation assay, we confirm that there is a co-localization of plum as well as EZH2 in the nucleus of myeloma cancer cells. And this is also further confirmed by RNA immunoprecipitation assays demonstrating that EZH2 binds strongly to plum transcript in vivo. So when we further verified this with our RNA pull-down assay followed by Western blotting, we can see that when the plum transcript is absent for exon 7, it loses its interaction with EZH2 as well as the PRC2 core complex members EED and SUG12, implying that this exon 7 of plum is important for the interaction with the EZH2 as well as the PRC2 core complex members. So when we further depleted the expression of plum through antisense oligonucleotide treatment, we can see that in the cancer cells, myeloma cancer cells, they lose the phosphorylation of EZH2, which is the active kind of catalytic site for EZH2 histone trimethylation activity that you can see here. And this is lost even in the presence of ectopic overexpression of EZH2. And you might like to know that these are some of the transcriptional repressors of the cell cycle repressors that in turn become de-repressed, and these are turned on upon these are overexpressed upon reduction of EZH2 activity, demonstrating that EZH2 plays an important role in repressing this, the expression of these cell cycle progression modulators to in turn promote cell cycle progression in the cancer cells. So when we further characterize the EZH2 plum interaction, we first degraded plum expression through shRNA and perform EZH2 co-immunoprecipitation assays, and we see that upon the degradation of plum, EZH2 loses its interaction with the core complex members of PRC2, EED, and SUG12, implying that this interaction is critical for the formation of the plum, the PRC2 complex. And this RMP complex is also important for maintaining or promoting the catalytic activity of EZH2. So to further characterize the biochemistry of this interaction, we first performed the in silico structural prediction of the exon 7 sequence of plum that you see here in gray, and we performed in silico docking with the protein structure of EZH2, and we predicted some of these interacting residues. So amongst these interacting residues, this in the protein domain of EZH2, we can see that some of these residues have been previously documented to display RNA binding activities for PRC2 complex or EZH2. So to further check whether these residues are important for the interaction of EZH2 with plum, we've mutated each of these residues and we perform RNA pull-down assays. And interestingly, we see that amongst the mutants, the mutant 4, HA mutant 4, which is the region for the disordered region of EZH2, loses its interaction with plum the most when this disordered region is mutated, implying that this disordered region or EZH2 plays a critical role for the interaction between this RNA with EZH2, as well as important for the formation of the PRC2 core complex. And we further verified this with our mutants with our co-immunoprecipitation assays, and we see that the disordered region mutant of EZH2 loses its interaction with the EED as well as SUG12, implying that this region is important not just for the interaction with plum, but it's also important for the formation of these PRC2 core complex members. So we know that there are many kind of complications for the myeloma disease, and it's because of these complications that causes it to for the refractory patients to encounter various kind of debilitating kind of disease. So this is due to the abnormal proteins, which is the abnormal M proteins. These are monoclonal antibodies that are abnormal, and they are not able to have a normal kind of defense function, and they overcrowd the blood, and also they overcome the normal kind of immunoglobulins that are important for the normal immune defense. And these abnormal M proteins not just accumulate in the blood, they also accumulate in various tissues, including the kidney as well as the bone. And this causes the complications of the myeloma disease when the patients encounter relapse after this kind of encounter resistance to the typical kind of standard regimen treatment. So to try to understand how this plum EZH2 complex might be regulating potential genes or processes that might be contributing to this chemo-resistance or resistance kind of or the aggressiveness of this myeloma disease, what we did was we first knocked down plum in our myeloma cancer cells, and we performed H3K27 trimethylation ChIP-seq. And we are surprised to see that upon loss of the plum expression, there is almost a global loss of the demethylation of this histone mark, and these regions fall at the EZH2 bound transcriptional start sites of various genes. So amongst these genes, one of the most enriched pathway that we see that is regulated by this plum upon plum knockdown was the unfolded protein response pathway, UPR. So the unfolded protein response pathway plays a major role in the balance between the cell death and the cell recovery when the cancer cells encounter proliferative stress, such as where they have the abnormal accumulation of these proteins, and they try to overcome this so that they can survive and proliferate, or they can lead to the induction of the apoptosis if the damage is too large in the cells itself. And so this pathway plays an important role in terms of mediating the balance between cell recovery and survival versus cell death. So amongst these signaling cascades for the UPR pathway, we see that the plum transcript plays an important role in activating the phospho-IRE1 alpha splice XBP1 axis signaling axis, which plays an important role in the pro-survival kind of functions, particularly also in the myeloma cancer cells. So to further try to understand whether we can design a new or novel therapeutics targeting this plum EZH2 interaction, and in turn try to overcome this chemo resistance in the myeloma patients, what we did is we first performed the structural prediction of the full-length plant transcript, and we dock it with the protein structure of EZH2. And from this in silico docking, we obtained the three best in silico models predicting various kind of interacting exons of plum with EZH2. And then we next design antisense oligonucleotides, and these are steric antisense oligonucleotides. So they are chemically modified with 2' MOE as well as locked nucleic acid kind of technology, so that when they bind to the plant transcript, they are stable, but they do not degrade the plant RNA, because they are not able to recruit the RNase machinery, but they in turn act as a steric hindrance to try to interfere with the binding of the RNA with other proteins, for example, the PRC2 complex or EZH2. So what we did was we treated our myeloma cancer cells with a panel of steric antisense oligonucleotides that were targeting each of the predicted exons that we have found for our in silico models, and we perform RNA immunoprecipitation assays. And here we see that amongst the steric ASOs that display the depletion of the interaction of EZH2 with plum, the ASO for guide 11 and 12, which target the exon 7 region of plum, results in the depletion or the reduction of EZH2 interaction with EED and SUG12, implying that this region of the plum transcript is important for the interaction between EZH2 and plum, as well as the formation of the PRC2 complex to reconstitute its catalytic activity, and this can be putatively abrogated with these steric ASOs targeting this interaction by binding to the plant transcript. So when we tested the efficacy of our steric ASO against the global FDA-approved global EZH2 inhibitor, tazemetostat, which works by a different kind of mechanism in that this molecule binds to the catalytic domain of EZH2 to interfere with its catalytic activity, whereas our steric ASOs bind to our RNA transcript to in turn interfere with the interaction of EZH2 with its other PRC2 core complex subunits, as well as the catalytic activity. So you might like to see that in both the native resistant myeloma cells as well as the acquired bortezomib resistant myeloma cancer cells, our steric ASOs show similar efficacy compared to the FDA-approved EZH2 inhibitor, tazemetostat. In terms of inhibiting the activity of EZH2, you can see that there's a depletion of the phospho-EZH2 along with the loss of the H3K27 trimethylation mark. And this is comparable. And when we treated our tumor xenograft models with this steric ASO guide 12, one of the guide 12 that targets the exon 7 of plum, and we treated these ASOs also with combination with the bortezomib treatment, which is one of the key drugs used in the VRD treatment regimen for the patient samples. We see that combinatorial steric ASO treatment with bortezomib can reduce the tumor growth and prolong survival in vivo, showing that this might be a potential therapeutic that can be further developed for combinatorial treatment in relapsed or chemo-resistant kind of myeloma patients that display aberrant NF-κB activity. So in our current model, we show that the PLUM, which stands for PRC2 associated long non-coding RNA regulating the UPR pathway in multiple myeloma, it is a P52 regulated oncogenic long non-coding RNA that is overexpressed in the NF-κB activated high-risk myeloma patient subtypes, as well as VRD resistant patients. And mechanistically, it interacts with the PRC2 complex through the disordered region of EZH2 to regulate its histone methyltransferase activity. And although I don't have time to show, we show that two of the novel target genes of the PLUM EZH2 complex is the phospho3 and the ZFP30, which plays a major role in modulating this UPR pathway to in turn activate the UPR pathway that drives chemo resistance. So we show that the PLUM-associated programs contribute to a sustained therapy-resistant malignant cell state, and targeting these PLUM-EZH2 interactions can be potentially exploited for the treatment of refractory cancers with aberrant EZH2 activity. And we are currently developing effective delivery systems to treat to try to deliver these ASOs into the bone marrow as well as other kind of cancer types. And this is currently what we are doing right now. So I would like to thank the members from my lab who have contributed to this study. Specifically, the first author was Kamalashi Decker. And you see here who was delivering her baby at the time during this the revision of this study. And the in silico prediction and in silico docking work was done by Akesh here. And John Michelle Carter is a bioinformatics specialist who has contributed to looking at the histone modification changes from the ChIP-seq as well as the gene expression changes. And I would like to thank my collaborators who have contributed to this study as well as my funding support. Thank you.
Thank you very much for that. Thank you very much for that excellent presentation and for highlighting such promising avenues in multiple myeloma research. Thank you, Dr. Lee.
Thank you.
Well, up next, we're very pleased to welcome El Hadji Dauda from Senegal, medical oncologist, medical doctor in the Department of Hematology and Cellular Therapy at Dalal Jam Hospital, who will be speaking about the evolution of multiple myeloma management, advances, and persistent gaps in Senegal. The floor is yours.
Thank you, Susanna. I don't know if my screen is clear and my voice also. Do you hear me?
Everything's fine, thank you.
Okay. I put it again in full screen. Well, thank you, Susanna. Thank you to the OncoDaily organizers. My name is El Hadji Dauda. I am a medical doctor specializing in hematology with an experience in both benign and malignant hematology disease. I also have experience in stem cell transplantation. I spent more than 1 year in 2023 and recently in 2025 at Pauli Calmet Institute in Marseille, where I gained hands-on experience in management of patients who underwent bone marrow transplantation, particularly in acute leukemia, myeloma, and some others hematology malignancies, even in benign disease such as sickle cell disease. And I'm working at Dalal Jamm Hospital in the Department of Hematology and Cellular Therapy, led by Professor Sain Boufal. I'm really honored to be here and to have the opportunity to share our experience regarding the management of multiple myeloma by highlighting the advances which have been made and the persistence gap in our setting. To begin, I would like to provide some epidemiological context. As you all know, multiple myeloma ranks 24th among the most common cancers worldwide, and it accounts for 1% of all cancers. It occupied also the second most common hematology malignancies after lymphoma. And in Senegal, according to Global Cancer Observatory, multiple myeloma ranks 23rd among all cancers in our country, which means that it is not a rare disease and should be taken seriously if we want to improve the outcomes. Significant advances have been made globally in both diagnosis and therapeutic landscape, which improved the survival of patients. And in terms of advances of treatment, we can cite, immunomodulatory drugs. There are antibodies, anti-CD3 stem cell transplantation, and also proteasomes inhibitor. And there are also newer drugs which can be used in relapse or refractory disease. We can cite also bispecific antibodies. We can also cite the chimeric antigen T cell receptor therapy. However, those advancements are predominantly available in developed countries. In our setting in Senegal, we face a lot of challenges, and the first one is a limited access to diagnosis tool. While we can perform a bone marrow transplantation, bone marrow aspiration, serum protein electrophoresis, and some blood counts, even flow cytometry, to assess prognosis, sometimes it could be difficult by perform cytogenetic or molecular analysis in routine. They are not available in public structure, and to perform those analyses, sometimes we require some private facilities, and they are too expensive to use it in our daily practice. The limited access to diagnosis tool, the restricted availability of modern therapy leads to delay diagnosis. As we will show it earlier, you can see that at presentation, patients have serious complication and advanced disease. With the restricted availability of modern therapy, the clinical outcomes is not so high. It's so poor, and it is a lot of challenges we face. But we are committed to provide our patients the best possible care, accompany them throughout their entire journey, even when they need, palliative care. We will now share some study. It is real life studies which was conducted in our context. And in this first slide, we can see the profile of multiple myeloma patients in Senegal. And this study conducted by the Professor Sain Boufal is an important study, which it was conducted over 11 years between 2005 to 2016. And this study describes the profile of multiple myeloma in our setting. One of the key findings of these studies is the main age at diagnosis. We can see that the patients suffering from multiple myeloma in our context are young, and the majority are less than 65 at diagnosis. And there are several factors which can explain this result compared to what we can see in the other studies conducted preferentially in Western studies. And the first explanation is the demographic data. Recently, with the demographic profile of Senegal, the main age of our population is 18. And this condition may explain why population or myeloma patients are so young compared to the other study. And the other explanation is the high level of pollution and exposure to toxic substances in our context. As we all know, this exposure may conduct to genetic abnormalities, mutation, which can lead to cancer and preference to multiple myeloma. And the third explanation is the difficulty patients have to meet healthcare facilities. In our setting, there are only two major hematology department and a fewer hematology units in internal medical department. And this situation may lead to underdiagnosis or misdiagnosis of multiple myeloma, particularly in elderly patients. And the other findings of this study is the severity of symptoms at initial diagnosis. As we can see that in this slide, patients describes burn in more than 95% and associated with deterioration in terms of conditioning, which means that they are seen in late stage of diagnosis. And also there are the burden of complications at diagnosis, which are not negligible. Here we can see the burden of infection occupied 23%, the pathological fracture, there are also cordon-spinal compression, and the burden of hypercalcemia, which means that patients at diagnosis present several complications, serious complications, and to improve that, we need to pause diagnosis earlier and avoid these complications. Recently, we have conducted a case control study in order to investigate why patients develop infection in their at diagnosis, the occurrence of infection in multiple myeloma in our setting. As we mentioned in the last slide, there are burden of infection at diagnosis. And to investigate that, the first finding of our study was to confirm what is previously described by the study conducted by Professor Sain Bufal is the main age of diagnosis, which means that patients, even in case and control groups, they are so young with an age at diagnosis nearly 50 years old. And the second important finding of our study was the delay in diagnosis. In both case and control groups, the median diagnosis delay was more than five months. And also, alongside this, we observe a high burden of comorbidity. By using the Charlson score comorbidities, we can see that the majority, even in cases and control groups, there are more than 3 comorbidities during the initial presentation. And this delay in seeking medical consultation contribute significantly to late disease. And what is tricky is that even in the study conducted by Professor Seinfeld and our more recent analyses, we show that stage 3, by using Salmonella disease, is the most frequent stage at diagnosis in Senegal. And as I mentioned earlier, we can't use our ISS in our context with the difficulties we face to perform cytogenetic and molecular analysis. But we are aware of the utility of the risk stratification to better understand our population and to give them the opportunity to have better outcomes. And in the same study, to investigate the risk factor of the occurrence of infection during this disease, we made 2 analyses. The first one is bivariate analysis. And in the bivariate analysis, what we can see, there are several factors which are associated with the occurrence of infection at diagnosis. And the first one is renal impairment. We can see here, and delay of consultation. There are the presence of comorbidity with Salson score comorbidity, and the late stage 3 at diagnosis by using Salmon criteria. And when we move to multivariate analysis, the most significant independent factors associated with infection was the presence of comorbidity. We can see it here, renal impairment, and the evidence of inflammatory biological markers as a factor which can explain the onset of infection at diagnosis. And those findings underline the complexity of patients at presentation in our setting and the need for earlier diagnosis and better risk stratification. To better understand the evolution which have been made in our setting, we compare two periods. The first period is a period of between 2005 to 2015, corresponding roughly to the period of the initial study. And the second period is the period between 2016 to 2025, reflecting more recent practices and improvement in terms of management of multiple myeloma. And this comparison allows us to observe the evolution of therapeutic strategy, therapeutic landscape. And what we can learn is during the first period, 2005 to 2015, treatment options were very limited. And the most commonly used regimen is what we used to call Alexania protocol, associated melphalan and prednisone, was the majority of therapeutic regimen. And we can see that the thalidomide regimen very small in the first period. And what we can also see in this graph is that there are a significant number of patients who remain untreated, representing here 30%, reflecting the major difficulty to access to therapeutic, to even to diagnosis tool and therapeutic strategy. And during the second period, 2016 to 2025, we observed a shift in treatment practices. And the most commonly used regimen during this period is the association of cyclophosphamide, thalidomide, and dexamethasone, representing 96% of our cohort. And we all know the standard therapeutic of multiple myeloma in first line is not CTD, but the reason why we use it predominantly in our context, in our setting, is that these molecules, these therapy are available in our context. The second one is IV cyclophosphamide and thalidomide are free of charge. And the third explanation is this regimen is widely used in low-income country, even in middle-income country. And also during this period, we can also, see that protocol using melphalan, prednisone, thalidomide, even inhibitor bortezomib regimen increased progressively, and the number of untreated patients decreased during the second period, which means there are a significant evolution in terms of therapeutic arsenal, therapeutic availability in our context. And in terms of outcomes, patients treated with melphalan prednisone protocol had poor survival with a high mortality rate. And with the CTD, which predominantly used in the second period, the patient treated with this protocol show improved survival, with the majority remaining alive during the follow-up. Here we can see that 60.5% patients in the are alive during the follow-up. And in terms of curve analysis, the survival analysis demonstrated a statistical improvement between the two periods, highlighting real progress in management of multiple myeloma in our setting. As the protocol CTD, cyclophosphamide, thalidomide, and dexamethasone occupied the most regimen protocol during the second period, we performed a retrospective study between 2018 to 2022 to study the outcomes in patients treated with the protocol CTD protocol. And what we can learn here is the overall remission was 65%, and we have only 22 of mortality. And here we can see the OS, overall survival, near 80%, and the progression-free survival was around 60% with the protocol CTD. And recently, we conducted also a study in myeloma field to evaluate, investigate the burden of renal impairment, a multicenter retrospective study from 2018 to 2024. This study was performed in hematology department and nephrology department in Dakar. And what we can learn in terms of therapeutic is that CTD is the most common regimen which are used in this population, and we all know with renal involvement, it's preferable to use inhibitor bortezomib based regimen. But due to the cost of these molecules, sometimes it's difficult to access in our context. And here also the burden of infection is a case control study. We can see in terms of outcomes that with multiple myeloma patient with infection, the death rate was 60%, where control group, the death rate was only 32% with highly statistically significant between these two patients. And this curve demonstrates the burden of infection in patients who suffer from multiple myeloma. And also in the study which evaluated the renal involvement in multiple myeloma, here we can see that renal impairment, comorbidities were also strongly associated with increased mortality and the reduced overall survival. And recently, also, we have established the first bone marrow transplantation program in our setting, which was a milestone, as we know. When we compare the two periods, we can see, let me please turn behind. And here we can see that during the first period, a stem cell transplantation was not performed. And the second period, only 5% patients underwent bone marrow transplantation. The establishment of this program in our setting is a milestone, as it helps patients to access to the better care, of treatment care. And what we can see, what we can learn in this article is we require the majority of requirement basing to the WBMT recommendation for hematology stem cell transplantation program in low resource setting. We meet the ideal and preferred requirement for initiating such activities, which has been done. However, certain essential facilities remain lacking, including cryobiology infrastructure, molecular diagnostic, as we mentioned it earlier, which is performed in private structure, nuclear imaging such as PET scan, and the quality assurance systems. As we know, in Senegal, patient paid totally, and also sustained government support and some technical and financial partnership will be necessary to ensure the program continuity. The perspective, we compare two periods, 2005 to 2050, and the second period 2016 to 2025. But we're looking ahead 2026 to 2035, and our goal for the next decade is clear. The first one is improve diagnosis capacity by integrating cytogenetic and molecular testing into routine practice in public hospital in order to better make a risk stratification at diagnosis. The second one is to improve access to first-line innovative therapy, bortezomib, lenalidomide, which are not available routinely in our context, and also to increase the number of patients eligible for autologous stem cell transplantation. And in terms of research, either is to strengthen international collaboration in order to perform some difficult analyses we face in our setting, and to facilitate access to new therapy and even include our patients on clinical trials. To reach these goals, we need the system of government support to ensure long-term government commitment to strengthen healthcare access and system capacity, even in terms of autologous stem cell transplantation, to enhance hematology specialties. As we mentioned earlier, there are only 2 major hematology departments in Dakar, in Senegal, and fewer hematology units throughout this country. And we need to enhance, to spread the specialties in all the country. The expand bone marrow transplant programs to increase the access to improve outcomes. As we all know, bone marrow, the stem cell transplantation is in front line in terms of therapeutic landscape in this disease, but is not performed totally in our context. And the last one is international partnership, as I mentioned it, to develop global collaborations, to share expertise in terms of resources and in terms and best practices. I'd like before to thank to the entire team at Dalaviam. As you can see it, they committed to give the best possible care to patients. Here they also too, which means that we perform 2 bone marrow transplantation, and the goal is to continue to perform and to spread it in the maximum of patients. I would like also to sincerely thank to the organizer of the Congress for this opportunity. Thank you very much for your attention.
Thank you very much for taking the time to join us and providing such valuable real-world insights on multiple myeloma management. Thank you very much for your insightful presentation. We now move on to our next keynote speaker, and we're very honored to welcome Samvet Bardakjian from Armenia. He's a medical oncologist at Hyoyan Hematology and Oncology Center, scientific director of IMONC, and adult oncologist at the clinic, and will be speaking on treatment and outcomes of multiple myeloma in Armenia.
Hello, my name is Samvet Bardakjian. I'm a medical oncologist. I'm working in Hyoyan Hematology and Oncology Center, and I'm scientific director of Immuno-Oncology Research Institute. Today, I'm going to present you our study data about treatment and outcomes of multiple myeloma in Armenia. We are going to speak the multiple myeloma clinical pathological characteristics, the survival data, and Cox regression analysis. Our study was conducted in Hyoyan Hematology and Oncology Center, and we collected data of multiple myeloma patients treated through January 2017 until December 2022. 265 patients were identified. From them, 247 multiple myeloma patients were included in the final analysis. Data analysis was performed by May 2024. Here you can see clinical pathological characteristics of our study population. As you can see, median age at diagnosis was 62. Almost half of patients were below age 16 at the time of diagnosis, and half was above 60. Male to female distribution was equal. Type of immunoglobulin, 22% of patients were identified to have immunoglobulin G as M protein. 9% of patients had immunoglobulin A, but for majority of patients, 63% of patients, the M protein was not identified, so the type of immunoglobulin was unknown. Type of light chains, again, for majority of patients, for 57% of patients, type of light chains were unknown. It was kappa light chains for 24% of patients, and for 19%, it was lambda light chains. Staging. Unfortunately, in our study population, staging was done using the old staging system, Juris-Salmon staging system. So by Juris-Salmon staging system, only one patient had Juris-Salmon stage 1 disease. 13% of patients had stage 2 disease, and 73% of patients had stage 3 disease. The newer staging system, this means ISS staging system or revised ISS staging system, which are now incorporated and newer staging systems and used worldwide. Unfortunately, this new staging system was not largely used in our study population. For majority of patients, for 67% of patients, ISS stage was unknown. For 7% of patients, this was stage 1. 10% of patients had stage 2, and 16% of patients had stage 3 ISS stage. But for majority, as I said, 2/3 of patients, this was unknown. This was mainly due to beta-2 microglobulin unavailability in our study population for most of patients. ECOG performance status, it was ECOG 1 for 8.5% of patients. For 50% of patients, it was ECOG 2. 29% of patients had ECOG 3 at time of diagnosis, and 8.5% of patients were ECOG 4. Percent of plasma cells in bone marrow was checked for majority of patients, or 80% of patients. 10% of patients had percentage of plasma cells in bone marrow less than 10%. For 55% of patients, it was something between 10 and 60%, and 14% of patients had more than 60% of plasma cells in bone marrow. For 20% of patients, the percentage of plasma cells was unknown or not checked in bone marrow. Unfortunately, in our study population, majority of patients who were diagnosed with multiple myeloma were not diagnosed using strict IMWG criteria. 68% of patients were diagnosed with multiple myeloma, which was not satisfying the all necessary diagnostic criteria of IMWG. This was mainly due to lack of clonality confirmation. All these patients, or probably all these patients, had multiple myeloma, but for 68% of patients, clonality was not checked by immunohistochemistry or flow cytometry. It was not confirmed. That's why these patients were not satisfying the strict criteria of IMWG for the diagnosis of multiple myeloma. Treatment. Unfortunately, 9% of patients didn't receive any treatment at all, and 90% of patients received systemic therapy. Unfortunately, for 57% of patients, response to first-line systemic therapy was not checked. As I mentioned before, M protein was not checked for majority of patients at the initial diagnosis, and it was not checked during treatment. Follow-up. At the time of data analysis, 36% of patients were still alive, while for 64% of patients were dead. Mean number of systemic therapy lines was 1.5. 54% of patients received only one line of systemic therapy. 26% of patients received 2 lines of systemic therapies, and 9% of patients received 3 lines of systemic therapies. In our study population, only few patients received more than 3 lines of systemic therapy. Autologous stem cell transplantation, which is a very important type of treatment for multiple myeloma, was incorporated only in 13% of patients, and 87% of patients didn't receive autologous stem cell transplantation during their course of treatment. This was mainly due to unavailability of autologous stem cell transplantation in Armenia until recent years. Autologous stem cell transplantation was started to be done in Armenia starting from 2017, but was largely incorporated in treatment strategies starting maybe from 2020. That's why majority of patients were not able to undergo this very important type of treatment for multiple myeloma. Maintenance therapy, which is again one of the most important treatment types for multiple myeloma. Unfortunately, only 1/3 of patients with multiple myeloma received any type of systemic therapy. 2/3 of patients didn't receive any type of systemic therapy at all, maintenance therapy at all. First-line systemic treatment. Mean number of first-line therapy cycles was 5. 74% of patients received first-line therapy with proteasome inhibitors. This means bortezomib or carfilzomib containing regimens. Only 4% received first-line therapy with IMiDs, lenalidomide or pomalidomide containing regimens. 8% received both of these agents, bortezomib, carfilzomib, and lenalidomide pomalidomide. And 14% of patients didn't receive any of these agents during first-line therapy. This means that they received treatment with all the agents, just standard chemotherapy with cyclophosphamide, doxorubicin, melphalan, and so on. Of the treated patients, 62% received less than 6 cycles of therapy during first-line treatment. Second-line systemic treatment. Mean number of second-line therapy cycles was 4. 48% of patients received second-line therapy with proteasome inhibitors containing regimens. 21% received second-line therapy with IMiDs containing regimens, and 21% of patients received both of these agents, IMiDs and prostaglandin inhibitors. 10% of patients didn't receive any of these agents during second-line therapy. Here you can see the overall survival of our study population. As you can see, median overall survival in our study population was just 32 months, which is much less if compared with developed countries, European developed countries, US, where in some studies, median overall survival is exceeding 10 years. But unfortunately, in our study population, median overall survival was less than 3 years. Here you can see overall survival by Jewish-Talmud stage. As you can see, patients who were diagnosed with stage 1 or 2 had much better overall survival, with median overall survival of 56 months versus 25 months for Jerusalem stage 3 patients, so 2 times better survival for stage 1 and 2 patients. Overall survival by ECOG status. As you can see, patients with ECOG status 1 or 2 at diagnosis had much better overall survival. Median overall survival was 14 months versus 21 months for patients who were diagnosed with ECOG 3 or 4. Overall survival by response to treatment. As I mentioned before, for majority of patients, response to treatment was not assessed or was assessed just clinically or using imaging techniques, but was not assessed using M protein. But for those patients for whom response was assessed, patients who achieved complete response or very good partial response had median overall survival of 60 months. This is the green curve. As you can see, it is much better than for those patients who achieved just partial response. This is the orange curve, for whom median overall survival was just 32 months. And for those patients who achieved only stable disease, this is the red curve, median overall survival was just 14 months. And for the study population who hadn't checked this M protein, this is the blue curve. You can see that this is in the middle. Survival by autologous stem cell transplantation. So the patients who received autologous stem cell transplantation during their course of treatment, this is the green curve, they achieved much better overall survival. Median overall survival was 16 months, which was 2 times better than for patients who had undergone autologous stem cell transplantation. They had median overall survival of just 31 months, so 2 times difference. Survival by maintenance therapy after first-line treatment. As you can see here, those patients who received any type of maintenance therapy after first-line systemic therapy, they had much better survival, median overall survival of 56 months, versus those who didn't receive any type of maintenance therapy, just 22 months of median overall survival. And this is statistically highly significant. You can see huge separation of curves. However, I have to mention here that immortal time bias was not taken into account for these calculations, but we think that this difference is mainly not to immortal time bias, but mainly unavailability of, as a very financially toxic, unaffordable drugs for the study population. Survival by first-line systemic therapy type. As you can see, those patients who received first-line systemic therapy with novel agents, this means proteasome inhibitors or IMiDs, they had much better overall survival. This is the green curve, and their median overall survival was 41 months, versus those patients who received systemic therapy with other agents, mainly older agents, just standard chemotherapy, something like that. They had median overall survival of just 26 months. This is the orange curve, versus patients who didn't receive any systemic therapy at all. For them, median overall survival was just 4 months. Survival by number of first-line systemic therapy cycles. As you can see from this slide, those patients who received 6 or more cycles of systemic therapy had much better survival of median survival 44 months, versus those who received less than 6 cycles of first-line systemic therapy. They had median overall survival of 27 months, and this is statistically significant. Here again, I have to mention that immortal time bias was not taken into account, so this may be one of the reasons of the difference, but we think that this is not the only reason. For survival after relapse by number of second-line systemic therapy cycles, as you can see here again, those patients who received second-line systemic therapy and received 6 or more cycles of second-line systemic therapy, they lived much longer, median overall survival of 22 months, versus those who received less than 6 cycles of second-line systemic therapy. For them, median OS was 14 months. And Cox regression analysis, you can see that the main variables in univariate and multivariate Cox regression analysis for survival were autologous stem cell transplantation. Those patients who received autologous stem cell transplantation lived 3 times longer, better, as I saw, and better overall survival than those who didn't receive autologous stem cell transplantation. First-line systemic therapy type. Those patients who received first-line systemic therapy using proteasome inhibitors or IMiDs, they had 2 times better overall survival than those who received other older agents. Number of first-line therapy cycles, 6 or more cycles of systemic therapy as first-line therapy, brought to 1.5 times better survival than less than 6 cycles of systemic therapy. Maintenance systemic therapy, this was one of the major variables impacting survival. Those patients who received any type of maintenance systemic therapy had 4 times better survival compared to those who hadn't. And in multivariate Cox regression analysis, you can see that autologous stem cell transplantation, number of first-line therapy cycles, and maintenance systemic therapy still remain statistically significant prognostic factors for overall survival. So our take-home messages. Unfortunately, in our study population, overall survival was much lower compared to high-income countries. Median overall survival was just 32 months. Serum and urine M protein ISS staging, diagnosed by IMWG criteria, mainly clonality, and response to treatment were not assessed in majority of our patients. The most critical determinants of survival were autologous stem cell transplantation, adequate first-line therapy with modern agents, proteasome inhibitors or IMiDs, and prolonged maintenance therapy. Thank you very much.
Hello everyone, and thank you for excellent presentation. Now I would like to introduce our next speaker from USA, Samer Al-Hadidi, Associate Professor in the Department of Internal Medicine at UT Southwestern Medical Center, who will be speaking about management of newly diagnosed multiple myeloma.
Hello, my name is Samer Al-Hadidi. I'm an associate professor at the University of Texas Southwestern Medical Center. I'm sorry I'm not being able to join you live today, but looking forward for this great meeting and OncoDaily Virtual Global Congress on multiple myeloma. Today, I'll be talking about management of newly diagnosed multiple myeloma, a topic that's keep changing with the progress that we made in this field. These are my disclosures. First, we'll start as a background. So, multiple myeloma treatments changed over the years. So back in the 1990s, we started using doublet therapies. After that, we started doing triplet therapies, and more recently, we did quadruplet therapies. And the idea was to add one more agent that could have been active in multiple myeloma and see if that will help in improving the outcomes of patients and with sort of minimal added toxicity, because whenever you add another drug, you worry about accumulated toxicity. So with that being said, the most recent way of treating multiple myeloma is to use quadruplet-based therapy, which means using 4 different drugs that target myeloma from different angles. And the idea is to try to deepen the response for patients with myeloma. The more we get rid of those cancer cells, the better outcomes we expect to patients. And initially, we thought, getting rid of the myeloma protein is all what we need to do. But with better understanding of and better technology to sort of measure cancer activity, we now have different ways to see if the patient has cancer cells at a very low level that cannot be seen by the eye. And this is the minimal residual disease testing that nowadays we're able to do for patients to confirm that they don't have any remaining cancer cells. And all of those are metrics or ways to confirm that the patient response is quite deep. And in case that we need to change therapies or improve the patient outcome, those are metrics we can rely on in comparing different clinical trials. So overall, the thought process of multiple myeloma was based on transplant eligibility. So whenever we see patients who are newly diagnosed, we think about them as either fit to go for transplant or not fit to go for transplant. But this concept of transplant eligibility is quite not clearly defined. So I'll talk about it in more details in the coming few slides. But the idea is if you have somebody who's transplant ineligible, is to try to give them treatments until disease progression, and they could have been for many years. When it comes to transplant-eligible patients, the treatment has multiple kind of sections, starting with induction therapy, followed by consolidation therapy with the high-dose chemotherapy and autologous stem cell transplantation, followed by extended or maintenance therapy. But we need also to realize that the outcomes of patients got much better with the outcome, with the developments that we have in the field. So, looking at long-term data from University of Arkansas as, example, there is approximately 1 out of 3 patients who are, disease-free living as long as they will live without myeloma, and they're off therapy. So we're estimating that there is roughly a third of patients with standard risk myeloma who could have been cured from this disease. And we're expecting with the current regimens that we have is that those numbers will likely be better. For example, with a quadruplet-based therapy, the sustained MRD negativities exceed 40%, which is really quite promising. But we're having some problems now, which is good problems to have, is the fact that the duration of therapy is way longer than it should for many patients. And we need to try to balance between this continuous therapy as well as the toxicity burden, as well as the financial toxicity that some patients and institutions, as well as countries, may encounter. So nowadays we're thinking about treatments for duration, and that could have been based on sustained complete response, or more importantly now, sustained MRD negativity, and hopefully discontinuation of treatment. So our goal in the future is to improve the fraction of cure, but also trying to do fixed duration treatment, which is actually a very critical part of cure definition. And that brings me to this word, cure. And for a long period of time, the myeloma field thought that this is not possible to call myeloma as a curable malignancy. But in February of 2026, we met in the International Myeloma Society and discussed the good outcomes that have been seen all over the world with this disease. And the definition of cure is quite stringent in a way that to call somebody cured, you need to come up with all of those criteria to ensure that this is real. And one of it has to be based on being off therapy. So we propose that patients could have been cured if either they have a newly diagnosed myeloma or even relapsed myeloma. So the diagnosis, as well as the stage of disease is not very important when it comes to cure. But what we need them to have is sustained complete response with the criteria and the best evidence as well as tools that's available to you as a clinician. And with MRD negativity 10 to the minus 6, which is sort of the best sensitivity that we have now commercially available to judge into the depth of the response. And want those patients to have sustained MRD negativity for at least 5 years without therapy, regardless of them treatment duration that they encountered before stopping therapy. 4 out of for the 5 years to have those MRD assessments, which require bone marrow biopsy, as well as advanced imaging showing no active disease. That includes either a PET CT scan or an MRI study, starting when the patient stopped therapy and continue for 5 years. So quite stringent sort of definition of cure, quite important, because the idea is once we define cure, we now change our impression and how the way we treat patients to fixed duration therapy, which is quite exciting. So if you look at the NCCN guidelines, nowadays quadruplet regimens are the current standard of care. And this is, a snapshot of the NCCN guidelines looking at patients who are either transplant eligible or transplant ineligible. And you can see that the preferred regimens for transplant eligible for patients are centered about quad therapy, and that include an anti-CD38 antibody, either daratumumab or isatuximab, along with lenalidomide, bortezomib, and dexamethasone. And that, carries a category 1 recommendation for transplant eligible patients. Now, for transplant ineligible patients, you could have seen that we still have a triplet regimen as an option. And I'll discuss that with you in more details, which is based on the Maya study, daratumumab, lenalidomide, dexamethasone. Given the really good outcomes we've seen with this study and the long-term outcomes we encountered for patients who are followed for a long period of time, but as well as the fact that quadruplet-based regimens similar to transplant-eligible patients are being now labeled as category 1. And this is because of the phase 3 studies that we have showing, a superiority of those quadruplet-based regimens with, minimal added toxicity for the most part for those patients. But, some warnings, those patients were all less than 80 years old. And so to keep that in mind, we have limited data on patients who are more than 80 years old when it comes to quadruplet-based regimens in a randomized fashion. So quadruplet-based regimens are the current standard of care nowadays, and they have been listed on the NCCN guidelines. So we're doing more and more of it for patients regardless of transplant eligibility. And this idea of transplant eligible versus quad eligible is quite important. Now, what's a transplant eligible patient? And you could have, assumed that this is a well-defined sort of phenomena, which is not. This is a very really well-done study. It looked at randomized control studies that included transplant eligible patients, and they tried to look into what it was called as transplant eligible and what was not called as transplant eligible. And it's interesting that this definition was all over the place. For the most part, it was based on age and comorbidities, but there was no consistency in those definitions. So when it comes to this, it's not clear how we can call a patient transplant eligible or non-eligible when it comes to studies. That makes this kind of, setting the difference is very, very difficult. But nowadays, with the newer guidelines that we're trying to implement, we're trying to come up with what we call if patients eligible for quadruplet-based regimen or not. Because if the patient is eligible for a quadruplet-based regimen, regardless of transplant eligibility, they should go for it. Because we have now randomized studies showing the improvement of, outcomes when it comes to quadruplet-based regimens. And here I show you the ASCO recent living guidelines that, included this quadruplet therapy eligibility as part of the judgment criteria on what to do for those patients. And the other complexity to this is that in real-world practice, the majority of the newly diagnosed myeloma patients are transplant non-eligible or they do not receive transplant. Now, believe it or not, even with this transplant being around for a very long period of time, many patients who qualify to get the transplant don't get it. And this is because of many reasons, including, access to care, as well as patient preference, as well as, the complexities that could have happened with the transplant for some patients who may live far away from the transplant center. So this is a really nice study that was done looking at electronic health records from 2011 to 2020 for more than 6,000 patients. And if you see there, for transplant non-eligible patients, they were considered to be at least 50% of those patients or more. And when it comes to transplant eligible patients, only of those 25% of patients receive the transplant. So that tells you a lot that even when you call somebody as a transplant eligible, they may not necessarily receive a transplantation. And that's quite important to keep in mind. So what we do in myeloma has to do with what we learned about treating myeloma over the years. So one drug doesn't do the job, and we try to do combination-based therapies. And for that setting, we try to use those 4 drugs you could have seen there, which is immunomodulatory drugs. We started with thalidomide, more recently what use lenalidomide as upfront therapy, proteasome inhibitors with either bortezomib or carfilzomib, and a monoclonal antibody targeting CD38 with daratumumab or isatuximab, as well as corticosteroids with dexamethasone being the most commonly used one in the United States. And the reason why we use this combination-based therapy is that those drugs work a little different. So when it comes to immunomodulatory drugs, they're well known to modify the immune response, specifically working through the cereblon-dependent mechanisms and resulting in apoptosis of cancer cells. The proteasome inhibitor, work on the proteasome pathway, which cause accumulation of this misfolded proteins, leading to this cellular stress and apoptosis of the myeloma cells. So the kind of different ways of killing the cancer cells. This anti-CD38 antibodies as an antibody drug that result in either direct and indirect ways of apoptosis by immune-mediated killing, which is another important way of treating myeloma. And even corticosteroids, which is an anti-inflammatory sort of agents and could have been suppressing the immune system, directly resulting in apoptosis of those myeloma cells. So more than one drug is what we need to treat myeloma. But this concept of quad-based therapy with multiple drugs is not new. Actually, if you look into the data, the first approved quad-based therapy is something we never use in the United States, which has to do with oral melphalan, which we don't use that here. But nowadays we got it right in a way that we choose in the 4 drugs that we think that they're the safest when you combine together, as well as they're the most efficacious. So this is a table of the approved quadruplet-based regimens in the United States by the FDA. And, they're labeled with different colors for a little bit of a reason there. But the idea is for transplant eligible or non-eligible patients, we have quite good number of those approvals with either daratumumab, lenalidomide, bortezomib, dexamethasone, or isatuximab, bortezomib, lenalidomide, dexamethasone, which is approved mainly for transplant non-eligible patients. And with the yellow part of the table looks into the DARA VTD or thalidomide combination bortezomib and dexamethasone, and this is approved before, for example, the daratumumab, lenalidomide, bortezomib, dexamethasone, but it was used less often in the United States because we use less thalidomide here. But if you look at the red part of the table, it's the oldest quadruplet-based regimen that was approved back in 2018. And as I told you, we never used that regimen, which include melphalan on top of daratumumab, bortezomib, and prednisone. And the reason why is the toxicity of the oral melphalan, which was approved for transplant non-eligible patients. And we really routinely don't use this in the US. So quite important to see that those agents are being approved, and the most recent approval is actually this year, 2026, where DARA VRD was approved for transplant ineligible or transplant deferred patients. So let's talk about transplant eligible patients. And on the first study, that is a randomized controlled study showing that the quad-based therapies with the immunomodulatory drug is superior to triplet-based therapy was the Cassiopeia study. And this study was done in Europe, looking into the addition of daratumumab on top of the bortezomib, thalidomide, dexamethasone. And you can see that the addition of daratumumab resulted in improvement, of overall response rates, as well as, progression-free survival, as well as overall survival. And you could see that this study has multiple, times where it was followed, short follow-up. That some of those metrics don't read out very well, and then some of those longer follow-ups where you could see some improvement of those, survival outcomes. So the Kaplan-Meier curve is seeing that, the quadruplet is better, certainly when it comes to progression-free survival, as well as in case of, overall survival. And the median follow-up is quite good, which is close to 7 years. But the longer we follow up those patients, the better we understand on how they do. Now, this actually, other metrics you could see there has to do with MRD, negativity, 10 to the minus 5 and 10 to the minus 6. And you could see that level of, depth of response is much better with a quadruplet-based regimen. Now, if you look at the most, a common study that we cite when we actually treat patients here in the United States is the Perseus study, and that looks into daratumumab, lenalidomide, bortezomib, dexamethasone compared to, lenalidomide, bortezomib, dexamethasone, and DARA VRD versus VRD, and you can see the improvement of progression-free survival, which was the primary endpoint of the study with the use of quadruplet-based regimen. And if you look at that at 4 years, you can see that with a quad-based therapy, almost 85% of patients are progression-free and alive, compared to roughly 2/3 of patients on the triplet arm. And that resulted in a significant hazard ratio difference for this, as well as deeper responses. So if you look at the MRD negativity 10 to the minus 5, almost 3/4 of patients in the quad therapy actually achieved this metrics compared to around 50% of patients on the triplet regimen. What we care more about now, talking about cure, is the sustained MRD negativity, which is much better when it comes to the use of quadruplet-based regimen, with more than 50% of patients having sustained MRD negativity for at least 2 years with this quadruplet-based regimen, which is quite, reassuring and really good to see with those agents. Now, if you look at the other antibody, which is isatuximab, the GMMG-HD7, is a study that looked into isatuximab VRD compared to a VRD. And again, the same story kind of tells itself, the better progression-free survival at 3 years here with a shorter follow-up, as well as, a significant hazard ratio in case of progression-free survival, as well as, MRD negativity. So MRD negativity was also measured post-induction, and was better with a quadruplet-based regimen. Post-transplant was better, and even continued this MRD negativity post-induction and post-transplantation continued to be better with a quad. So with all of those, what we're trying to say that those studies showed that the efficacy of a quadruplet-based regimen was certainly better than triplet-based regimen, specifically when you add a drug like anti-CD38 antibody. So this is a summary for you on those different studies as well as the different regimens used as well as the outcomes. And a few things I want to highlight for you there. One thing is the fact that patients were relatively younger because those are transplant eligible study, and you can see the median range is in 58 to the early 60s, and you can see almost always better CRs, better BFS, and better MRD negativity with all of those quadruplet-based regimens. Now, one other thing I want to also look into is the difference in serious adverse events. And you could really see that with the use of quadruplet-based regimens, there was minimal increment of the serious adverse events for the most part, because the anti-CD38 antibody, we think about it as a safe option to add in myeloma. Now, the stem cell collection is the one thing I want to also highlight is there is some decrement in the amount of stem cell yield when you use a quad. And so you're going to be careful on when to harvest those stem cells and not to delay that for longer. And you could have seen that the amount of stem cells were relatively lower in case of quad, and the success rate was relatively similar between both of them. And all, we as a transplanter, we have multiple ways of harvesting stem cells. We got better with those technologies nowadays. So if you look a little bit more expanded onto those quadruplet-based regimen, here I added some of the studies that did not result into an actual approval by the FDA, including some important studies like the MASTER study, the ISKIA study, ADVANCE study. Those looked at different sort of, backbone regimens, some of them including the carfilzomib instead of the bortezomib, and the same story repeats itself, that you have better progression-free survival, you have better MRD negativity as well as depth of response. So the use of quads quite important in newly diagnosed myeloma patients nowadays. So there are some questions that we still have in the field. First of all, CAR T, which you will hear about more in the relapse refractory setting where it's approved. Does that technology will replace autologous stem cell transplant? Now, a few things you need to keep in mind. Even with stem cell transplant being around for a long period of time, we still don't do it much as we should when it comes to transplantation. But there was a really good study called CAR-T6 study that completed enrollment, and we're waiting the results here. And that looked into the question if cell-to-cell, in this case, is better than transplantation. And this study, as I say, the completed enrollment, we're waiting for the results of it, not only for efficacy, but also more importantly, into the long-term adverse events and side effects that some of us are worried about with either technology. The other thing is, with all those better sort of outcomes with quadruplet-based regimens, should we really increase the maintenance? Should we do maintenance on everybody to start with, or should we base that on some sort of other metrics? And this is a study that looked into patients who did not receive upfront daratumumab, but looked into daratumumab lenalidomide maintenance compared to lenalidomide single agent maintenance, and it showed that the use of doublet maintenance was better than a single agent maintenance, specifically for in this setting where patients did not receive an upfront anti-CD38. And you could have seen that the progression-free survival favored that combination. Now, the good news is that the study with this cetuximab VRd will tell us if this maintenance with an anti-CD38 plus lenalidomide will be the strategy moving forward, because there was a second randomization at that setting. But without that, we cannot tell for sure if doing this will be sort of a standard for all patients. But if you think about it in a different way, the Perseus study was done as a package, including the quadruplet-based regimen, the transplantation, as well as the consolidation, followed by daratumumab lenalidomide. So if you think about it that way, then this package is what resulted in actually good outcomes, and you may follow how the study was done. But the good thing also that the fact that when you do those daratumumab lenalidomide, you don't really need to keep these patients going forever, and there are some stopping rules in the study after some certain amount of time that you can drop the daratumumab, which is important. And I think this is one of the most important questions to my mind is, should we even need this indefinite maintenance therapy? And this is a very, changing point we have in the myeloma field now, hopefully with having the cure definition. But the idea is we base this on way old studies when we said, lenalidomide is the standard of care for maintenance therapy. But if you look now backward and see the meta-analysis that was published back in Journal of Clinical Oncology at that time, most patients who benefited from lenalidomide maintenance were those who got suboptimal response to induction. So those patients who did not really achieve a good CR, those are the one who benefited. And the idea is for those patients who don't get the deep responses, doing more is better. And you could argue even if you add something on top of lenalidomide, maybe that's even better. But also looking at long-term data, like from the Arkansas, which we know published on over the years, doing a finite duration therapy was associated with really excellent long-term outcomes. And this is more of a patient-friendly sort of way. And now we have better tools that could have been more efficacious as well as safer to use. So that could have been even better. So nowadays we're really excited that many myeloma studies are studying MRD as a way of stopping treatments. So hopefully with the future, we will not be seeing this treatment until progression anymore, and we get to move from these concepts. But one caveat to this, for high-risk disease, you're going to be a little careful. For high-risk disease, we need longer therapy as well as multiple line sort of combination of therapies to get what where we want to get. Because the idea of the high-risk disease, you still can get deep responses, but you lose those responses quickly. So you need to think about myeloma as in a different way, that there are some patients who may require longer treatment as well as more intense treatment. Now, switching gear to transplant-ineligible patients, one of the initial studies that resulted in the first approval for a quad is the EMERALD study, which looks into isatuximab VRD compared to VRD. It's quite really good, well-done study, looked at patients up to 80 years old. So none of those were higher than 80 years old. And you could have seen that progression-free survival was quite, better with the quad-based therapy. At the 60 months, 63% of patients are progression-free and alive compared to 45%. CR or better was better. The median progression-free survival was not reached in the quad-based regimen, and the MRD negativity 10 to the -5, as well as sustained MRD negativity, both of those were better with the use of quadruplet-based regimen. The CFIA study is the daratumumab VRD compared to VRD, but this study included patients who got deferred transplant as a strategy on top of patients who transplant non-eligible. So also was including patients only less than 80 years old, and again, the story repeats itself. Quad is better across the line, transplant eligible and non-eligible patients, deeper responses, better median progression-free survival, better MRD negativity, as well as sustained MRD negativity. So when it comes to quadruplet and triplet regimens, this is actually 3 of the quad versus triplet studies that's being done in this patient population. The third one, which we did not talk about in more details, is the benefit study, which actually looked into the addition of the bortezomib portion, which is the proteasome inhibitor, on top of a backbone of anti-CD38. The idea of all those studies showing you that the quad-based therapy is better than the triplet-based therapy when it comes to better responses like CR, PFS, MRD negativity, as well as sustained MRD negativity. But a few things to keep in mind there. The ECOG status, all of those patients were really either 0 to 1. Very minimal number were 2, but certainly did not include frail patients as the way we want them to include. The other thing is the age. If you see the median age and try to compare it with the transplant-eligible patients, the MRD, the age here is a little older, with the median age in the early 70, which is good to see the evidence of quad-based therapy on older patients in general. So when we talk about the CD38 quad used in transplant eligible, this is a way of actually improving the outcomes for this specific patient population, specifically that we cannot do stem cell transplantation on. And you see this nice sort of summary figure, including the transplant ineligible patient, that when we use the quad, we're improving the PFS for those patients. And we're trying even to aim for those to be as good as the transplant eligible patients, which is quite amazing. Back when we used to use the triplet-based regimens without the transplantation, we got a little bit problems with lower progression-free survival for transplant non-eligible patients. And hopefully this will kind of close the gap between those two patient populations, which, has to do with their age and comorbidities. But we should not forget about triplet-based therapy in this scenario. And this is a really well-done study called the Maya study, which we have a really long follow-up for it. And it included patients above 80 years old. So, I mean, this is the table here, if you can look. There is patients who are 75 or older. Roughly 43 to 44% of those patients in that study were that old, which is more than 75 years old. And we have roughly 17% of patients with the ECOG of 2, which is quite good to see. So this is more older, more frail patients. You can see doing the triplet for those patients specifically resulted in improved progression-free survival. We look at the 60 months time point. More than 50% of patients are still progression-free in the triplet-based arm compared to roughly around a third of patients in the doublet arm. And the overall survival also was better when it comes to the triplet compared to the quadruplet-based therapy. So the triplet versus the doublet therapy. So the idea is triplet and quadruplet for patients who are transplant non-eligible should be personalized, because some patients may do well only with a triplet-based therapy, specifically those with comorbidities and specifically patients who are older than 80 years old. So that's quite important to keep in mind. So, we don't have really a study as of yet comparing DERA-RD versus VRD. There's VRD, VRD Lite. There are different ways of dosing VRD. But there was actually real-world sort of data suggesting that the use of anti-CD38 with lenalidomide dexamethasone may be better than bortezomib. And the idea with older patients, they may have higher chances of getting in trouble with bortezomib, including peripheral neuropathy and other side effects that you worry about with this sort of regimen. So with this real-world sort of data and analysis, it seems that DERA-RD may be better than VRD. There's currently a SWAG study that is looking into this question for transplant ineligible as well as frail patient to see if DERA-RD is better than VRD. But most of us in the community believe that the anti-CD38 is the safer sort of drug to combine when it comes to those triplet-based regimens. So just keep that in mind. Using VRD in transplant non-eligible patient is not wrong, but you're going to be worried about, neuropathy specifically and comorbidities related to the use of some of those agents. So back to the ASCO guidelines, living guidelines, which we really, worked on to make it hopefully updated based onto the evidence that comes by, is the fact that, excuse me. So that guidelines, the fact is for patients who are transplant eligible or transplant non-eligible, we do suggest if they're able to get a quad to proceed with a quad, because that seems to be, the way to go for those patients. One thing I want to highlight for you is the fact that we're using, maintenance therapies based on the package, which is the Perseus study with daratumumab and lenalidomide. But there were very minimal studies that looked into the question of maintenance, if doing more than one agent is better than doing only one agent. You can see this summarized here in table 5 in that publication, and specifically has to do with the addition of carfilzomib on top of lenalidomide. And you can see with the addition of those extra agents, you get better outcomes when it comes to progression-free survival. And I think all in all, what we need to focus on is the fact that in the future, what we need to do is to make sure that we treat to a certain metric, and hopefully we don't really keep patients on those extended therapy or maintenance therapy for forever. So this is some sort of a decision framework I came up with, presented first in ASCO, a year ago. But the idea is when you decide into the treatment, first, you need to have some sort of comprehensive patient assessment. If the patient age is important, special consideration for those above 80 years old. Frailty assessment is quite important. There are multiple frailty assessment tools that you could have used. Comorbidity assessments are important. Quality of life goals. Some patients have different goals than others, so are all important, aspects, including the social support that the patients get. And then transplant eligibility assessment should be done accordingly. And for all transplant eligible, I think, quadruplet-based therapy is the standard of care for patients who are transplant eligible. And likely, when it comes to transplant non-eligible, we try to use them in most patients, but there's some personalization factor that plays a role. And why do we use that? Because quadruplet-based therapies improve PFS, better MRD negativity, and potential for deeper responses, and hopefully stopping treatment in the future. And the other thing we need to keep in mind is the outliers risk of those quad-based therapies, including infection risk. So you're going to be careful specifically when you start treatments, as well as peripheral neuropathy. And after all, it's all personalized in a way that what matters to patients is what matters most for us is to follow those kind of goals that the patients set for us. So in conclusion, a quadruplet-based regimens show superior efficacy compared to triplet-based regimens should be done for transplant-eligible and non-eligible patients in most part because of improved outcomes. Personalization of treatment by fitness is what's important. Age is only a number, and transplant eligibility is not a one-time done process. It could have been changing according to how the patient is doing. So I do recommend the quadruplet-based regimens for all transplant-eligible patients and for most transplant non-eligible patients, and that's based on frailty assessment. Monitoring safety is important, being careful about infection, increased risk of cytopenias, as well as higher treatment-related mortality that's reported specifically in the EMERALD study for patients who got the quadruplet-based regimen. And the idea of all of that is the fact that for those patients, you're going to be a little worried about the dosing of treatment. So for many of them, you don't really start with a full speed. For example, for older patients, we sometimes use lower doses of lenalidomide to start with, lower doses of dexamethasone, those modifications for the proteasome inhibitors. Those all things are very, very important. So thank you for the attention. Hopefully you'll find this a congress of benefit for you with the other speakers as well as the other talks. We're really excited to see the progress that we have done in myeloma over the field of the years. And this is my email for if you have any questions. You're welcome to send me that. And you enjoy your day. Thank you.
I want to say thanks Samar Al Hadidi for a really good presentation. And moving on, I would like to introduce our next speaker from China, Xiaolong Feng, a professor of physiology, K Laboratory of Cell Proliferation and Regulation Biology, Ministry of Education, Beijing Normal University. Speed topic, plasma cell development based prediction of prognosis and treatment response in individual multiple myeloma.
Oh, sorry, something. Can you see me? Can you see me? Sorry. There's some trouble here. Just the first time using it. Entire screen. It's on. Oh my God, something wrong here. Just please, Jingjing, please. Can you help? Just I have some trouble here. Can you listen? Can you hear me? Just if you see, just sit here. Can you see me? Why it should be like that in open entire screen? Sorry. 我已经 open 了，就是，但是这个不行了。
这个是腾讯还是？
然后 Google something Google Can you see that? Can you see my PPT? Shit.
应该可以，好像
Aha.
设上。
Okay, now I can start. So I can start here. So we thank the organizer for inviting us to present our project. So our project, we're developing plasma cell development-based prediction model of prognosis and treatment response in individual patients with multiple myeloma. And I'm from School of Life Sciences at the Beijing Normal University here in China. And our goal is to develop individualized risk stratification, individualized prediction of treatment response. And if we can achieve these two goals, and we think that the patient will not be overtreated, and patient will be treated only with the drugs they do respond to. I will use bortezomib-based treatment as an example to explain why this is important. Bortezomib is a WHO essential medicine, which is a part of standard therapy to all myeloma patients. However, early trial data shows that not all patients benefit from bortezomib treatment. This EPIC trial data shows that only 38% of the patients will benefit from bortezomib treatment. In this trial performed in Holland and Germany, the Holland 65 and GMMG 84 trial, it said that about 70% of the patient do not see benefit because we don't have a method to identify or discriminate the patients who will benefit or will not benefit from bortezomib treatment. And we give this treatment to all patients. So the data looks like this. The real data looks like this in this trial. This is the Holland 65 trial. So the patients were randomly assigned into the traditional VAD arm, which does not contain bortezomib, and the PAD arm, where the treatment contains bortezomib. And you can see the results. The benefit to bortezomib-based treatment is only seen in progression-free survival, not seen in overall survival. Sorry, how could? So we want to develop a different approach. So our expertise is in developmental biology and also in big data transcriptome analysis. We want to use our expertise to develop a new classification scheme, which is a plasma cell development-based myeloma classification scheme. We think that if we achieve this, we will define myeloma according to etiology. So subtype A will be driven by etiology A, subtype B will be driven by etiology B. Therefore, each subtype have their specific subtype-specific response to the treatment of the same drug. So how can we, this is our hypothesis, how could we get there? And we first form additional hypothesis that we think that myeloma does not originate from later stage of B-cell development, also not originate from terminally differentiated plasma cells. Instead, myeloma originate from a germinal center formation. So here that anti-activated B cells will expand, will differentiate in germinal center, which will undergo two kinds of process: somatic hypermutation and class switch. And eventually, so memory B cells and plasma cells will be generated. And we need a way to identify, to develop new biomarkers. So we hypothesize that the gene networks conserved between plasma cell development and myeloma pathogenesis will enable myeloma classification. So how could we develop such biomarker? So we use a computational screening for gene network in myeloma transcriptome. So you can see this slide. On the left, we have the regulators of germinal center development. On the right, we have the transcript data of different data sets. So we use these regulators as seed genes and do co-expression analysis in the myeloma transcriptome. We aim to identify which of the regulators can form gene co-expression network. And we also then identify to assess which of the gene co-expression network will enable myeloma classification. So to this end, we found that only MCL1 co-expression model, we name it MCL1M, enables myeloma classification. So these are the content of this members of MCL1M. About 40% of the MCL1M members are located in 1Q, which is frequently amplified in myeloma genome, and which also show gene dosage-dependent expression here. And the members of the MCL1M are crucial for both plasma cell development and also myeloma pathogenesis. Just a few examples here. MCL1, of course, interleukin-6 receptor, and XA2, which regulates osteoclast function, and NP32 and H3F35, which regulates chromatin structural modeling. And so to develop a clustering scheme, we also identified another set of genes which is negatively or inversely correlate to MCL1. And this set of gene is represented by Tor-like receptor 10. So we call it Tor-like receptor 10 model. So here you can see, with this, you can see the myeloma samples can be easily and clearly classified into two subsets, either with MCL1M high expression or with Tor-like receptor 10M high expression. So this is the clustering data at the population level. So we ask the question, how can we turn this population level clustering approach into a diagnostic tool? We did the following. So we use 3 steps. So unsupervised clustering, as you see in the previous slides, and so each sample will be assigned into a subtype, and then based on this, we developed support vector machine algorithm. So here each dot is one individual sample in this step, and this step allows us to define a boundary which defines the one subtype from another subtype. The distance from each sample in this space to the classification boundary reflects the extent of this classified gene. So we use this. We take advantage of this distance. We call this distance as myeloma classification score, MCS. So these 2 steps, unsupervised clustering and support vector machine step, both work at the population level, and we use this MCS and the expression of these 2 sets of genes to develop an regression model. And here, by importing each sample's gene expression, the expression of the classified genes, we will get the myeloma classification score. And this is the final stage we reach. So we can use the RNA-seq data from individual samples to calculate the myeloma classification score. And then we use the myeloma classification score to predict prognosis, treatment response. So how can we get there? We define high risk, low risk, medium risk groups based on the extent of expression between MC1M and toll-like receptor 10M. If a sample has a significant higher MC1M expression, which will be defined in our case, which will define as high risk, and if the sample has a high toll-like receptor 10 expression, this will be defined as low risk. The remaining will be defined as medium risk. So you can see that this risk stratification scheme is applicable for newly diagnosed patients. These are data from two trial data, the TT3 trial and the Hoven 6 MMG-HD4 trial. You can see that the same trend. So both for PFS and OS. And we can see that this MCS-based risk stratification is also applicable in relapsed patients. I'm sorry. So these are the APEX trial and TT6 trial. So again, high risk, the same trend, though the exact data is different, but the trend is the same. And also in the real world cohort, here to the left, you will see the data from a cohort. From a cohort in Beijing. To the right, we can see the cohort from MMIF, both for the subset with stem cell transplantation or without stem cell transplantation. The trend is the same. So the MCS-based risk stratification is applicable to transplant eligible and transplant non-eligible patients. We can see that this strategy allows us to identify ultra high risk newly diagnosed MM. These are from patients they're not eligible for stem cell transplantation, but have really low MCS value. So you see this patient has a 3-year survival below 40%. So this patient has a real high, ultra high risk patients, and the difference between this the patients with transplantation or without transplantation is in age, not because they have different MCS value. So you see high risk, medium risk, low risk, high risk, medium risk, low risk. They have difference in age. And the high risk MM harbor unstable genome. You can see that the mutation burden, loss of heterozygosity event, and a marker of genomic instability, CDC20M, they're all high in the high risk, in the high risk subset. And this MCS values are independent of the risk-associated genomic alterations. You can see the high risk, medium risk, and the low risk. And here we can see all the risk-associated genomic alterations. If we compare high risk with medium risk with a low risk, we will see these risk groups are not specifically associated with any of these genomic alterations. And further, we can see that the MCS is independent of the other biomarkers. Here are the gene expression signatures which are used which are frequently used in other studies, we see very few overlap or no overlap. And compared with RIS2 system, so we can see that in the RIS1 and RIS2 stage, so you can see that the MCL1M myeloma patients have much worse prognosis compared with Toll-like receptor 10M myeloma patients. And we can see that the MCS-based risk stratification outperforms genomic alterations. So the patients are identified according to genomic alterations and also according to the subtypes newly defined by the MMRF consortium. You can see in each of this category. So our strategy further refines patients into high risk or low risk patients. And we can see that that our classification scheme enables discrimination or identification patients who will benefit from bortezomib treatment or patients who will not benefit from bortezomib treatment. And the data looks like this. So here you see this is the Hoven 65 data. So the PAD is the regime contains the bortezomib, and you will see like that. So you see only in MC1M high patients the PFS OS will be improved following PAD treatment, and the OS was improved from 36 months to 69 months, and the hazard ratio was about 0.6, and in the patients with Toll-like receptor M high myeloma, there's no benefit, no effect from bortezomib-based PAD treatment. So for this patient, for this subset of patient, bortezomib-based treatment is over-treatment or unnecessary treatment. The same is true for the relapsed patient. Here is the data from APEX trial. You can see that only in patients with MCM high myeloma, you will see a benefit from bortezomib-based treatment, and in the Toll-like receptor 10 high myeloma, we will not see a benefit from bortezomib-based treatment. And also we see that the benefit was restricted to the patients with a poor survival. And here this data is from Hoven 65 trial, and you can see if the I'm sorry, I can't move this one. If the MCS value is above -1.3, the PAD treatment will not show any improvement in the survival. For the patients with low MCS, so they have poor prognosis, so the effect of the PAD treatment will be stronger. So the effect of this is because the high risk myeloma have higher activities of unfolded protein response. Therefore, this subset of myeloma will benefit from bortezomib-based treatment, and in the low risk myeloma, the unfolded protein response is low, is weak. So therefore, they do not respond to bortezomib-based treatment. So we next asked question whether dynamics in MCS predicts disease state. Here we define dynamic like this. So we use delta MCS, which is the value of MCS in follow-up samples minus MCS in the baseline samples, or the difference of MCS in follow-up 2 samples minus follow-up 1 sample, and and we see that that if the MCS, the delta MCS is equal to is close to zero, that means that there is no difference in the MCS in the follow-up sample compared to the baseline sample. Then the disease is stable. If the MCS is declining in the follow-up sample, the myeloma is progressing. And this is true. You can see the survival data. So with a lower with a lower delta MC value, the patient have much poor survival, and this disease state is not correlated with age, nor correlated with whether the patient receives stem cell transplantation or not. And this effect can be replicated in another trial. This trial was from Spain, and you can see that the patient with complete remission, the MC stay stable, and the patients with progressive diseases, the MCS was dropping. And the progressive state was driven by genomic instability. You see, we present two representative samples. Here, one stable sample. Here, one progressive sample. A stable case, progressive case. So here, the stable case has a high risk chromosome translocation, the T414. You can see baseline and follow-up sample have actually almost the identical chromosome abnormality, but in the progressive setting, so this case, so the follow-up sample have much more new chromosome alterations. Sorry, I can't move this. Can I hide this? Yes, I can hide. Oh my God, sorry. And at the so the if we look at the entire chromosome change, so we'll see that in the progressive subset, we will see much more copy number changes. So our take-home message is that we can transform developmentally conserved gene expression signature into a myeloma classification score. And this myeloma classification score predicts prognosis in newly diagnosed MM and relapse MM. And a myeloma classification score discriminates patients who may or may not respond to botensilimab-based treatment. And dynamics in myeloma classification score predicts stable or progressive disease state, allowing real-time monitoring of treatment response. And myeloma classification score is independent from currently conceived biomarkers. And this results have been recently published in a journal hosted, in a journal based in Beijing, and you can see all the data which I'm presenting today, and you're also welcome to contact me if so. We will be happy of the world. Okay.
Thank you very much, Professor Han, for an interesting presentation. And I'm going to introduce our next speaker, Professor Dikran Kazancan, a professor of clinical medicine, who is also chair of today's event. Professor is going to talk about new era of chemotherapy-free combination therapies for newly diagnosed multiple myeloma. So, Professor, the stage is yours.
Can you hear me okay?
Yes.
I will share my screen here. Okay, we're getting closer here. Okay, can you see my screen okay?
Yes, everything is good.
Okay, thank you. So I'd like to thank the organizers and OncoDaily for the invitation. It's a pleasure for me to give this talk, and I am totally humbled amongst all the great speakers that we'll be presenting today and have presented. On that note, the title of my talk is The New Era of Chemotherapy-Free Combination Therapies for Newly Diagnosed Multiple Myeloma. So just to give a background, as of a couple of decades ago, the paradigm for treatment of newly diagnosed myeloma revolved around high-dose melphalan with stem cell support, also known as autologous transplant. There were multiple randomized studies and meta-analyses that confirmed the benefit of autologous transplant, both in terms of overall survival and progression-free survival. And so historically, the field moved forward, always keeping autologous transplant as kind of the nucleus around which all other therapies were formulated, both in terms of upstream combination therapies known as induction, and also downstream in terms of maintenance. So the advent of proteasome inhibitor and immunomodulatory drug novel combination, and more recently, the addition of the anti-CD38 monoclonal antibody-based quadruplet therapies really have delivered unparalleled clinical benefit independent of autologous transplant and transplant eligibility in terms of newly diagnosed multiple myeloma. One of the first quote unquote modern trials evaluating the triplet combinations of proteasome inhibitor and immunomodulatory drugs with or without autologous transplant was by the French. They compared bortezomib, lenalidomide, and dexamethasone up front in both arms, and compared basically for those who only received VRD for 8 cycles versus those who received 3 cycles of VRD, followed by transplant, followed by a couple more cycles of VRD and 1 year lenalidomide maintenance therapy. Here, as you can see from the initial result, autologous transplant did improve progression-free survival, as nicely seen by these Kaplan-Meier curve. However, overall survival was more or less the same between the two arms. In the meantime, there was a study done in the US in Boston, and it was fairly the same trial design. It was called a determination study, where all patients received VRD upfront, and one arm received stem cell collection and transplant, whereas the other one continued VRD. And the major difference between this and the French study was the duration of maintenance therapy. As we can see here from the result, again, progression-free survival had improved with the addition of transplant. And here you can see there was no difference in overall survival. This lack of difference in overall survival additionally was not completely due to crossover of the non-transplant arm to transplant. More importantly, the authors assessed the long-term outcomes in terms of attaining MRD negativity. And what is really key up front is for those patients who attain MRD negative response, at least 10 to the minus 5 sensitivity, whether or not they receive transplant did not change progression-free survival nor overall survival. So that leads us to say that in patients who attain MRD negativity, receiving transplant did not improve progression-free survival. Additionally, there was a signal for secondary cancers in those patients who received the high-dose melphalan. So moving forward to the quadruplet therapies, we have our own advanced study at Sylvester. It sets the stage that a reasonable approach may be to save transplant for those who do not attain MRD negativity upfront or relapse. And in other words, can we successfully harvest patients' stem cells upfront and only give the high-dose therapy with stem cell support if needed down the road? Here's the study design of the advanced trial. It's for newly diagnosed multiple myeloma, irrespective of transplant eligibility. They received a quadruplet of Kyprolis, lenalidomide, and dexamethasone, with or without the fourth drug, daratumumab, which is the NICD38 monoclonal antibody. All transplant eligible patients did have their stem cells harvested and then continued on to complete 8 upfront cycles of either the DARA KRD or the KRD. Those patients who were MRD negative after the initial 8 cycles moved on to lenalidomide maintenance therapy. And those who were not were recommended to use their stem cells to have an autologous transplant. The primary endpoint of the study was MRD negativity, 10 to the minus 5 sensitivity. And as you can see here, the DARA KRD arm significantly different, almost double the rate of MRD negative response in the ITT population. In terms of progression-free survival, we saw the same trend. The secondary endpoint was event-free survival, and again, there was a difference in DARA KRD compared to KRD. So now, in the current day, we have multiple randomized studies testing the quadruplet-based therapies using an NICD38 monoclonal antibodies, either daratumumab or isatuximab, in addition to the proteasome inhibitors, bortezomib or carfilzomib. So in the IMRA study, this was for transplant ineligible patients, patients who were either received VRD with or without isatuximab. And here you can see a significant improvement in progression-free survival, basically a 40% decrease in the risk of progression or death. MRD negativity rates were also higher in those who received the quadruplet versus the triplet. Then we have the Perseus study, which was, again, VRD, but this time with or without daratumumab in transplant-eligible newly diagnosed multiple myeloma. Here, you also see about approximately a 60% improvement in the risk of progression or death by receiving 4 drugs. Also, a difference in MRD negativity rate. Then we move the VRD plus or minus daratumumab to transplant ineligible patients in the Cepheus trial, in which actually the primary endpoint was MRD negativity. And here you can see approximately 20% increase rate of MRD negativity in those patients who received the 4 drugs versus the triplet. And here we have one more study, which is the ISKIA study. And again, the addition of isatuximab, the carfilzomib, lenalidomide, and dexamethasone in transplant-eligible patients showed a significant increase in the rate of MRD negativity. Here is the specifics on the ISKIA trial. And what's important to see that the 1-year sustained MRD negativity rate, which is an even more important objective than just the depth, but the duration of the depth of response. And in all subgroups, the quadruplet improved it over the triplet. What was interesting in the study was the subgroup of patients with the translocation 1114, and really does represent a unique group of patients who probably have disease that responds differently to our novel therapies. This is kind of important to show because the responses were a little less, as you can see in this subgroup of patients, even though historically these patients overall in their natural history have a better prognosis. Given these data and data from prior studies, that actually led us here at University of Miami to design the Salvage study, which is an investigator-initiated study testing selinexor in combination with venetoclax in this subgroup of patients. Just briefly, selinexor is an inhibitor of XPO1, which is the nuclear export. It targets key mediators of myelohomogenesis. It is actually approved in the relapsed refractory myeloma population. This other drug is venetoclax, which is the BCL2 inhibitor. And we do know from prior studies that patients with this 1114 subgroup is a somewhat moderate biomarker of high BCL2 expression and response to treatment with BCL2 inhibition. And this investigator-initiated study basically tested the hypothesis that these two drugs can act synergistically. Here is the study design. The patients initially received 1 cycle, 28 days worth of venetoclax with step-up dosing, followed by the combination of both treatments. This was a Simon 2-stage design that met its initial futility and continues to enroll patients currently. Here's the preliminary results of the 13 patients that so far have been treated. The overall response rate has been about 62%. The median PFS has not been reached. And as you can see, we definitely do have activity as hallmarked by the best overall responses in the different IMWG response criteria. Here are the treatment emergent adverse events, and as one expect with this combination, the toxicities that really stand out have been hematologic laboratory abnormalities in most patients and infection. Moving on, back to our quadruplet story, we have the MIDAS study. This was also a very key study. It was a study where all patients with newly diagnosed myeloma received 6 cycles of isatuximab with KRD. And those patients who were, I would say, functionally high risk, meaning those patients that after the initial induction combination did not attain MRD negativity, were randomized to either receive transplant with some more ISA-KRD or tandem transplant. Whereas those patients who were MRD negative were randomized to either receive 6 cycles of ISA-KRD versus transplant with ISA-KRD. And as you can see in this picture, patients who were MRD negative here after the initial induction therapy, whether or not they received transplant or only ISA-KRD, there was no difference in MRD negativity rate. Moving on, before the maintenance, the same, no difference in MRD negativity rates. And important to see here, in those who were MRD positive prior to receiving the randomization and treatment with either tandem transplant or single transplant, there was actually no difference in those between those two treatment modalities. What I would say is it would have been nice. We always sort of, as it is, it's very difficult to conduct these trials. But if we can play, as we say, Monday night quarterback, it would have been nice to have a fictional third arm, as you can see here, that I kind of fictionally put in. In those patients who were functionally high risk MRD positive, what would have happened if they had actually received only ESA KRD? That is, maybe one day we will know the answer to that. Moving on, the other, I think, important thing is like, and this was a tweet from Dr. Fonseca on Twitter that I saw, and I thought it was very interesting, is we traditionally have given about, 4 cycles or so of initial induction therapies before moving on to transplant. But why do we do that? It is very clear that patients continue to deepen their responses with induction therapy. And then, interestingly enough, and what Dr. Fonseca put together is those studies, including the advanced over here, the more initial induction cycles they had, the higher chance they had to attain MRD negativity prior to moving on to transplant. So that's an important note. So, are there alternatives to transplant consolidation in this day and age of immunotherapy? Can we immunoconsolidate patients? So, with a paradigm change where over half of our patients attain MRD negativity with upfront quadruplet, how about patients who do not attain that MRD negativity, which is the other half? So, can immunotherapies possibly afford a chemotherapy-free immunoconsolidation approach? So, on that note, we at Sylvester developed a study, an investigator-initiated trial using abbreviated fixed duration, by default only 4 cycles of immunotherapy, as a strategy to deliver deep and durable responses at the MRD negativity threshold of 10 to the minus 6 after initial combination therapy, which is called the Immunoplan study. Here's the study design. It's patients who with newly diagnosed multiple myeloma who had at least received 4 cycles up front of induction therapy combinations, which had to be either immunomodulatory, IMiD, proteasome inhibitor, and/or anti-CD38, as you can see here in the key eligibility, and who, after this initial induction therapy, attained at least a very good partial response or a complete response, but remained MRD positive in their bone marrow. And they met eligibility, can move on to the study to receive 4 28-day cycles of linvoseltamab. Linvoseltamab is a bispecific T-cell engager. The targets are BCMA and CD3. It has been in the last approximately half a year ago approved for relapse refractory multiple myeloma after 4 prior lines of therapy. So in this study, we're moving it up front to use it as immunoconsolidation in patients with newly diagnosed myeloma who do not attain that deep response of MRD negativity after the induction therapy, despite receiving highly efficacious triplet and quadruplet-based therapies. After the 4 cycles, patients have MRD assessment, 10 to the minus 6 sensitivity. And for those patients who still remain MRD positive, move on to receive 2 more cycles of therapy. Those who convert to MRD negativity move on to the end of treatment and moving on to standard of care maintenance treatment at the investigator's discretion, which for the most part is lenalidomide-based maintenance treatment. This is a 2-stage Simon Minimax design where the target MRD negativity rate was 30% with a null hypothesis of 10%. The first stage was enrolled, and met its futility boundaries, and then we finished enrollment of all 25 patients who are getting, who are receiving treatment and will be finishing up their initial assessments. And in terms of endpoints, the primary endpoint was MRD negativity. The secondary was the feasibility or the safety of receiving linvoseltamab after induction therapy, in addition to the durability of MRD negative responses. On that note, to give you the details, as I said, the primary objective was to determine MRD conversion rates using the clonoSEQ assay with a fixed duration. Overall secondary objectives included safety of the combination, to determine the durability of MRD negativity at 6 months, 12 months, and 24 months, progression-free survival, overall survival, and corollary studies. And so far, as I mentioned, we finished enrollment of the initially designed study of 25 patients. Median age was 62, and about 32% of patients were older than 65 years of age. About a third of patients were female. All patients had good ECOG status, and 16% of patients were Black, whereas 44% of patients were Hispanic. On the right, you can see the disease characteristics, but probably the most important to note is, although the trial initially allows for at least 4 cycles of induction therapies, patients who had been enrolled had actually received up to 8 cycles of induction therapy. And in terms of induction therapies themselves, here you can see the breakdown of what patients received. A third of patients received DARA VRD, another third received the triplet KRD, another third received DARA with KRD, and a couple of patients received alternatives of VRD and isatuximab VRD. And here are the results timeline using a data cutoff of November 1 of the prior year. So of the 25 patients treated, they all finished at least 1 cycle of the linvoseltamab. You can see 88% had attained stringent CR with 12% very good partial response. And 19 patients made it to the post 4-cycle bone marrow biopsy for MRD assessment. And of those 19 patients, 17 of them, or 90% of patients, had actually attained the deep MRD negativity at 10 to the minus 6, and 100% attained the MRD negativity by flow at 10 to the minus 5 sensitivity. Because those 2 patients remained MRD positive, they went on to receive cycle 5 and 6. And of those 2 patients at the time of this data pull, 1 patient had finished those 2 cycles and had converted to MRD negativity. The other patient had not yet finished the additional cycles of treatment. And so overall, in terms of the MRD negativity response, after 4 to 6 cycles, 100% have attained, of the evaluable patients have attained MRD negativity by both next generation sequencing at 10 to the minus 6 and by flow cytometry with a sensitivity of 10 to the minus 5. In terms of progression-free survival, all 25 enrolled patients remain free from progression or relapse. The overall survival has been 100%. No patients had incurred cytokine release syndrome or ICANS, and we had no patient death. 1 patient had a grade 3 serious adverse event, which required hospitalization and was diagnosed with peritonsillar abscess. But there were no grade 4 treatment-related adverse events, and about a third of patients required temporary dose delays. Here on the right, you can see common adverse events that we encountered, and as one would expect, Most common were hematologic laboratory abnormalities. Specifically, 20% of patients had neutropenia, 8% of which was at grade 3. And infections were common. Outside of the peritonsillar abscess, 28% of patients had upper respiratory infection. And a few patients had AST/ALT elevations and GI symptoms, cough, fatigue, and arthralgia. Now, moving on, how about introducing bispecific antibodies in other high-risk subgroups in newly diagnosed multiple myeloma? So we have two specific subgroups that I'm focusing on. So the one subgroup is those patients who receive quadruplet-based combinations, in addition to high-dose melphalan with stem cell support. Despite those treatments, some patients still remain MRD positive while going into their maintenance therapy. The other functional high-risk subgroup are patients who attain MRD negativity with quadruplet induction, with or without transplant, but have early relapse, meaning relapse within the first year or so. Not overt progression, but this is in terms of conversion from MRD negativity to positivity. And that kind of led us to design the ALPDUET study. It was a parallel 2-cohort study of linvoseltamab in addition to lenalidomide for maintenance therapy in newly diagnosed multiple myeloma to deepen responses or redrive MRD negativity after relapse. Here you can see the study design. As I mentioned, it's for patients with newly diagnosed multiple myeloma on maintenance therapy already with lenalidomide, but within the first 12-month window, who either in cohort 1 had at least a partial response benefit from the upfront treatment going into maintenance, but remained MRD positive, or the second cohort who attained a complete response or MRD negativity, but then relapsed during the maintenance within the first year. After baseline evaluations and the study start, patients receive linvoseltamab and lenalidomide maintenance treatment. And as you can see over here, the treatment schedule is for up to 24 cycles. The first cycle is given, first 3 cycles given weekly, and cycles 4 to 6 every other week. And by cycle 7 is given monthly. The lenalidomide is actually restarted at cycle 2, just to isolate any safety signals from linvoseltamab in the first cycle. After the 24 cycles, at the discretion of the investigator, patients can continue standard of care, lenalidomide maintenance, or other treatments as indicated. Here are the objectives. The primary objective to determine the MRD negative conversion rate. Secondary objectives include the rate of early conversions, the durability of these MRD negative conversions, to determine the overall activity in terms of overall response rate and IMWG, best overall responses, to determine durability of those responses, determine length of time to worsening, meaning progression-free survival, overall survival, and of course the safety of the combination of the IMiD and bispecific T-cell engagement. So here specifically, you can see the treatment plan for cycle 1. Patients receive 2 step-up doses. Those are given in the hospital with 24-hour observation, followed by weekly at the full treatment dose. Of note, this treatment dose is lower than the FDA-approved dose because this is also testing the combination with lenalidomide. And for cycles 2 to 24, the lenalidomide is reintroduced. And as I mentioned, receive weekly treatments for the first 3 months, and then every other week for the next 3 months, and starting with the 7th cycle, the 24th cycle. It's given. So in terms of eligibility, patients that have received a triplet or quadruplet-based initial combination therapy containing at least 2 of the following: immunomodulatory proteasome inhibitor and/or anti-CD38, with or without transplant, and being on lenalidomide maintenance therapy within the last 18 months. Again, cohort 1 is that at the time of assessment, the patient's current response is at least a partial response and MRD positive by NGS adaptive clonoSEQ in the bone marrow. The second cohort is at the time of assessment, the patient has a relapse from their initial CR post-induction, but do not meet criteria for IMWG progression. Meaning those patients who no longer meet criteria for CR, but whose M protein is less than 0.5 grams per deciliter, or the immunofixation is turned positive and or converted from MRD positive disease, the MRD negative disease to positive disease. Two-stage design. So for the first cohort, for the first stage, 10 patients will be enrolled. And if we have greater than 2 patients who will convert to MRD negativity, it will meet the futility threshold, and we'll continue to enroll 7 more patients for a total of 17. Success would indicate at least 8 MRD negative, greater than 8 MRD negative responses, total of 17 enrolled patients. For the second cohort, we're going to enroll 7 patients. And if we see greater than 1 patient, we can move on to enroll the complete 15 patients. And we are looking for at least greater than 5 MRD negative responses from a total of 15 patients. So we talked about the immunoplant study using a bispecific redirected T-cell engager to do immunoconsolidation after initial induction therapy. We talked about the ALPDUA study, which uses the same bispecific T-cell redirector in order to target high-risk populations while they're on the maintenance therapy. But this poses also a question: can we move these bispecific T-cell redirectors completely upfront for the treatment of newly diagnosed myeloma? And that leads us to the Advanced 2.0 study that we have at the Sylvester. And in this study is the combination of elranatamab, which is another FDA-approved therapy for patients who receive at least 4 prior lines of treatment, with lenalidomide and dexamethasone, and depending on patient eligibility, with or without carfilzomib in newly diagnosed myeloma. In this study, it's an open label, Simon 2-stage design, with the primary objective of evaluating the rate of deep remissions, at least 10 to the minus 5 sensitivity, and approximately 150 newly diagnosed patients with multiple myeloma. Here is the objectives and the endpoints used to assess those objectives. The primary endpoint, again, is MRD negativity after at least 12 cycles of treatment. Secondary objectives include the traditional metrics of overall response rate, disease stability, partial disease, and duration of response, partial response, and complete response. Then we also, of course, want to evaluate the durability of these MRD negative responses, i.e. the sustained MRD negativity rate, and evaluate the rate of deep remissions at both 10 to the minus 5 and 10 to the minus 6 sensitivity at the 12 and 24 month milestone. Here is the treatment plan. In short, patients receive step-up dosing with elranatamab and dexamethasone, and if cycle 2, start to receive lenalidomide, and for those who qualify, carfilzomib. This goes on for 24 cycles. Patients who are MRD negative at the 24 months could continue standard of care maintenance with lenalidomide. Those who are MRD positive at 24 months could continue maintenance with lenalidomide and elranatamab or other treatments as indicated at the discretion of the treating physician. Here's eligibility for patients deemed eligible for quadruplet combination therapies, including carfilzomib. They have to meet one of these criteria, either quadruplet eligible, ineligible, or deferred. So in summary, as I wrap up my talk today, we're really trying to move the needle forward in using immunotherapies earlier in higher risk patient groups. Using an investigator-initiated trials platform allows us to collect research samples and perform important translational science. It really opens many doors for potential collaborations and projects with our Moffitt and other brothers and sisters across the U.S. and the world. The immunoplant study uses a short fixed 4 to 6 cycles duration of the bispecific to convert patients to deep MRD durable responses. So far in the immunoplant, we see 100% MRD negativity rate, and a 10 to the minus 6 sensitivity, and 6 and 12-month durability thus far is also being observed. So given the magnitude of this MRD negativity and favorable benefit to risk profile, we did expand the study to enroll more patients. The OptiS study uses bispecifics during maintenance phase to target high-risk patients who either haven't attained MRD negativity or have converted to MRD positivity. And lastly, Advanced 2.0 takes a step forward to introducing these bispecifics during induction with a highly effective triplet backbone of KRD or RD. On that note, I'd like to thank all our supporters and my group, patients who allow us to do these trials, and my whole team at Sylvester, the research team, and of course, our chief mentor, Dr. Langren, and all my colleagues that support our group. Thank you.
Thank you, Professor, for your informative and interesting presentation. And I'm going to introduce our next speaker, who is Professor Manoj Bhasin, who is going to talk about reframing multiple myeloma through the lens of immune microenvironment. Professor, the floor is yours.
Thank you. First of all, thanks for inviting me. And this is a really interesting concept. And for next 20 minutes, I will be talking about our recent work in the field of multiple myeloma, where we are trying to map the immune microenvironment of multiple myeloma and trying to explore if it has association with outcomes in multiple myeloma. I hope everyone can hear me well, correct? Okay, before going into the scientific part of my talk, I would like to thank all the members of my team who really worked on generating the data, analyzing the data, as well as I would like to thank all my collaborators, as well as, let me just take a laser pointer, all my collaborators and the funding agencies and the patients who contributed the samples for this study. So multiple myeloma is a second most common hematological malignancy. And in last 2 decades, we made a great progress on improving the outcomes in multiple myeloma, but we still cannot say that multiple myeloma is curable. Most of the patients, the disease relapses and progresses. And so there is a significant amount of progress being made in developing new therapies for multiple myeloma. So per current standards, multiple myeloma is stratified based on like cytogenetic variants as well as the clinical factors. And we generally put multiple myeloma into 2 bigger buckets. One is high risk disease and other is standard risk disease. And what we observed in last decades, that some of the patients which have like a high risk disease, they achieve pretty stable remission. The disease don't progress in these patients. Whereas if we look at the other part of this disease, the standard risk patient, they show a rapid progression of the disease. So that made us to think that cytogenetics and the clinical factors are not only contributing in the progression of the disease. There is a missing link in the progression of multiple myeloma. And to really understand that missing piece, we started a multi-center study with our partners 5 years back to really profile the immune landscape of multiple myeloma. The work has been performed by using a technique that is called as single cell profiling or single cell RNA sequencing. So single cell RNA sequencing has emerged in last 2 decades as a primary functional assay for primary functional genomics because it allow us to look at each cell of tumor as well as its microenvironment individually. So before that, what we used to do is we used to take a complex tissue like a tumor tissue. It has the tumor cells, it has the immune cells. We used to crush that tissue, make a smoothie kind of thing, and that is like an average expression of either tumor cell or immune cells or stromal cells or a mixture of them. We don't know from where the signal is coming. So what single cell brought on the table is that it allow us to look at each cell's profile very precisely with great accuracy. So we implemented this technique to map the immune landscape of multiple myeloma. And the phase 1 of Immune Atlas has generated the data on 337 newly diagnosed multiple myeloma patients. And we divided the study in 2 phases. One is the discovery part of the arm, and second one is the validation part of the arm. And like here is the glimpse of the data. This kind of maps, they are called as UMAP, where you're seeing like each dot is one cell and they are clustered based on their expression profile. So when we like profile these 337 patients, that generated the data on 1.4 million cells from myeloma bone marrow microenvironment. And all of these 337 patients are newly diagnosed patients. Their data is generated when they first time visited the clinic before they got any therapy. So the data based on the clustering, it formed 5 major islands. The first island is, and the largest one is the T cell compartment, followed by myeloid cell compartment, followed by B cell compartment, erythroid cell compartment. Though this study was performed on uh, immune focused part of the bone marrow microenvironment, so we selected CD138 negative cells, but we still able to capture some of the malignant plasma cell in this assay. So after doing all extensive characterization, annotation of these cells, we are able to characterize 106 different cell type, subtype, and functional states of immune and stromal cells in myeloma bone marrow microenvironment. The study of such a scale uh, allowed us to like look at most of the canonical cells. Like this UMAP represents like the T cell compartment. So we are able to see most of the canonical T cells like naive CD4 T cells, naive CD8 T cells, all NK variants, but it also allow us to look at the rarer cell types like cytotoxic CD4 T cells. So we mainly look at the CD8 cytotoxic T cells, as these are the primary cells which help in eradicating the tumor. But we observed in this study that there is the existence of CD4 cytotoxic T cells, and we labeled each of the cell types manually based on very well characterized biomarker which are specific to these cell types. So after doing all this annotation, we started going into like, can we really see like if there is a difference in immune microenvironment of the patients if we stratify the patients based on the current risk um, like parameters. So we stratify the patients into standard risk and high risk based on like current standards in the field. So we have 108 patients which are standard risk. We have 123 patients which are high risk. And after doing this stratification, we ask the question, is there specific kind of immune cells which are enriched in these high risk patient and might be associated with the progression of the disease? So here you're looking at the T cell compartment of these patients. Like this is the trajectory of T cells arranged from naive T cells to more differentiated kind of T cells, like late effector T cells or kind of exhausted kind of T cells. So when we looked at each one of these T cell components, so what we learned is that there is a transitional T cell cluster that we labeled as CD8 T effector HLA. And these cells are more enriched in high risk patients as compared to standard risk patients. And they are not only more in high risk patient, but if you look at the activity score of these cells, that is also more in these high risk patients. And by looking at what these cells express, we call them putatively dysfunctional T cells because they express low level of cytotoxic markers, but they have like high level of antigen presentation related molecules. So we call them like putatively dysfunctional T cells. So then we ask the next question, like if we put our patient into two buckets based on the level of these putatively dysfunctional T cells, is this able to predict the outcome of the patients? And the answer is here. Like if you stratify the patients based on like the level of these dysfunctional T cells, the orange color line represent the high level of these dysfunctional T cells, blue color is low level. So we do see that the patient which have like high level of these dysfunctional T cells, they have poor progression-free survival as well as they have poor overall survival. So this is the first glimpse we achieved from this data, that the high level of these putatively dysfunctional T cells associate with the poor outcome. And when we looked into the gene signature of these cells, these dysfunctional T cells, they have high level of exhaustion markers like PDCD1, LAG3, and they have like high level of senescent markers, and they have low level of co-stimulatory molecules like CD27 and CD28. So kind of these are compromised cells in this case. So, okay, if we put our patient into two bigger buckets, like one is standard risk and high risk, we do see that the high risk patient have these dysfunctional T cell enrichment. But then we ask the question basically, like, is every high risk patient which carry different kind of cytogenetic abnormality that making them high risk patients, do everyone's immune microenvironment look similar, or they have difference in their immune microenvironment? Because it might be the case that one group of patient using one component of immune system to overcome the immune surveillance, whereas the other one is using something else. So when we did that, so here is the glimpse of that. So T414, that is one subtype of multiple myeloma. And if you look into like MAF translocation kind of multiple myeloma, and then del17p13 multiple myeloma. Generally, in high-risk patient, we see those patients have less amount of interferon 1 activity, and we see that in T414 kind of multiple myeloma in both CD4 compartment as well as in the CD8 compartment. And they have like usual accumulation of these exhausted T cells, more cytotoxic terminally differentiated T cells, and senescent kind of T cells. But if you focus on this part of this heat map, del17p13 patients, they have more interferon 1 activity. They have more amount of naive T cells. They have like less amount of cytotoxic T cell. They have less amount of senescent kind of T cells. So like T414 and del17p13 patients, though both of them are high risk patients, but they have very different kind of immune profile. So that first time given us a hint that different high risk patients with different cytogenetic abnormalities may be using different immune components to overcome the surveillance and make the progression of the disease. So then we ask the question like, who is secreting this interferon 1 in these high risk del17p13 patients? Like, this is coming from like just T cells or myeloid cells or some other cells? So when we looked deeply into it, like I'm showing this in this heat map, that del17p13 patient, and these are each one of the cell types. So every cell is secreting high level of interferon 1 activity. So they have like high level of interferon 1 activity, mean they are secreting it. And then we validated it on full compass cohort, where we see that even if we look into the bulk data, there is a striking concordance in between interferon signature score as we observed in our single cell study. So to summarize the first part of my talk, what we achieved till now is that the high risk patient show accumulation of putatively dysfunctional kind of T cells, and the plasma cells with distinct kind of cytogenetic alteration, they differently shape the immune microenvironment. T414 cells, myeloma cells, they are associated with dysfunctional or senescent kind of T cell state, whereas del17p13 plasma cells, they are associated with increased interferon 1 signaling in both tumor and immune microenvironment. So that is, I think, first time we shown in this study. Then we ask the question, let's forget about the cytogenetics and let's focus on like the progression of the disease. Like, can we compare the patient which show the progression of the disease and compare them with the patient which have not shown the progression of the disease? So in our study, we looked at two extremes part of the kind of patients. One is the patient which we called as the rapid progressors. These patients show the progression of the disease within first 18 months of the treatment. We call them rapid progressor. And there's a second group of patients which have no sign of progression within first 4 year after the treatment. So these are kind of like a long-term patient which have no progression of disease. So we have like 67 patient where the disease progressed within first 18 months, and there is 83 patient where there is no progression of disease in this case. So here we started looking into each of the immune compartment. This is the figure of from their T cell compartment, like the cells are arranged from naive to more differentiated kind of T cells. And these are like a central memory kind of T cells. So like this is the trajectory of T cell differentiation that I'm showing. And we looked at like each point of this trajectory, like is there the difference in the proportion of cells from the patient which show a rapid progression of disease as compared to non-progressors. So when we look at the starting part of this trajectory where there is more naive T cells, so we do see that the patients which are non-progressing, they have more of these naive T cells as well as these central memory kind of effector, early effector T cells in these non-progressing kind of patients. But when we look toward the end of this trajectory, these putatively dysfunctional kind of T cells, which are terminally differentiated kind of T cells, as well as these CD8 effector, which are also terminally differentiated because they are toward the end of this trajectory, they are more enriched in the patient, which show the rapid progression of the disease. So it show a similar kind of picture that we observed in high-risk patients, that these terminally or putatively dysfunctional kind of T cells are more enriched in the patients with the rapid progression of the disease. So then we say, like, if we like stratify our patient based on the level of this cytotoxicity signature or the dysfunctional signature, do we see an association with the outcome? Yes, the patient which are having like more amount of these terminally differentiated cytotoxic CD8 T cells, if they have more amount of them, they have poor progression-free survival. And similar is true if they have like a dysfunctional kind of signature. So these accumulation of these dysfunctional or late effector T cells in the bone marrow associate with the poor outcome. Then we ask another question like, okay, this is not clear that the patient which are rapidly progressing, which are high risk, they have these dysfunctional kind of T cells. But we have a subset of patients which are standard risk, but even then they show a rapid progression of the disease. How does their immune microenvironment look like? So we asked that question, and by looking at these patients, like which are rapid progressors, but they are standard risk patients. So if we look at their immune microenvironment, does it's similar to the high risk patient or it is something different? So when we looked at that, so their immune microenvironment of these patients which are standard risk but shown the rapid progression of disease has multiple similarities with the high-risk patients' immune microenvironment. You can see their CD8 T cells are pretty similar to the high-risk patient. Their B cell compartment is very similar to that. But if you look at where the differences are coming, is these patients have the enrichment of these CD4 cytotoxic T cells. So they are more enriched in the immune microenvironment. They have like more level of these immunosuppressive M2 macrophages in their bone marrow microenvironment. And they have a low level of these NK cells in their bone marrow microenvironment. So it looked like to us that these patients which are standard risk but showing a rapid progression of the disease, they have like something like even more than what we see in the high risk patients. They have immunosuppressive M2 macrophages. They have CD4 cytotoxic T cells, which are not observed in the patients with the high risk of the disease. So all this analysis made it very clear to us that immune system is like showing a differential expression as well as differential enrichment in the patients with high risk of the disease as compared to the standard risk, or in the patient which show the functional progression of the disease. So then we ask the question, like, all the changes that we're observing in the T cell, can they complement the existing parameter that we use for stratifying the patient into the standard risk and high risk? So what we learned is that the patients, if we develop a risk stratification model based on their cytogenetics, based on their age, based on their ISS staging, they like predict the progression-free survival with an area under curve of 0.73. When we add the immune component that we just described in last few slides, based on our data, so that like AUC from 0.73 jump to 0.96. So it means that we can predict the progression of the patient with much more accuracy if we add the immune input along with the cytogenetics input. And then we ask the question, like, who is contributing, like who is making this increase from 0.73 to 0.96? So what we learned is that the major component is these putatively dysfunctional kind of T cell, these terminally differentiated kind of CD8 T cells, which are more enriched in the patient, which show the rapid progression of the disease. So this finding is um, like we independently validated it on generating the data from 73 more patients in our cohort, where we see that the patients which have like we can predict their progression-free survival with similar AUC on this validation cohort that is never seen by our prediction model. So that is great thing. So that gives us the idea that we should be using immune system along with other cytogenetic component to better predict the patient who are going to progress, the patient who are going to have like a sustained kind of remission, and look like to us that as a summary that late effector CD8 T cells are associated with the rapid progression of the disease, and standard risk patient with rapid progression of the disease, they have enrichment of these cytotoxic CD4 T cells and M2 macrophages, and adding this immune component along with the current cytogenetics further improve our performance. Okay, so this is all data that I presented till now is generated from the baseline, is from the newly diagnosed patient, their first sample that we got from these patients. So let's now shift gear and look into like what happened to the immune system if we look into the like longitudinal sample. So from the same study, we have 209 samples, 243 immune microenvironment sample for which we generated the single cell data to really see like uh, to really observe like what are the immune feature that predict the long-term remission, and what are the features of myeloma cells that by using them they can overcome the immune system, and then how does the immune system and the myeloma cells interact during the progression of the disease. So we are now looking at like the difference in the immune profile of the sample that is obtained at diagnosis or at remission or at relapse. So we are looking at the paired samples in this case. So we looked at a very uniform subset of the patients here who used induction therapy and then they got the transplant. And then some patients have like more than median progression-free survival, whereas some patients achieved lower than median progression-free survival. And we said like, what is the difference in between the patient who achieved more than median progression-free survival as compared to the patient which have like a lower than median progression-free survival. So one cell type that emerged as strikingly different when we looked at the baseline and first response samples is these naive B cells. They are much more enrichment of naive B cells in the patient's first response samples as compared to baseline, which achieved greater than median progression-free survival as compared to the patient which have like a lower than median progression-free survival. We don't see any increase in their naive T cells, or there is a very minimal increase into their naive B cells, and it's not significant. And if we compare these patients who have like a greater than median progression-free survival as compared to the patient which have like a lower than median progression-free survival, their transcriptome profile, we do see that these like B cells from the patient with greater than median progression-free survival, they have activation of CD40 and MAP kinase signaling pathway. They have the pathways which are associated with the migration of these immune cells, as well as the differentiation of these immune cells. like these B cells for carrying out different functions. Then let's look at the other side of the coin, like what happened in the myeloma cells of the patient, which show the progression, we show the relapse. So if we compare the baseline sample with the first progression samples and look at the myeloma cells, what we observed is that there is a significant enrichment of a group of genes which we call as cancer testis antigens. So these genes, which are shown into the pink color as well as in the pink color, so they show a significant increase in the first progression sample as compared to baseline. And if we look at the immune component of these patients, like, so these are the immune component of these 52 patients where we have like the baseline and the first progression data. So if we look at the immune component of these patients, this will look like that. And if we stratify them based on the patient which have like high level of these cancer testis antigen versus which don't have it. So what we learned is that the patient which are enriched with cancer testis antigen, they are lacking into this part. They don't they are kind of like there's less amount of these cells. And if you look at this UMAP, these are the B cells. So the B cells, like less amount of the B cell is associated with the cancer testis antigen and progression of multiple myeloma. So look like the B cells are key for the sustained remission or the progression of the B cells. So if we look into the T cell component of the same patients, and what we observed is like this is the T cell UMAP. And if you look at like what happened into their CD8 T cells, so all these exhaustion markers, all these cytotoxicity markers, and all these chronic inflammation kind of markers, if we look at the patients which are like cancer testis antigen enriched versus others, so we do see their CD8 T cells have enrichment of exhaustion markers, they have enrichment of these cytotoxic markers, and they have the enrichment of these chronic inflammation kind of markers. So again, the story is same, that the patients which like have the cancer testis antigen and show the progression of the disease, their CD8 T cells in the follow-up samples have the enrichment of these like exhaustion signature or the cytotoxicity signature. So this is like just true for if you just look at the first relapse sample, or if we have like multiple relapse in the patient, like where we have like second relapse, third relapse in the patient, do we see this story of cancer testis antigen intensify or not? So to really prove that, we looked at the some of the patient where we have like a multiple relapse samples, like, so this is the first relapse sample, this is the second relapse sample, this is the third relapse sample from the same patient. And if you look at this purple part of the bar graph that represent the levels of amount of cancer testis antigen, they are increasing from the first relapse to second relapse to third relapse. So they are becoming more enriched. And if you look at like again the immune component from this same patient, we do see that with like of each relapse, like at fourth relapse there is less amount of B cells, and at fifth relapse even they further reduces. So kind of like it shows that as we are patient is relapsing again and again, we are losing more of these B cells in those patients, and these cancer testis antigen, they are becoming more enriched. So I think with this, I will like to finish by giving like some key take-home messages. That first of all, that immune system is really play a significant role in the outcome of multiple myeloma. Adding the immune component to the current cytogenetic risk stratification strategies really improves like how we can predict the progression-free survival. And the patient myeloma cells which are having like different cytogenetic alterations, they have different kind of immune landscape, like T414 versus del 17p13. They have like a very different kind of immune profile, and accumulation of these late effector CD8 T cells look like to be associated with the poor outcome in these patients, and look like if we have longitudinal samples, B cells play an important role in the sustained remission of these patients. If you have more amount of naive B cells after the transplant, you're going to see a much better outcome. Whereas, like if the patient is showing a quick relapse, those patients, myeloma cells, they have like enrichment of these cancer testis antigens, and they also have the T cells, which show signs of these late effector features or relatively dysfunctional kind of the features. With that, I would like to thank everyone for listening to me, and happy to answer any question. Thank you.
Thank you, Professor, for your excellent presentation.
Thank you.
Now we have a short break.
Okay. Can I leave?
Yes, you can leave.
Thank you.
So moving on, I would like to introduce our next speaker, Dennis Pecker from USA, Professor, Department of Pathology and Laboratory Medicine at Emory University School. Speech topic, clonal evolution in multiple myeloma, what MRD is and isn't telling us. Please, you can start.
Good morning, everyone. Can you hear me? I can't hear anything. Perfect. So I'll start my presentation very quickly since we have limited time. Good morning and good afternoon, depending on where you are physically. I am Dr. Denise Pecker-Barcliffe from Emory University School of Medicine and Winship Cancer Center. And I will talk about clonal evolution in multiple myeloma and also what minimal residual disease tells us and doesn't tell us. And I have no conflict of interest to declare related to this talk. And this is just an overview and objectives. The objectives of this talk is to understand clonal evolution in myeloma, review of MRD methodologies and performance, interpret MRD in the context of spatial and temporal heterogeneity, define what MRD does not capture, and discuss the future directions and possible novel tools. Plasma cell myeloma, diagnosis of plasma cell myeloma requires clinical symptoms and laboratory findings, CBC, CMP, serum, urine protein, UPEP, SPEP. You all know how we make the diagnosis of myeloma from the very beginning, including flow cytometry and molecular testing, and MRD is now part of this process. Of course, myeloma is a complex disease, just like every other plasma cell neoplasm, and it requires certain diagnostic criteria, especially with the presence of clonal plasma cells, either more than 10% in the bone marrow biopsy proven clonality, with other findings like hypercalcemia, renal insufficiency, anemia, bone lesion, so forth. Or if the patient has more than 60% clonal plasmacytosis in the marrow, that also is enough for rendering the diagnosis of myeloma. And there are other major criteria that you don't need the minor criteria to make the diagnosis based on the 5th edition of WHO, which we use as a diagnostic standard. This is just an image of what we look at in myeloma marrows in the background of normal hematopoietic proliferation. We have these deep blue cytoplasm cells, and we do 200 to 500 cell count and determine what the percentage of myeloma cells in the marrow on aspirate and also on clot section or core biopsy section, depending on what you have. And you can also use immunohistochemistry to more accurately determine on the core biopsy or H&E sections. And flow cytometry is another diagnostic tool we pretty much always employ for the diagnosis or monitoring of myeloma. And this is not an MRD flow. This is just a conventional flow. We have myeloma defining or plasma cell defining antigens like CD38, CD138, and kappa and lambda. Here is a lambda restricted population, which is also expressing atypically CD56, which can be important for us, not only for prognosis, but also for monitoring the disease to see if this aberrancy is present in the follow-up marrows. So the therapeutic landscape of myeloma has dramatically changed, as we all know, starting from steroids all the way to now CAR T cells and targeted treatments. The incorporation of monoclonal antibodies, first in the relapse setting and more recently in the frontline treatment in a triplet of quadruplet regimen, the approval of CAR T therapy and everything, it revolutionized the myeloma treatment and also prognosis. Alongside the molecular and cytogenetic features of plasma cells, depth of response to therapy is still a key prognostic determinant and is essential for the patient management. Minimal residual disease assessment has significantly enhanced the evolution of treatment response and refined the prognostic stratification across multiple settings, including newly diagnosed, transplant eligible or non-eligible patients, and those with relapsed disease. The prognostic value of MRD is now well established, supported by numerous retrospective and prospective studies, and MRD negativity has been incorporated as a standard endpoint in clinical trials. However, despite the strong prognostic significance, the role of MRD in guiding myeloma is still a shaky surface, and there are still some homework we have to do and some challenges we have to overcome. From here, with the challenge, speaking of challenges, we need to look into the myeloma clonality and biological basis. So myeloma is a clonal ecosystem. It's a very complex disease in the background. It's not a single clone disease. What we measure with MRD is usually just the dominant visible branch, not the entire evolutionary tree. There are multiple coexisting subclones that we may not be able to detect. Dynamic evolution under therapy pressure. So there are multiple factors determining dominant and non-dominant clones and subclones and how they are going to behave. From initial diagnosis to post-therapy, we have an initial diagnosis with a multiple coexisting subclone, but we usually have a dominant clone or two. This is the baseline evaluation here. And with early therapy, a lot of these clones are eliminated with patient going into remission. And then we achieve the deep remission. Again, quite a bit silent clones, and cancer cells can easily go into dormant stage and just wait for the trigger to come back and get activated. And maintenance and continued therapy, then these subclones start emerging slowly and eventually can cause relapse. It could be dominant clone just coming back, or it could be just subclones that we did not really detect and they were dormant, and now they are running the disease course. So it's a very multifactorial process. We have the founding and evolving genetic events. We have the dominant clone and subclones and emerging clones. We have epigenetics that pretty much includes everything around that patient, including the therapy. And we have bone marrow microenvironment, not only related to myeloma, but also we are changing the microenvironment with treatment and so forth. So there is an ongoing multifactorial factory going on in the background that can change quite a bit. So let's look at the genetic events. Just the baseline. When we diagnose myeloma, we always do cytogenetics and or FISH testing to see if there are some genetic abnormalities that are commonly associated with myeloma, and they have prognostic value, as we all know. So 1114 translocation with cyclin D1 gene, or 414 translocation, or hyperdiploidy, quite a frequent finding in myeloma patients. So we determine these from the very beginning of the disease. Then we use these markers, if they are positive, as a baseline and follow up for monitoring the disease. So this is, again, very baseline. However, there are also mutations, not only copy number changes in the chromosomes or translocations, but we also have mutation analyses, and we have the data for this. And Wang and colleagues looked at the initial mutations in a cohort of 162 patients in China, and almost 80% of the patients at initial diagnosis had at least one mutation. And mutations were up to 10 in subgroups of the patients, maybe a lot less in frequency, but still that's quite significant. However, there is also this 20% population is not showing the mutations that was detected. Why mutations are important? First, they can be a target for treatment, and mutations also determine which clones win, and especially post-therapy settings. So we need to know this information. While we are focusing on new treatments and MRD assessments for patient management, the genetic landscape of myeloma is also evolving. As we all know, cancer tries to outsmart us, the cancer researchers and practitioners. In newly diagnosed myeloma patients, Walker and colleagues show that deletion of 17p alone is not a really prognostic utility. As we all know, 17p is associated with the TP53 alterations, could be deletion or could be mutation. But their studies show that by allelic alteration of TP53 is present in almost 4% of newly diagnosed myeloma. This is very important and is associated with poor outcome. Not only just one copy change, deletion of 17p or monosomy, but by allelic alteration. This is only 4% in the initial diagnosis. However, biallelic inactivation of TP53 has been reported to be higher at relapse, almost 26%. This just shows that myeloma is evolving under the treatment. Additionally, copy number gains of 1q have been long associated with poor outcomes. This study showed that 4 or more copies actually were associated with significantly poorer outcomes as far as the 1q abnormalities are concerned. So clonal evolution after treatment pressure, it's a thing, and genomic aberrations and transcriptomic convergence are part of this. So Misson et al. Show that increase in number of mutation in samples taken in myeloma patients, and there was a particular increase in patients who had received HDM treatment. Especially progressive disease. So alternating dominance in myeloma clones harboring RAS mutations in all 7 patients with decreased clonal fraction of mutated KRAS and RAS genes, and another NRAS KRAS mutation appeared. So not only new mutations are evolving, also existing mutations are changing their structure and maybe function. And overview of treatment and M component in a patient in patient 15 is estimated that clonal composition and there was a clear RAS gene mutation shift in this patient. So it's very important. If you look here, this is the bone marrow 1, bone marrow 2, biopsy 2, biopsy 3. So we have FOXC1 stable with all the biopsies, and we have NRAS here with both first and second biopsies. With third biopsy, we don't have the NRAS, but we have the KRAS emerged here. So there is also a shift within the same gene group. So after speaking of clonal evolution briefly in myeloma, we can just jump into MRD methods and what we are looking at, what we have and what we are now looking at as far as the minimal residual disease is concerned, which is a very important prognostic factor with management decisions. Multiparametric flow cytometry was used in the past, but this is not really a sensitive test, and there's no standardization, and it's not really reproducible. So we have now next generation flow cytometry developed and standardized by Euroflow to overcome most of the conventional flow cytometry limitation. So it acquires 10 million bone marrow cells and uses 8 to 12 colors. These colors are just markers characterizing most cellular subtypes and normal plasma cells and aberrant plasma cell markers, and also looks at the clonality using the kappa and lambda, cytoplasmic kappa and lambda light chain. So has a high sensibility, allowing detecting one normal plasma cell count close to 1 million, and does not require a sample at the time of diagnosis, but this is just a comparison with NGS. It actually requires a sample at the diagnosis because you want to know what your patient has to start with, not necessarily for the MRD purpose, but you need to have this clonality studies and flow cytometry immunophenotyping. And these methods can identify one malignant cell again in 500,000 to 1 million. And now we have next generation sequencing, right? This is a very sensitive test developed by Adaptive Biotechnologies called clonoSEQ. It's an NGS assay, currently only assay cleared by the FDA. It's for MRD evaluation for myeloma cells. NGS can detect clonotypes that are defined by sharing identical immunoglobulin gene sequence reads with frequency more than 5%. 5% or more. This strategy requires an initial bone marrow sample to identify the predominant clone and allows the myeloma clone to be detected 90 to 92% of myeloma patients. And bone marrow MRD assessment requires repeated invasive procedures that we need bone marrow biopsies. And there are some limitations that we will talk about, like patchy nature of bone marrow and so forth. So these are the next generation flow cytometry and next generation sequencing are now widely used MRD methods. Also, imaging is very important. We will touch base this. I will not go into details of imaging and MRD monitoring using these techniques, but it's crucial part of the myeloma management. And circulating cell-free DNA, we will touch base at the end of our talk, and single-cell RNA sequencing and mass spec methods and so forth. Those are the future directions, and with current limitations, with a lot of studies going on. I just put an image to show both flow cytometry, next generation flow cytometer, how it works, and also next generation sequencing. So flow cytometry and next generation sequencing are completely two different technologies, completely different. With the flow cytometry, you're actually looking at receptors on the surface of the membrane, cell membrane, or inside the membrane, like light chains. But with the next generation sequencing, you are extracting DNA, which you're not doing with flow cytometry, and you are preparing the library, and you just need to know that predominant clone, and you start sequencing the DNA, and you analyze your findings, which requires enormous mental workforce and experience. And what you get with flow cytometry is this: you have a lambda and kappa positive population here, just like normal plasma cells or B cells expressed. And you have here kappa and lambda, and you have this blue or aqua population that is piling up in lambda. That means these are lambda clonal. So this is the MRD by flow cytometry. On the other hand, clonoSEQ shows you a positive results. For instance, this is a sample report of clonoSEQ and 91 residual clonal cells per million nucleated cells. So this is the sensitivity of the test. When we compare these two tests, again, these are completely separate technologies. They are apples and oranges. However, we are trying to do the same thing using these two technologies. Sensitivity is less in flow cytometry as expected. You're not looking at the DNA level. With NGS, it's a lot more sensitive. Applicability, flow cytometry is very easy to access. It's pretty much everywhere, or you can just send the sample to the institutions who validated MRD assays on their flow cytometry, and you can get it done very quickly. However, NGS is 90%, despite all the efforts with the Medicare and Medicaid approvals and more now insurance support. Turnaround time, flow cytometry is a very fast technique. You can get results in hours. For NGS, it takes about 7 days because of the complex processing. And sample has to be fresh for NGS flow cytometry, but fresh or FFPE as long as it's not decalcified for NGS. Diagnostic sample you need for NGS, that's a must, and quantitative, both of them. There's no molecular characterization by flow cytometry, and cost is a little different for these two tests because of the different technologies. So when to use MRD assessment and how much useful in high-risk disease? MRD only in patients with complete hematologic response or every other patient, Or should MRD results impact therapeutic decision making? So these are the questions we have been asking ourselves to better manage these patients over the years. 568 patients who achieved bone marrow MRD negativity following autologous stem cell transplant and maintenance combination therapy with an immunomodulatory agent and a proteasome inhibitor. And bone marrow MRD was evaluated using next generation flow cytometry at 3 to 6 month intervals. And conversion to MRD positivity was more likely within the 5 years of diagnosis or from the first autologous stem cell transplant. And abnormal cytogenetics and GAP70, which is a validated assay with 70 genes to determine high-risk myeloma, correlated with the MRD conversion from negative to positive. So the results of the study is very interesting, like how MRD actually converses. It's just not like positive or negative, but how it changes over time and what affects this. And MRD negativity within 6 months of diagnosis indicates a higher likelihood of MRD conversion and future clinical relapse in these patients that were studied. And late MRD conversion also confers a similar favorable overall survival as achieved with sustained MRD negativity. So there is actually quite a bit data on this that we can make sense of, and we are. So this is why MRD is becoming a very, very valuable tool for us. And it affects our therapy decisions, right? One study that I just want to discuss here very briefly looked at the variability in the myeloma experts, naming treating clinicians. So they looked at this variability with expert panel of 61 practicing hematologists, oncologists from 14 countries in Europe. So when we looked at the key consensus-based recommendation on MRD testing, there was quite a bit consensus, more than 75% by the experts in these areas. However, here, there wasn't really a consensus on recommending MRD testing if a patient had very good partial response, or no consensus on recommending MRD testing with or without PET-CT prior to transplant, and no consensus on making treatment decisions based on the MRD status. This is, again, just 61 colleagues from 14 European countries, but it just shows that we don't really have concretely established practice yet. And what does NCCN guideline tells us? With the recent version, NCCN guidelines recommends obtaining baseline clonotype identification at diagnosis or store an aspirate sample for future clonotype identification to enable minimal residual disease testing by NGS, right? This is the NCCN guideline recommendation. So what does MRD tell us, really? So based on the MRD, based on the NCCN guidelines, again, response criteria for multiple myeloma is also categorized based on MRD negativity by flow, by sequencing, plus imaging, and so forth. So I don't want to go into details. We don't have time, but it's also in the NCCN guidelines how we act on MRD results in these patients. So what does MRD not tell us? So this is the most important part that we need to understand and tackle, and which there are enormous number of studies trying to address these questions. So MRD negative does not mean disease is eradicated like we talked about in the very beginning. There's a special heterogeneity. Where you look matters. Myeloma is a patchy within the marrow. Even within a bone marrow biopsy I receive on a daily basis, you have 60% myeloma cells in the core biopsy, and you have a very hemodilute aspirate with no plasma cells and flow cytometry negative, but you have that large sheets of plasma cells that you cannot use for NGS testing. So these are the limitations that we come across even on our daily practice. And different anatomical sites may harbor distinct subclones and different mutational profiles. So we just need to keep an eye on these different anatomical sites in osseous or extraosseous plasmacytomas, and they may have divergent clones. So MRD to be interpreted as site-limited disease assessment at this point and integrated with imaging and clinical context. At temporal heterogeneity, when you look matters. Clonal architecture evolves over time. We saw that initially. Therapy pressure, immune selection, ongoing genomic instability, everything, microenvironment, changing microenvironment, everything contributes to this. And minor subclones at diagnosis may survive therapy and expand later, causing in relapse. MRD should be interpreted longitudinally, not as a one-time endpoint. So MRD is technically a partial truth, but it's an enormously important tool we have. And our MRD measures disease at one site and one time in a dynamic heterogeneous disease. So we need to overcome this, and how we can tackle and detect these subclones and how we can determine these subclones are going to be the cause of the relapse in these patients. So just summary, what MRD captures is the depth of response at one site and moment in time. What misses spatial disease distribution. It depends your sampling limits. If you don't have a good aspirate with plasma cells, and if the bone marrow biopsy from the patient shows plasma cell myeloma, there's not much you can do with that sample sometimes. And clonal diversity is a problem, and evolutionary trajectory of the clones and subclones, and emerging resistant clones. Like we saw that T53 by allelic mutation evolves over time, although it's not present in the very beginning. So what are the future directions? Very briefly, liquid biopsies, they are less invasive and easily obtained from the patients in an office setting even. They can track genomic aberrations such as tumor mutation, copy number aberrations, or translocation, especially circulating cell-free DNA. But also low level of circulating tumor DNA or cell-free DNA is a challenge for these techniques, and also ultra deep targeted sequencing is promising, but its sensitivity relates to the number of, again, tumor mutations and limited data so far on these. So these technologies are emerging. There is a lot of research going on, and hopefully we will have some results that we can complement at least what we have in the near future. And automated mass fix is replacement for gel-based immunofixation, more sensitive than the traditional immunofixation that we use on our myeloma patients in the laboratory setting, but still limited by interference from the polyclonal immunoglobulin background, which we all have, right? And clonotypic mass spectrometry is very promising, and it's clonotypic mass spectrometry, CTMS, which involves a proteolytic digestion of M protein and analysis of peptide fragments with an Orbitrap mass analyzer. So with this technique, you're almost getting a peptide fingerprint of a myeloma cell. And this signal is highly specific and can be traced at extraordinarily low levels in subsequent samples, with a limit of detection approximately 1,000-fold lower than serum protein electrophoresis, like SPEP. But also, just like the other techniques, there are some handicaps here. So both automated mass fix and CT mass spec suffer from a variety of myeloma secretion. So not every single myeloma is the same secreting myeloma, right? We have light chain myeloma, we have non-secreting myeloma. So those fringe variants are going to be the problem with these techniques, even though it's very sensitive. So this is the end of my talk. We only had 30 minutes. This is such a fascinating topic. I could just talk about this till the morning, but I want to stop here and thank you all for joining. And I don't know if I have time for questions, but I'm happy to take any questions here, or later on, you can just email me. Thank you very much.
Thank you very much, Professor Pecker, for the insightful and engaging presentation. We truly appreciate your valuable contribution.
By the way, I can't hear anything. I don't know what the problem is.
Thank you. It is now my pleasure to introduce our next speaker, Francesco Maura. Dr. Maura is the Associate Director of the Myeloma Research Institute at the University of Miami, where he leads important work in understanding multiple myeloma and improving therapeutic strategies. Today, he'll be speaking on mechanisms of resistance to immunotherapy, a topic that is critical as we continue to advance cancer treatment and address challenges in patient response. Dr. Maura, the floor is yours.
Thank you. Can you hear me? Can you hear me? Can you hear me?
Yes, we can hear you.
Okay. Hi, good morning or afternoon. Thanks for having me. Just clarification, I recently moved to Memorial Sloan Kettering, so I'm not in Miami anymore. So today I'm going to talk about mechanism of resistance to immunotherapies in myeloma. So my conflict of interest. So when we talk about multiple myeloma and immunotherapies, of course, we have right now 5 different products, anti-BCMA products approved by the FDA for treatment of relapsed refractory multiple myeloma. We know that CAR-T are very effective and also bispecific antibody. We also have a class of anti-GPRC5D therapy approved with talquetamab as a bispecific antibody, a new agent coming both for targeting either GPRC5D or BCMA, or also novel targets like FCFR5. So these treatment, as everybody knows, are rapidly changing our approach to patients. The survival is impressive. These are some of the studies. I haven't updated, but I'm sure many of you are familiar with the MajesTEC-3, incredible results. And so when we talk about tumor resistance or tumor evolution, when we treat the patients, we have to consider 3 groups of patients. So one are the patients that are cured. You treat them and or cure or achieve a very long remission. Then you have the patients that relapse after initial response. So you basically wipe most of the tumor cells. The patient is in MRD positive or even in MRD negative. And then after 1 year or 2 years or 3 years, the patient relapses. And then you have the refractory patients, where the patients do not respond or marginally respond and quickly lose sensitivity to the therapy. So in the first case, the one with the relapse, maybe I can put my pointer here. In this group, we expect that the major clone is wiped out by the therapy, and one tumor cells usually acquire a distinct mechanism of resistance that expand and take the dominance. And that might take years to this phenomenon to occur, or like shorter. And then the refractory patients are the one where the mechanism of resistance is already present at baseline, making them resistant. When we talk about immunotherapies, it's also important not just to understand how patients progress, if it's long-term or short-term or refractory, but also how this drug works. So we know that the CAR-T are at their maximum efficacy in the first weeks when they have maximum expansion of the CAR. And then there are different opinions about if the CAR still provide a selective pressure over time or not. But in principle, most of the selective pressure against the therapy is concentrated in a few weeks after the CAR administration. With the bispecific antibody, our selective pressure instead is constant over time. We keep giving antibodies for now, at least until progression. We might delay the doses, but this way of administration provides a constant and prolonged selection. So the tumor, to survive this selection once respond, needs to most likely directly escape the antibody, for example, through antigen escape. While in the context of CAR-T, if the selective pressure is just limited in a short time, it doesn't have necessarily to acquire permanent alteration of the antigen or something like antigen escape that is permanent, might just create a dormancy situation and then expand again after the CAR disappear. The last concept, that's the third, after the 3 groups, the way of selective pressure over time, we have the target essentiality. We know that some targets like BCMA are extremely important to plasma cells. Is a key marker of plasma cell differentiation, sustained plasma cell NF-κB, and is particularly important in multiple myeloma. GPRC5D, on the other hand, we don't really know what it does, and it seems not to be essential in different studies. And so if you have a target that is not essential, you have a more easier way to lose it. The tumor cell is smart, is sneaky, they can find a way to lose the antigen quickly. But if something is essential like BCMA, it might be very hard for the tumor to lose it. So let's talk quickly about the anti-GPRC5D antibody. We know since the first New England Journal of Medicine at MSK, led by Shamayel and Cody and Eric Smith, that when you treat patients with anti-GPRC5D CAR-T in these settings, all the patients progressing have either no or significantly decreased expression of GPRC5D and relapse. And later study, in particular the one led by our collaborative effort with Calgary, Würzburg University, and TGen, City of Hope, and MSK, and Miami, we show that the evolution of the tumor under the pressure of anti-GPRC5D therapy, in this patient was a talquetamab, is often characterized by loss of GPRC5D through B-allelic inactivation. So you lose either both copies, or you lose one copy and you inactivate epigenetically the other one. We think that overall 90% of the patients, if not more, that respond to anti-GPRC5D therapy relapse with the distinct mechanism of antigen escape. These antigen escape mechanisms are not seen in patients that are primary refractory, and we still need to understand what is behind this behavior. When it comes to BCMA, if we know that 90% or more of patients that respond to talquetamab or CAR-T anti-GPRC5D lose GPRC5D at progression, in the context of BCMA, we have a completely opposite situation where only 5% of the patients lose BCMA biallelically. As I said before, BCMA is a very essential biologically, so it's very hard for the tumor cells to lose it. These are some of the studies that have been reported. Different groups reported individual, 1 or 2 patients. So overall, our estimation, according to all these studies, is that around 5% of the patients progress as BCMA negative after the first treatment with anti-BCMA. If you treat multiple times, if you have patients exposed to multiple lines of anti-BCMA, probably the number of BCMA negative cases will go up. Importantly, BCMA negative cases are never present before therapy. So these are clones that are specifically selected under the selective pressure of our therapy. So when it comes to patients that respond to bispecific antibody, where the treatment selection is persistent and chronic over time, so these are not the patients that are refractory, these are the patients that respond for more than 6 months, we show with Denise Arbalis, Paolo Neri, and Oli Lee in Nature Medicine a few years ago that most of these patients relapse with mutations on the BCMA. These mutations are localized specifically on the extracellular domain of BCMA. So BCMA is still expressed by flow, is still able to bind BAF and APRIL, so BCMA and the tumor cells are still able to activate downstream NF-κB and the tumor cell proliferation. But what this mutation does, they alter the binding of the antibodies, teclistamab and erlotinib, which are very similar and close one to another. It is very fascinating how the tumors evolve under the selective therapy of bispecific antibody, selecting these mutations that are not found in any newly diagnosed or relapsed patients that are not exposed to anti-BCMA, teclistamab and erlotinib. Interestingly, if you give another antibody, alnuctamab, and more recently, the Regeneron team show also with linvoseltamab, alnuctamab seems to have a different binding properties, and it seems to kill these mutations, at least in cell lines in vitro. So of course, this is to be tested in vivo, but this suggests that the binding site is actually very important to consider when we decide the order and the sequence of our therapy. The key factor that I mentioned at the beginning of this slide is that we see this mutation only in patients that respond 6-9 months after to teclistamab or erlotinib. In this study more recently with Paola Neri and Marius Papadimitriou in my lab, we show that these mutations are most likely acquired, non-selected. So this is an important distinction. If you have something that is selected but pre-existing, You treat the patient, you kill most of the cell except the one that are resistant, the small subclone that then will expand and take the dominance. But if you have that you wipe out most of the cells and then one after some time acquire de novo a new alterations, that's is still a selection, but that will require probably more time and is a very distinct mechanism of evolution. So how we demonstrate this? We first show that using chemotherapy mutational signatures caused by melphalan, so the prior autologous stem cell transplantation exposure, we were able to demonstrate that at least in 4 patients, these events were not present at the time of diagnosis. So at the time of transplant diagnosis, these mutations were not detected, were not acquired that time, they were acquired later on. And then with Paola Neri using digital PCR, we show that in some of these patients, the mutations are yes detectable few weeks or months before the progression, but always within a long time frame and time window where these mutations are undetectable. So we don't know, of course, by 100% that these mutations are acquired, but most likely the majority of these seems to follow that pattern. When it comes to primary refractoriness, so patients that do not respond, so the one that respond to anti-BCMA, teclistamab, and elranatamab are the one that progress with the mutations. The one that do not respond have different mechanisms. One that is well known is extramedullary disease and high tumor burden, but high tumor burden can be, can present in different ways. In this study with Oli Lee and Nizar Balis, we show that high soluble BCMA that can be driven by but either high tumor burden or by distinct genomic alteration that upregulate BCMA specifically, can saturate the antibody, elranatamab and teclistamab, creating a shield or a saturation effect for which the antibody cannot reach the tumor cells because they bind the soluble BCMA. The level that we estimate in vitro was around 500 nanogram for ml, so we apply the same cutoff on the MajesTEC-1 data that were kindly shared by J&J, and you can see the results that most of the patients were refractory except one. So of course, this might be different for other antibodies, as is seen, for example, that linvoseltamab has a higher cutoff due to the higher dose that is given. So these are in the context of bispecific antibody and mostly in responders and high soluble BCMA in refractory. But let's focus more on the refractory, also in the context of CAR-T. So in this study that is still unpublished but is available on bioRxiv, is a large collaboration between Moffitt, MSK, University of Miami, and Calgary. We assemble 3 different cohorts, one treated with CAR-T, 74 patients with whole genome sequencing available at baseline, 26 with whole genome sequencing before bispecific antibody, and 35 patients with targeted MSK DNA sequencing impact. These were all cilta-cel, all 35, while these 74 were a mix of cilta-cel and ida-cel. As always, you find biallelic loss of BCMA, but you only find them in patients priorly exposed to anti-BCMA. In this case, you have 2 patients. They were both exposed to anti-BCMA therapy before getting the CAR-T, like belantamab, and they were both refractory. There was a 3rd patient with a small clone, around 5% of biallelically loss. Again, another patient that was primarily exposed to belantamab, and this patient took 6 months for the clone to expand and progress. When we look at mutations or the genomes of the patients at the time of progression after cilta-cel or ida-cel, what we found is the complete absence of mutation in BCMA and mutation in the extracellular domain of BCMA. So you might see some mutations, but those are usually mutations in the that cause a biallelic loss of BCMA. So like stop coding or that alter the whole protein. So the protein is not expressed anymore. But extracellular mutation, like in the bispecific antibody, were not detected. And this is in line with what reported by Surbisidar and David Kurtz on a larger data set using cell-free DNA, where none of the patients investigated, almost 30 patients, had evidence of these mutations. And this reinforced the idea that while bispecific antibody are continuously given over time, and so the tumor needs to have some sort of antigen escape, the CAR-T selective pressure that induce the selection or the acquisition of this mutation is mostly concentrated in an early phase, and so later on the tumor to progress doesn't need necessarily an antigen escape. 2 years ago, with the multi-center team of different institutions, we proposed a genomic classification for multiple myeloma, identifying more than 130 myeloma genomic defining events. And we identify also a pattern called genomic complexity that is mutually exclusive with the pattern of genomic simplicity. So you can see here, for example, the CyclD1 translocation simple have very few tumor suppressor genes involved. They are enriching RAS genes, but very few copy number, while the complex are very enriched for tumor suppressor gene alteration, deletions, and chromotripsis and other marker of genomic instability. Applying the same exact classification to our training set of 74 patients, you see a clear split in the Kaplan-Meier where the simple genomics have an excellent outcome compared to the complex genomic after CAR-T. And the same was validated on the MSK impact treated only with cilta-cel. When you want to understand a little bit more which genomic drivers are actually involved, not just the pattern of complexity, but specific genes, we combine CAR-T and bispecific together, and then we analyze the two cohorts separately. The set was not so big, but we were able to identify two groups of genomic features that are associated with early progressions and early treatment failure. One group is characterized by genomic alteration associated with genomic instability and complexity, the usual suspect, TP3, ATM, RPL5, CDKN2C. And the second group is associated with a group of genes that are usually not deleted in newly diagnosed myeloma, but tends to be deleted later on due to the selective therapy of, for example, daratumumab in the CD38 case, or XBP1 or Icaros3 for IMiDs. So when you have both these alterations, so one alteration of each group, your outcome is usually pretty terrible, and all patients progress within the first 6 months very quickly. Looking at single-cell RNA data, what we found on 16 patients is that the pattern associated with the primary refractoriness or early relapse within the first 6 months were mostly associated with cell proliferation, genomic instability, like SIN17 signatures and other signatures associated here, DNA repair, but also the downregulation of this A bone marrow plasma cell signature. This is a bone marrow plasma cell signature in normal cells. And so the idea that the resistant tumor to anti-BCMA are the one that downregulate the plasma cell biology or the original plasma cell biology seems to be relevant and in line with what previously reported by Madhav Dudapkar on blood cancer discovery, where he showed that certain myeloma genes are upregulated in the patients that have favorable outcome, which is in line with what we show here. Among the genes that were associated with clinical outcomes, at least the one that showed the strongest association was TP53. Why I'm focusing on TP53? First of all, was quite frequent in our cohort. Second, you can see the clinical outcome was clearly different. Third, if this association was found also if you look only at CAR-T or bispecific separated. And finally, because TP53 is a specific gene, so it's very hard to model 1Q gain in vitro, for example. The 1Q gain in mouse, for example, are different, while TP53 is a gene that we can work with. And in fact, there is a TP53 mouse model recently developed by the Navarra University group, in particular the José Martínez Clement lab and Marta Larrayoz. She presented this mouse at ASH 2024, and in this mouse with TP53 monoallelic loss on a BCL2 background. And then they have another mouse that has the wild type with BCL2 background, which is extremely indolent. It still developed myeloma, but is indolent. And then they have the MYC background with TP53 wild type that is the most aggressive mouse they reported in their first Nature Medicine in 2023. If you look the expression of TP53, you can see that in RNA sequencing and in single cell sequencing that the patient with TP53 monoallelic loss, they all downregulate TP53. And interestingly, they do downregulate also BCMA, similarly to what observed in human. And they downregulate the A bone marrow plasma cell signatures, which is the one associated with clinical outcome. Importantly, after CAR-T, importantly, the TP53 mouse in this analysis was compared to the MYC mouse, which is more aggressive clinically. So the MYC mouse is actually more aggressive TP53, but despite that, it retained the plasma cell biology or its gene expression program, while the TP53 tend to lose it. When you treat the mice with bispecific antibody anti-BCMA, again, thanks to Jose Martinez Clement and Marta Larrayots, you see a clear splitting in a meek mouse. Despite it's more aggressive, the mice that are treated respond much longer than the one with the wild type, while in the TP53 settings, the mice did not respond. And so there is this idea that also in mice, TP53 create a shift in the tumor cells that from a plasma cell network or biology, you shift away from that in something else that we still have to understand, but where these genes are downregulated, including BCMA. As a second validation in animal model, there is another mouse model, as you know, the Vic-Atomic mouse model, which is different from the one developed from Navarra. Recently, Marta Casey, Liedberg Sagel, and Erin Meyer published a blood paper where they tested all these different lines with the bispecific antibody anti-BCMA, similarly to what presented by Jose Martinez Clement. And what you can see here is that some lines are resistant and some lines are sensitive. So that's important to highlight the fact that these resistant lines are not like the one from Jose Martinez that you have TP53, so they all share the same background. In this case, the mice, the Vic-Atomic mice, are spontaneously grow over time. So these mice acquire myeloma over time and through different combination and accumulation of genomic drivers. And what we found is that despite this heterogeneity between these lines, all these lines that were resistant to bispecific antibody showed downregulation of BCMA and showed the exact same enrichment for genomic instability and proliferation and downregulation of plasma cell gene, similarly to what observed in the Navarra mice and in human. And so the summary of what we think are the main mechanisms of resistance for patients treated with anti-BCMA immunotherapy is that you can have a primary refractory or you can have a selection, and the treatment selection can be driven by antigen escape. But this primary refractory group, which unfortunately is the larger group or are the group that we are still failing to achieve incredible results, is a group where we have high proliferation, genomic complexity instability, and loss of plasma cell biology. And because the plasma cell biology is the bulk on which we build all our therapies, from IMiDs to proteasome inhibitor to antibodies against CD38, against SLAMF7, bispecific, they are all targeted plasma cell biology. If a tumor shifts away from the plasma cell biology, all of a sudden we don't have any other therapies other than chemo that we know has limited efficacy. And so we need to better understand these tumors that are probably the real high risk in the immunotherapy era and develop better strategy. This was my last slide. Of course, this is a lot of work that was done in collaboration with multiple institutions and collaborators and friends. Of course, a big thanks to the patients that help us to develop these studies and our funders. And of course, thank you all for your attention. And thanks again for having me today.
Thank you, Dr. Francesca Mora, for your valuable presentation.
Yeah, no problem. I don't know if you have question time now or you just have to move to the next session.
We're running out of time now. Sorry.
All right, no problem. Thank you.
Thank you so much for the presentation.
Bye-bye.
It is now my pleasure to introduce our next speaker, Benjamin Diamond. Dr. Diamond is an assistant professor at the Sylvester Comprehensive Cancer Center in the United States, where his work focuses on genomic approaches to better understand multiple myeloma. Today, he will be speaking on leveraging whole genomes for identifying therapeutic resistance and residual diseases in multiple myeloma. Dr. Diamond, the floor is yours.
Hi guys, just bear with me 1 second while I try to share this. Can you confirm if you see this?
Yes, we can hear you.
And can you see my slides?
Yes.
Okay, so my apologies. I'm not able to share the PowerPoint screen just with this sharing platform, but we can at least look at the PDF. So some of the animations may not work, but I think you guys will get the idea. So thanks for having me. I'm Ben Diamond. I'm an assistant professor at the University of Miami. Nice that you guys got to hear from Francesco Mora. I worked very closely with him when we were together at Sloan Kettering and when he was here at University of Miami as well. And so I similarly work on whole genomes and specifically in multiple myeloma. And so today what I'd like to talk to you guys about is how we can actually use whole genomes to identify therapeutic resistance pathways that are important in the kind of the burgeoning immunotherapy world of multiple myeloma, and then how we can also leverage whole genomes to do a lot of other cool stuff, like identify residual disease, which is also a really important topic in multiple myeloma. So here are my disclosures. So as you guys probably know already, multiple myeloma is a plasma cell neoplasm. It's typically considered incurable, and though, as you've probably heard from multiple speakers so far, that is not for long. It is the second most common hematologic malignancy. And so we have a couple of tasks that I think are probably important for the coming era. And that is that we have extremely effective immunotherapeutics that are emerging. We have T-cell engagers, we have CD38 antibodies. We're about to have tri-specific antibodies in the space. And so the idea then is that while we are still trying to cure the disease, we need to maximize the duration of the responses that we get with immunotherapy. And to that end, we have to prevent antigen escape that tends to develop as we stimulate T cells to attack cell surface antigens over and over and over for long periods of time. So trying to figure out which cells are going to develop antigen escape is going to be of paramount importance. And then, as I mentioned earlier, we want to see if we can maximize the way that we are efficient in trying to identify minimal residual disease. We know this is an approved endpoint for accelerated drug approval. We also know that it is one of the most important prognostic endpoints in multiple myeloma. And then finally, the big limitation is that we still base our MRD assessments on a single site bone marrow biopsy. And as you know, multiple myeloma is an extremely spatially heterogeneous disease. And of course, as we use more and more T-cell redirecting agents, we're seeing more and more extramedullary disease as sort of the holdout site of relapse for multiple myeloma. And so we need to develop a better way of assessing residual disease that's not dependent on assessing the bone marrow. So let's start out by talking about the mechanisms of resistance to anti-CD38 antibodies. So we said earlier that most of our immunotherapy targets are on the cell surface, and we generally will direct immune effector cells to go and attack myeloma cells based on the expression of these targets. So daratumumab and isatuximab, the two commercially available anti-CD38 antibodies, actually do have a variety of mechanisms, and that's because they not only engage CD38 on the surface of plasma cells, but they also hit it on Tregs and also on NK cells. And so in the reports, you'll see a number of different mechanisms of resistance. I mostly want to focus on the genomic mechanisms. And so we know that primary resistance, patients that blow right through these therapies without having a response, these are patients that have genomic instability, chromothripsis, real high amplification with MYC, APOBEC mutagenesis, et cetera. But we're also interested in trying to understand why patients relapse after having long responses. And this is more often due to antigen escape, which is basically here loss of the target of attack on the cell surface, right? So loss of CD38 expression. It's been reported that CD38 expression can be lost transiently, and it actually may return to normal, and that there's selection for cells that are expressing low levels of CD38. But there can also be genomic loss. And as you can imagine, if a loss of CD38 becomes fixed to the genomic scale, that loss is permanent, right? And so that really affects our ability to retreat patients with CD38-directed therapies. Oops, let's see. Sorry, I wasn't expecting that. Give me 1 second. Okay, let me just share this tab instead. My apologies. Not sure why that page wouldn't load, but we can just move on. So I'll just explain what we did here. So what did we do? We were really curious to look at CD38 aberrations following therapy in multiple myeloma. And so in order to study this, we amassed a whole bunch of whole genome sequencing, whole exome sequencing data with a collaboration with multiple different collaborators, including the University of Calgary, University of Heidelberg, Mayo Clinic, and ourselves. And the idea was to see if we could see if there were enrichment for deletions of CD38 following treatment with CD38-directed therapies. And so to that end, we looked primarily in 3 different cohorts, patients that had newly diagnosed multiple myeloma, so patients that you wouldn't think there would be any selection for CD38 aberrations, and patients that had relapsed but not exposed to CD38-directed therapies, so those are patients that are naive, and then also patients that were exposed to CD38-directed therapies and then relapsed. And so what you can see from our findings here were that indeed, these deletions of CD38 were in fact enriched in patients that had exposure to CD38-directed therapy. This is sort of in line with what's been described before, but I want to make the I guess I want to make clear the difference is that because we have whole genome sequencing scale here, we're able to identify things like focal deletions and also biallelic deletions, which are not really able to be seen with things like FISH or with SNP arrays, which were the previous reports. And so we have a lot more resolution to see these events here. And what you can actually see is that the amount of CD38 deletion is pretty frequent. It's about 20% in cases where you've had prior exposure. And then more importantly, we have biallelic events at around 6%, so 3 of the cases here, which show that basically the selection pressure is extremely strong against CD38. In the plot on the right here, you can actually see what the copy number plots look like here to get a sense of the scale of these copy number aberrations. Some of them are basically copy neutral LOHs that involve the entire chromosome, where some are quite focal and involve basically just the gene body of CD38. So I want to show you a couple of these cases to give you a sense of sort of the selection pressures that we're seeing. So unfortunately, the whole slide's not showing up here, but I did want to show you this case where we do have convergent evolution across 2 different sites of extramedullary disease. So in this case, we worked with our colleagues at Calgary University to biopsy 2 different sites of extramedullary disease in the liver of this patient with multiple myeloma. Now, this patient had relapsed following 2 separate exposures to daratumumab. And at the second relapse, we got the whole genome sequencing of both of these sites. Now, it's not showing up here on the screen, but what we did find is that at each of these 2 different sites of disease, you're able to see that there are 2 completely different biallelic losses of CD38 directly in both of these cases. And the interesting thing about that is that the copy number breakpoints, the structural variant breakpoints are different across these 2 actually very anatomically close but distinct sites of disease. And so what this implies is that even across multiple sites of disease throughout the body, we have convergent evolution in the sense that the selection pressure is so long that 2 sites of disease can independently develop the same exact resistance mechanism through the same genomic loss. And so this basically tells us that with ongoing genomic instability, extramedullary sites across the disease are able to converge upon these pathways, right? And why is this important? Because we also had flow cytometry data from this case that also shows us, as you can expect, that CD38 expression is lost. And so trying to treat this patient in the future with anything that targets CD38 is going to be futile. So this also has ramifications for how we're going to treat the disease. Now I'll show you another case. Again, missing some of the expression data here on the bottom, but this is a case from our colleagues at Heidelberg. Interesting case. It was a monoallelic loss that you can see here on the copy number plot of chromosome 4. And on the remaining allele, there are both a frameshift mutation and then also this R140G variant. And so why is this interesting? Because basically we have 2 competing subclones, each with one of these different mutations on the remaining allele. And as you can imagine, this P98 frameshift mutation is going to just abrogate the gene product and disrupt the transcription product prematurely, resulting in non-functional CD38. But then the question is, why is R140G there? Is it being selected? Is it a passenger, or does it actually confer resistance to daratumumab in this case? So here's a summary of some of the other variants that we saw. Now, as we are a dry lab, we obviously have to work with our colleagues who can do functional work to help us validate these things. And so the University of Calgary was able to work with us on this and show us basically that among all the variants that we found, most of them were basically abrogating the binding of CD38 entirely. As you can imagine, right, this S95 nonsense mutation that's going to basically result in non-functional CD38 is not going to be able to bind stock monoclonal antibodies against CD38. And then some of the other mutations we found as well show that you can't bind CD38 anymore. The interesting one was this R140G variant that I had just highlighted before, and that shows that you can still achieve binding with monoclonal antibody, but the binding does seem to be less than you would get for wild type. And the same is true here when you look at DARA versus ISA. The difference is small, but I think you can appreciate that there is about a log less binding of DARA as compared to ISA. And for the record, the way that we did this was to take K562 cells, which are a CML cell line. They don't natively express CD38. And so by doing site-directed mutagenesis of a CD38 plasmid and transducing that into those cells, we can actually achieve expression of, the mutant CD38 that we're interested in studying. So we wanted to look more at the R140G variant. And so what you can see here is that with sequential binding assays at increasing concentrations, you can see that even increasing the concentration of daratumumab is not able to rescue the binding deficits that we're seeing, whereas the binding of isatuximab seems to be stable across multiple different concentrations, as you see in this delta MFI plot here. So then looking at a cell killing assay, where we take these cells and we co-culture them with human monocytes, in the presence of drug, we want to see whether there's still therapeutic effect. And as you can expect, sort of interestingly, we're able to retain the cell killing with isatuximab at varying concentrations. But here with the DARA, you see that even at increasing concentrations, we're just not able to achieve tumor kill. And so I can't show you the 3D model here, but basically what we did find here is that indeed, you can have mutations in the binding site, basically in the epitopes for DARA binding that are conferring resistance to one monoclonal antibody, in this case daratumumab, but not to isatuximab, suggesting that when you develop a mutation following exposure to one of these antibodies, you can in fact switch to another agent in the same class to see if maybe you can rescue response, as you could see with this one variant here. Now again, it's a rare variant and it's a proof of principle. We're only seeing this in maybe 1 out of 50 cases, but the truth is that re-challenging patients with CD38 antibodies is so common that it sort of behooves us to at least try a different product if we are going to switch, because you may in fact be encountering one of these resistance mutations that we can overcome just by switching the product. So overall, biallelic inactivation of CD38 is a recurrent mechanism of resistance. We often see the combinations of biallelic deletion versus deletion plus mutation with a prevalence between 5 and 10% estimated. And we do see commonly in cases of genomic instability that convergent evolution is common. And as we just mentioned, right, so some mutations confer resistance to one antibody and not another. This is similar to the story that we're seeing with the T-cell engagers, how each of these T-cell engagers with different epitopes may have non-overlapping resistance mutations. And so this sort of emphasizes why we really have to be sequencing patients over time, and as we choose new treatments, to make sure that we're choosing the right treatments for the right patients. So now to move on to the next step, I wanted to talk about how we can use whole genomes to advance our MRD assessment in multiple myeloma. Now, I won't belabor the point because we already sort of talked about this, but the idea, again, is that our current assessments underestimate spatial heterogeneity. We know that myeloma has patchy infiltration, and we know that extramedullary disease is obviously undersampled by bone marrow assessment. So I wanted to give you an example to sort of set the stage here. This is a patient of mine that relapsed after just getting quadruplet therapy with tons of extramedullary disease. I mean, this is a patient that you could actually see the scalp lesion just on physical exam. And on MRD, just by flow cytometry, this patient is MRD negative, right? And you only just see it at 10 to the negative 6th with the adaptive clonoSEQ. So clearly, with a patient with florid disease that you can see with your eye, even the bone marrow biopsy can be misleading. So we wanted to see if we could use a technique using whole genome sequencing of cell-free DNA to see if we could come up with a more systemic view of MRD. And so the idea, I think, is worth sort of explaining, right? Because it's a very simple, but also a very elegant concept. And when this paper first came out from Dr. Dan Landau's lab, it basically blew us away, right? So the idea is that if you try to use a targeted panel to try to look at genes of interest in cell-free DNA, the problem is that in an MRD setting, the genes or the genomic elements that you're looking for are sparse. And it's very likely that even if disease is present, you're not going to find representative DNA in the tube of blood that you're looking for. It's like looking for a needle in a haystack, and then maybe the needle's in a different haystack. So the way to get around this is to try to, instead of looking extremely deep, you look broadly. And so if you know a panel of mutations that exist at baseline from baseline whole genome sequencing, say you have 5,000 mutations, then you know what you're looking for. You can take whole genome sequencing of the entire complement of cell-free DNA and look for any reads that support that panel of mutations that you have from baseline. This is basically like a tumor-informed panel, almost like an adaptive clonoSEQ, but you're looking across the genome instead of just at the IGH region. And so the idea then is that you can use 40x whole genome sequencing to be able to look for any reads that support your tumor. And so we decided to see if we could do this for multiple myeloma. The cohort that we used this for was an NIH phase 2 study of carfilzomib, lenalidomide, and dexamethasone with len maintenance for high-risk smoldering myeloma. The reason we chose the study is because the authors, so Dr. Kazanjian and Dr. Langren, they had the foresight to actually collect Streck tubes, which are basically the best tube to do cell-free DNA studies with. They had the foresight to do this even back to 2012 when the study opened. And so they had Streck tubes collected basically at 3-month intervals corresponding to bone marrow MRD assessments at 10 to the negative fifth. And so there's an extremely well-annotated cohort for us to see if this would work. And so what we then did was to try to compare plasma to bone marrow assessment at regular intervals, and then also at times that are corresponding to a few months before disease progression, for example, so that we could see maybe if we could see any changes in the blood prior to detecting them in the bone marrow. And that amounted to 25 patients with 87 total plasma samples. So the first thing that we notice, sorry for the blurry images, is that first we can assess tumor fraction, which is effectively the amount of circulating tumor DNA among the cell-free DNA. And we see that patients that have higher tumor fractions do worse overall, right? So even with intervention with good therapy, these high-risk smoldering patients can still progress. And we see that those patients with high tumor fraction do in fact do worse. We also see that the tumor fraction appears not to be related just to bone marrow infiltration. In other words, it's not related to just tumor burden, but it's also related to disease biology. And it shows that, cases that have high apoBAC mutagenesis, genomic high risk, effectively high cellular proliferation and turnover, these are the cases that are associated with having a high tumor fraction, probably because they're shedding more cell-free DNA. So the next thing that we looked at is to assess the detection limits, how good cell-free DNA whole genome sequencing can be in terms of getting deep limits of detection that might compare with bone marrow. And so in short, the way that we do this is basically by looking at the number of sites that are supported by reads in plasma, and then dividing that by the total number of reads that we checked. And that gives us a detection rate. Then by comparing that detection rate to a panel of basically unrelated plasma samples and looking to see if we can detect the same SNVs in there, that gives us an error rate. So by comparing the detection rates to the error rates that we generate by looking at all unrelated plasma samples, we can use that threshold to come up with a limit of detection. And for us, we selected a specificity level where we're able to reject 95% of all control samples and our actual plasma samples. And so that corresponds to us being able to achieve an LOD of about 10 to the negative fourth, which is a log level higher than what we would normally want for our 10 to the negative fifth threshold that we use for bone marrow. But we also want to see if maybe 10 to the negative fourth in the blood still gives us the information that we need as compared to 10 to the negative fifth in the marrow. And so what we do see, just to give you the idea of concordance, is that we have good concordance for plasma. For positivity in the bone marrow. Only one case that was positive in the bone marrow was missed in the plasma. And then for negative samples in the bone marrow, we actually, it's interesting, we actually had far less concordance here. And it's because we're detecting a lot more positive cases in the plasma than we are detecting in the bone marrow. All right. And so the idea there is that we need to figure out whether those cases are in fact real. Are they true positives in the plasma? Or are they being overcalled? Are they false positives in the plasma? So we did a lot of extensive QC. And I'll just briefly go through it to tell you, why we think these are true. And I'll also show you the clinical histories to show why it also makes sense that these are true calls in the plasma. The first is that we see, even in these discordant cases, we're not really detecting artifactual mutations. We're detecting true myeloma-associated mutations because we see the presence of APOBEC, which is a myeloma-specific mutational signature that you wouldn't really see in B-cell clones or CH or anything else that might produce clonal mutations that are contaminant. And so we truly think that because we're seeing APOBEC, these are real. What we also see is that looking in longitudinal samples, there are very few repeated mutations across longitudinal samples. And that tells us that we're probably not propagating artifact and just calling artifact from sample to sample. The idea being that, because these mutations would be stochastically detected in each plasma sample, you wouldn't really want to see the same mutation appearing multiple times at very low tumor fraction settings. And so we do in fact see that these do not repeat themselves at the MRD time points. And we also see that as we look at the density of tumor supporting reads in increasing tumor fraction settings, we see that these reads appear to be real because, as you may know, fragments of cell-free DNA fragments from tumor-derived origins tend to be shorter than those that are derived from normal tissue. And as you can see here, there's a peak at this sort of 140 to 150 fragment length that we normally see just generally associated with tumor, as opposed to the canonical 167 base pair peak that we see with normal tissue, right? So there are multiple lines of evidence that tell us that these reads are probably real. Now, if we look at the clinical history, you can even see even further why these reads are probably, not false positives, but are actually truly depicting what happens in patients' clinical course. So to give you an idea, here's NIH-008. I put an arrow next to it at the top over here, and what you can see is that at the outset, right after induction therapy, this patient had negativity in the bone marrow, as seen by flow cytometry, but the plasma was still positive for cell-free DNA or for circulating tumor DNA. Now, it took a couple of years, but what you eventually see is that this patient converts to positivity in the bone marrow and retains that positivity in the plasma, suggesting that maybe there was systemic residual disease that was held out that eventually led to conversion later on in time. Now, we see the same thing for, let's say, for NIH-025. Right, in this case, you have a patient who has a positive bone marrow flow cytometry at the outset, and they clearly progress within a few short months of being on therapy. And there are also flanking assessments to this negative marrow here that are also positive, and plasma is persistently positive throughout. And so the suggestion here is that although there is discordance, it is likely the marrow that is the false negative here, and the plasma is reflecting true disease here. And the same thing you can see for NIH-038 again. This patient has negative bone marrow flow cytometry, but positive plasma, but they progress and convert. So again, what we're seeing basically is that despite this higher limit of detection at 10 to the negative fourth, we're getting really good resolution for clinical dynamics that is complementary and can give better resolution to just the bone marrow flow cytometry alone. The very last thing that I want to share with you is that we can also use these for dynamics. What we see then is that as tumor fraction increases in the plasma, I told you we had every 3-month measurements. We can do this before disease progression. We can actually see that preceding disease progression, we have increasing tumor fraction in the plasma, so that we can actually use this in real time without having to do a bone marrow biopsy to see if disease is growing and predicting, further progression for us to potentially do early intervention before we wait for a marrow assessment or wait for, the M spike, et cetera, to reappear on serum testing. So suggesting that this gives us a lot more flexibility and is logistical ease versus doing bone marrow biopsies. So this study is currently in press. Sorry, I should say we just published this last week. So if you're interested, you can read this study in Hemisphere, published just this month. So in summary, we really like this technique of using tumor-informed MRD assessment. This was done with 40x coverage, whole genome sequencing. It has very high concordance with bone marrow positivity, and it seems to give us more resolution in those bone marrow negative cases. Now, for the future, we can and go deeper for limit of detection. So we'll be working on further studies to try different platforms to see if we can achieve deeper thresholds. And we also need to develop tumor uninformed methods, right? So in case we can't get that baseline whole genome sequencing, trying to get a plasma-only MRD assessment will be of paramount importance. So with that, sorry the slides didn't fully work out for you guys, but I hope you got the gist. We obviously have a lot of people that we work with to accomplish all of these things. So I'm not going to name everybody, but big thanks to the Myeloma Institute here, which has made all of this stuff possible, and all of our collaborators. And thank you guys for your attention and patience.
Hello, thanks, Dr. Diamond, for your presentation. And I guess we should move to our next speaker. And our next speaker is Linda Bone from USA. She's a co-director of the Clinical Genomics Lab, clinical cytogenetist and clinical molecular genetist at Medicine and Pathology Lab at Mayo Clinic. And she will represent a clinician guide to FISH in multiple myeloma, interpretation and nomenclature simplified. Dr. Bone, stage is yours.
Hi.
Hello. Hello.
Okay, let me share my slides. Screen. Okay. All right. Hopefully. I'm not sure if this sharing is working. Are you able to see my slides? Are you able to see my slides?
Yeah, we see you. It's perfect. You can start. You can just turn the slideshow regime and start. Yeah.
Okay. Are the slides clear?
Yes.
Okay. Okay, excellent. Well, thank you for having me. So I'm one of the co-directors of the Genomics Laboratory, and my goal is to provide a practical guide to FISH and multiple myeloma, specifically for the interpretation and nomenclature. I will also talk about some of the whole genome and targeted NGS testing that will hopefully be available to clinicians. But for now, I will really focus on FISH. So as most likely the majority of the audience is aware, multiple myeloma does result from acquired primary genomic abnormalities. And the most common are IgH translocations and hyperdiploidy. So IgH translocations can occur to basically some of the common partner genes include CCND1, which is found in about 15 to 20% of myeloma, followed by FGFR3, NSD2, and MAF. Some of the more rare ones include CCND3 and MAFB. Hyperdiploidy, characterized by trisomies of odd number chromosomes, can be found in about 50% of myeloma. In about 10% of cases, they lack one of these recurring abnormalities. Multiple myeloma can also be associated with common secondary abnormalities, and these include MEC rearrangements that I will mention are not easily detectable by FISH, but by whole genome or some of the targeted panels, they can be found in about 30 to 45% of newly diagnosed myeloma. Also, immunoglobulin light chain and kappa, Ig kappa, can also be found. Common copy number abnormalities include deletions of CDKN2C, which is found in about 8 to 12% of newly diagnosed myeloma, and gains of chromosome 1, including the CKS1B gene, is found in about 30 to 40% of myeloma. Probably one of the most common deletions that is of clinical significance involves the TP53 gene, and this is found in about 7 to 10% of newly diagnosed myeloma. In terms of the single nucleotide variants, the gene that is obviously associated with clinical significance includes TP53, and this is found in about 6% of newly diagnosed myeloma. So last year, the IMS-IMWG risk stratification guidelines were published, and I would say that this is probably one of the most significant changes to the previous risk stratification guidelines, in that high-risk myeloma, as previously actually, is defined by TP53 deletion, but now there is the inclusion of TP53 mutation status. Again, this is something that is not able to be detected by FISH. In addition, 1p biallelic deletion, so deletion of the CDKN2C gene, is also considered high risk. In contrast to previous risk stratification guidelines, the abnormalities 414, 1416, 1420 alone are no longer considered high risk. They are considered high risk when they co-occur with either a 1q gain or amplification or a 1p deletion. 1q gain amplification along with 1p deletion is now considered high risk, but 1q gain or amplification alone is not considered high risk. Any abnormality that is not included as high risk is considered standard risk. So consistent with the changes to the IMS-IMWG risk stratification guidelines, the Mayo Clinic MSMART 4.0 classification includes all of those abnormalities with the addition of the plasma cell S phase. And so this is determined by flow cytometry, and when there is an S phase of over 2%, this is now considered a high-risk abnormality, even when it co-occurs in the context of standard risk abnormalities, such as an 1114 or trisomies. One important aspect to the new risk stratification guidelines includes the consideration of the use of whole genome or targeted NGS should now be used to profile the genetic subtype of each myeloma. The reality is that interface FISH is no longer sufficient to fully risk stratify patients with myeloma. And the reasons are because obviously FISH is not able to identify mutations in TP53, and FISH is at a pretty high risk of missing small deletions of 1p involving the CDKN2C gene. So biallelic deletions, while we have seen them in the laboratory by FISH, we are at risk of missing some of the smaller biallelic 1p deletions. So many laboratories are now working to validate a whole genome or panel testing for the use of a diagnostic approach for myeloma. I'm just highlighting one recent publication, but there have been multiple publications that have shown that this can be achieved within a diagnostic setting. So in this specific example from Brian Walker's lab, where they are able to identify all of the recurring cytogenetic abnormalities found in the IMS-IMWG risk stratification guidelines. But in addition, other abnormalities such as ApoBec mutation signatures and also deletions or mutations in genes that confer resistance or sensitivity to various treatments are also included. And this is definitely a value add for the myeloma community. I will point out that in this specific assay, they did report 20% failure rate due to an insufficient number of cells. So there would be potentially a risk of not being able to profile all patients with myeloma. So there are unfortunately few laboratories that currently exist that do offer the whole genome targeted NGS for the ability to detect structural variation, copy number ploidy, and SNV on enriched plasma cells. I was able to identify a few examples, such as potentially ChromoSeq at WashU, and also the commercial entity Predicta that is offering the GenoPredicta. Many academic settings, the assays are really still in development. Clearly, the utility for whole genome and panel testing for myeloma is undeniable. That's for certain. And in the future, FISH will be replaced by sequencing. But the fact that many laboratories don't actually offer this currently, I would like to spend some time to talk about FISH, since it still remains an important diagnostic assay. So in terms of even FISH or whole genome sequencing or panel testing, the need to isolate plasma cells is absolutely critical. And there are 3 general plasma cell isolation assays, and I put this in quotes because the first one really isn't pulling out the plasma cells. It's essentially just enabling a FISH score to really only score those cells that are plasma cells. And so this would be the implementation of a antibody to detect the kappa and lambda light chains. And based on morphology, the cells can be scored that only, or essentially only the plasma cells can be scored in this case. And so you're really only looking at the plasma cells. But most laboratories are implementing a CD138 magnetic enrichment so that you can actually pull the plasma cells. This is probably, again, the most common methodology. Within our laboratory, we actually do employ flow sorting, and this is using CD138, but also combining other markers such as CD38, CD319, and CD229. The difficulty with CD138 is that it is actually a fairly sensitive marker, and it can be shed from the cell surface over a period of time. And so more stable markers such as CD319 or CD229 can be very valuable, especially in a reference laboratory setting. Again, at the risk of sounding very technical, I do want to go over the FISH technology just very rapidly. So after the cells are isolated, they are fixed in methanol and acetic acid and dropped onto glass slides. The glass slides are heated so that the DNA can be denatured, and a fluorescent probe is applied. And obviously, we need to know exactly which area that we're going to target so that we know which fluorescent probe to use. The glass slide is then washed and the cells are scored. And this is a simple example of a BCR-ABL rearrangement where we're looking to see if we have now fusion of the ABL and BCR probe sets. So in the normal setting, you would not have fusion. You would just have 2 red, 2 green. But in an abnormal setting, you would have now the 2 fusion signals and a 1 red and 1 green signal pattern. I will go through some of the common probe types and signal patterns as they relate to multiple myeloma. So again, it's important to understand all of the diagnostic assay limitations and the pros and cons. The advantage with FISH is it doesn't require dividing cells. We're really only looking at interphase. It is a very good technique for identifying low-level clones. So obviously, depending on the number of cells that you're scoring, you can get as low as 1%, and in some cases, even lower than that. To identify the abnormal cell in a population of normal cells. This technology can also be relatively rapid in some cases, such as PML-RARA for a concern for APL. We're able to have same-day turnaround time. Obviously, we're limited to the region that we're interrogating, so we have to have some a priori knowledge. And the limit of resolution is typically the size of the FISH probe, and most commercial FISH probes are about 100 kb. Obviously, the breakpoint definition is imprecise. And if you would like to have a fairly comprehensive genomic analysis, you need to have very large FISH panels. In addition, it tends to be a costly validation, but it is a reimbursable test, and most cytogenetic or genomic laboratories do have the infrastructure to perform and interpret this testing. I do want to point out one other advantage to FISH is that depending on the percentage of plasma cells, the isolation can be a challenge. And so we've shown that even when we have less than 0.1% plasma cell biflow cytometry, 65% of the time we're still able to get an abnormal FISH result. Obviously, that number, the percentage increases as we increase the number of plasma cells. So if we have even a population of cases where we have less than 1% plasma cell, in 81% of the time, we're able to get an abnormal result. I do want to point out that cutoff determination, I've noticed sometimes it can be a little bit confusing, but our cutoffs are not randomly selected. We are actually determining the cutoffs from guidelines from the College of American Pathologists and the American College of Medical Genetics and Genomics. Each of the cutoffs are established in each laboratory, and it's all based on normal reference data. So we would have a collection of samples, and we're scoring the same number of cells that we're aiming to score on the clinical case. And we would essentially determine the number of false positives for each probe set and signal pattern. And we use the inverse beta distribution calculation with 95% confidence to calculate the cutoff for positivity. There are three main types of FISH probes, not just in the context of myeloma, but also in all of the other malignancies that we're really analyzing. So the three types are the break apart, the dual color, dual fusion, and the enumeration FISH probe. The way that we communicate the results are in what we call an ISCN language. And this is the International System for Human Cytogenetic Nomenclature. So all of your FISH reports will be reported in this type of language. And so just to decode this language, and again, I'm making these points because I've noticed conversations on X where there's some confusion about what the language is, and I think it's on us as cytogeneticists to be able to convey this information to the community. So the nuke-ish basically is just saying that we're doing this work on interface FISH. And the number includes the number that are abnormal over the number of cells that were scored. So here, this is in this example, it's 50%. And so this basically, all it says is that we have two copies of, and I'm using the 1114 rearrangement as an example. We have two copies of CCND1 and two copies of IGH. And the CCND1 con IGH, all it says is that there is now a fusion between CCND1 and IGH, and there's only one fusion that's been detected. So now I'm going to just go through a few examples. And here you can see that in this one, we're talking about a break apart FISH probe. In our laboratory, as well as most other cytogenetic laboratories that are evaluating for the context of multiple myeloma, I would say the immunoglobulin heavy chain gene region is the most common break apart FISH probe that we are evaluating. And so what you can appreciate here is that without an IGH rearrangement, here you have basically just two fusion signals. So this would be considered normal. But if you do have any kind of split of an IGH signal, or even if you have a deletion of one of these probe sets, you're going to have an abnormal result. And so here you can see, and again, using the 1114 as the example, you have one fusion, which is representing the normal IGH, the normal chromosome 14, and then you have a split where you have the derivative 14 and the derivative 11. When we say derivative, we're just basically saying this is involved in the 11-14 event. And when it's balanced, then you're going to have both the derivative 14 and the derivative 11. And so one of these IGH signals then hops over to chromosome 11, and you get the split. Again, just following up on the same example of the CCND1 IGH, the dual color dual fusion probe set is a very specific probe set to identify fusion of CCND1 and IGH. In the context of a normal result, you would just have two normal 11s and two normal 14s, and you would have the two red and the two green signals. But if you have again, a balanced 11-14 rearrangement where you have both the derivative 14 and the derivative 11, you're going to be creating two new fusion signals, one from the IGH and one from CCND1. And so in the pattern that you would see, you would have the two fusion, one red and one green. The final probe set is the enumeration probe. And again, you're just using these gene regions as examples for TP53 and the CDKN2C and CKS1B to look for a deletion of 1P and a gain of 1Q. So this is an example of a case that has monosomy 17. Here you're only picking up one green and one red, consistent with a loss of one of the chromosome 17s. In this example, you can see that you have two green signals, which would be associated with two CDKN2C gene regions. And in this case, there is a gain of one of the red signals, and you would then interpret this as a gain of 1Q. So based on discussion or what I've seen on X, there have been some examples where people have been confused about the FISH reports. And again, I think we would take as cytogeneticists somewhat ownership to this, that we're not communicating these results clearly, and we really should. But in this example, the signal pattern here was 3 red and 3 green for P53. And in this case, they happened to use the NF1 gene on 17q11 as their control region. And this would be associated actually with trisomy of chromosome 17 or gains of TP53 and NF1. However, the discussion actually centered around the fact that this result was resulted out as an atypical result, but it was misinterpreted as a TP53 deletion. So because of this confusion, we recently published guidelines for the testing and reporting of cytogenetic results for the risk stratification for myeloma that were intended to be consistent with the new IMS-IMWG risk stratification guidelines. And in our supplemental table, we indicated all of the different common signal patterns that you can get for these various chromosomes and actually provide the interpretation. So if a clinician or even a patient would have interest in this, that this could potentially be helpful to them. So finally, we do, again, while we're waiting for whole genome or panel testing to become more standard of care assays, we did provide a proposed myeloma FISH testing algorithm that could be employed by other cytogenetic laboratories. And we recommended that the most basic panel would include TP53 to look for deletions, as well as 1P for CDKN2C and 1Q for CKS1B, and IGH rearrangement. If, as I mentioned with the IGH break apart probe, if there is a split signal, then the recommendation would be to proceed with reflex testing using the dual color dual fusion probe sets for 14, 1416, 1420, and 1114. And while 1114 itself is not considered high risk, we felt that the inclusion of this in the upfront panel would be helpful for the potential use of BCL2 inhibitor treatments. Again, I will want to be clear, a limitation with FISH is that it does not have the ability to detect TP53 mutations. And so we do make the recommendation that TP53 mutation can be evaluated on enriched plasma cells if resources are available. And actually, I will say that numerous laboratories do have this testing available on enriched plasma cells. Again, there is a risk of missing the CDKN2C biallelic deletions by FISH. I mentioned that we are able to detect some of them in the laboratory. The exact percentage of how many we're missing is unclear, but hopefully we'll have those data soon. But that would be something that would require sequencing. So in summary, we hope that whole genome or panel testing will be the standard of care assay in the evaluation of patients with myeloma. But until then, FISH does remain the most common testing modality to identify the IMWG-IMS risk stratification markers. And the use of NGS for the evaluation of TP53 really should be considered, particularly for cases that do not have a TP53 deletion. And again, this should be done on enriched plasma cells. And we did assemble what we felt would be like a best practices for testing or reporting of FISH for myeloma. And finally, I want to acknowledge all of the other cytogeneticists, including many of the clinicians that have helped with this effort. And thank you again for your attention.
Awesome. Thanks, Dr. Bone, for your presentation.
Yes.
Thank you
Thank
so
you.
much. Thank you. And now we will go to a short break and return after a few minutes. Thank you all. Hello again, everyone. We continue our virtual Global Congress Myelo 26. And let me introduce our next speaker, Ansh Mehta from USA. He's a clinical assistant professor in the University of Florida, College of Medicine, Division of Hematology and Oncology. And he will represent the role of measurable residual disease in the escalation or de-escalation of therapy in myeloma.
Hello. Hi, can you hear me? Okay. All right. Are you able to see the screen? Okay, good. All right. So thank you for the introduction. My name is Ansh Mehta. I am assistant professor and research lead at the DSG and work at the University of Florida. So like we mentioned, the topic today is measurable residual disease in multiple myeloma, escalation and de-escalation of therapy. And so measurable residual disease has been evolving as the technology evolves and develops in myeloma to detect higher and higher sensitivity and detect myeloma cells with higher and higher sensitivity, right? Initially, we just were looking at the bone marrow biopsy with microscopy, and today we have not just flow cytometry, but a next generation flow, which is like Euroflow, which can detect 1 in 100,000, 1 in 1 million myeloma cells. So before we go into the details of how measurable residual disease can be helpful in escalation and de-escalation therapy, let me just go back and revise a little bit on what measurable residual disease methods we are frequently using in clinical trials and in clinical practice. Yes, the most frequently used measurable residual disease techniques are bone marrow biopsy-based measurable residual techniques, and most frequently we have next generation flow or next generation sequencing, and both of them are actually based on bone marrow evaluation. The standardization is through Euroflow, which is next generation flow, which is 12 color flow, and a clonoSEQ. clonoSEQ is test developed where we actually have we look at the first bone marrow biopsy that the patient had and evaluate their myeloma cells and find this genetic ID sequence and follow that ID sequence in subsequent bone marrow biopsies. So obviously in next generation flow, evaluation is not required at diagnosis. So there is no ID requirement in next generation flow. We don't need to follow that ID. Whereas because of this ID requirement in next generation sequencing based methods, we need the initial bone marrow biopsy with plenty of plasma cells that are cancerous, and then we can follow that sequence. So it becomes some of the trade-off of using next generation sequencing. Do you need a fresh sample for flow? Yes, you need a fresh sample for flow for viability of cells and make sure that they are still viable by the time you're performing the flow. Whereas in next generation sequencing, that may not be necessary. You have an old bone marrow biopsy, you can send to clonoSEQ, adaptive technology company, and then we can talk, and then they can take it from there basically. Is the cost is a little bit more expensive on next generation sequencing, whereas next generation flow is not that expensive. Applicability is almost universal for next generation flow because that's available widely, whereas next generation sequence is more centralized and is actually done by one company, and about and most of the patients actually, most of the samples actually go there. It kind of helps in some ways because it standardizes the process, whereas in next generation flow has a different advantage. Sensitivity, what we discussed, 10⁻⁵ to 10⁻⁶. And next generation sequencing, on the other hand, has higher sensitivity consistently in 10⁻⁶. In addition to the bone marrow evaluation part, we also have whole body imaging part, and that's PET-CT scan, whole body MRI. Both of these do not require bone marrow evaluation, but both of these are somewhat included in some of the trials that evaluate MRD status in myeloma because bone marrow is not everything that myeloma is all about. There are extramedullary disease, and we need to have high sensitive methods to exclude extramedullary disease, and that's the goal of PET-CT and whole body MRI here. Are they both standardized? Yes, they are both standardized, and evaluation is recorded diagnosis, not really, and we have this cost, applicability, sensitivity analysis here, whole body MRI being a little bit more sensitive than the PET-CT scan. So these are the current methods of testing MRD. Now, in the IMWG response criteria, which have evolved over time in myeloma, MRD negativity is now being included, right? IMWG MRD criteria obviously requires a complete response, and then we go ahead and evaluate whether there is MRD, measurable residual disease negativity, or not. Flow MRD negative, like I talked about, if it's negative by next generation flow, that's flow MRD negative. Sequencing MRD negative is the MRD status that's negative with next generation sequencing, which we also a little bit discussed that method already. A sustained MRD negative is something new on this slide, which means MRD negativity at the marrow by imaging, but also confirmed with minimum 1 year apart. So there is one MRD negative evaluation, and then after 1 year we do the exact same test, and it's again MRD negative. And as we talk about it in the next slides, it becomes actually one of the most important things in prognostication and also therapy decision making. So that is a new thing that's been included in IMWG MRD criteria. And imaging plus MRD negative, which is basically the same thing like discussed last slide, is MRD negativity in the bone marrow, along with those important imaging techniques that we discussed. Now, there are some other MRD techniques that we haven't talked about on the slides, which include mass spectrometry. Mass spectrometry is a highly sensitive method to detect abnormal monoclonal protein in the peripheral blood, and it is somewhat on a clinical investigation stage as far as myeloma is concerned. While there are some clinical decision making that are happening in academic centers based on that test, I wouldn't get into too much detail about it in this slide and in this presentation. Now, before I go into next slides with therapy decision making, I would like to let you know that I don't have any consulting or advisory roles or any other significant competing interests with any of the pharmaceutical companies that we are going to discuss. So let's talk about MRD negativity and the prognosis first, right? There is this large meta-analysis that was published in Blood Advances that looked at how MRD negativity can change or can determine the overall outcome of myeloma patients. And this evaluated quite a few publications. There were 93 publications or 8,000 patients. So it is a really large study that looked at multiple things and multiple different aspects of multiple different studies and looked at one important critical question: whether newly diagnosed multiple myeloma patients and relapsed refractory multiple myeloma patients, whether they are MRD positive or negative, does it change overall prognosis? Of course, there are some disadvantages of or I would say pitfalls of this study, because there are multiple studies involved, there are multiple methods of treating myeloma. So all of these are confounding factors. But looking at overall picture, you could see that the MRD negativity, which is right here, as represented by the blue, brown, and the green lines, overall is determining quite an improved progression-free survival in the 70s and in one case 51%. Long-term PFS compared to when the patients are actually MRD positive. And this is actually true in patients who have relapsed refractory myeloma, who have newly diagnosed transplant eligible or ineligible. It is kind of true across the board. One thing it's interesting to note is if you see the MRD sensitivity threshold, you will notice that 10⁻⁻⁴, 10⁻⁻⁵, 10⁻⁻⁶. As the MRD sensitivity deepens, and as we know the response is actually deeper and deeper, the PFS benefit is actually increasing, at least based on this analysis. Although it wasn't compared, head to head, we kind of gleaned that from the meta-analysis. Now, I'll start with a case so that we get an idea about the current data and where this MRD-based therapeutic decision-making and therapeutic refinement actually takes place. So we talked with a case about 70-year-old male patient with IgG kappa, standard risk, multiple myeloma, underwent 4 cycles of DARA-KRD, daracalfism and Revdex, has residual disease on NGS, that is the clonoSEQ test, and is positive. He then undergoes melphalan auto transplant. Post-transplant marrow shows no residual plasma cell clones with the clonoSEQ test. And then he goes on to receive an consolidation DARA-KRD, followed by 1 year of Rev maintenance. Now, so he's had another repeat marrow. So that's persistent MRD negativity. So that's sustained MRD negativity. If we go back a couple of slides before, sustained MRD negative based on IMWG criteria, which is 1 year apart, 2 bone marrow biopsies, and they are both negative. One thing I think important to note is that we also perform a PET scan on these patients, and that was also negative, right, in both of these settings. He never had any extramedullary disease. Or and so he is sustained MRD negative and is on Revlimid now. Now, the discussion is about like what is the benefit of continuing Revlimid further, and what are the risks associated with continuing Revlimid further, and and this is the question we will talk about a little bit more and go into the evidence for. And so going back a little bit, trials that established lane maintenance as standard of care, they were older trials and they did not have frontline quad as the induction regimen, right? Today, we use DARA-KRD and DARA-RVD as frontline therapies, which are 4 different highly efficacious medications for multiple myeloma. And that didn't used to be the case with CALGB 10104, IFM 2005, Palumbo 2014, and myeloma 11. And so that's, but those are the trials that established lane maintenance and highlighted its role in increased PFS and perhaps even in survival in patients who are receiving line maintenance versus who didn't. Now, older trials, like I said, didn't use quads, but look at the newer trials, right? Newer trials, Cassiopeia, Griffin, Perseus, Master, and Ischia. All of these, trials have quads, is ELO or DARA-KRD or DARA-VRD, ISA-VRD, ISA-KRD, all of these trials. And you can look at the MRD negativity rates. It's phenomenal, right? MRD 10⁻⁻5 negativity is almost 60%, 50-60% across the board. And then we have MRD 10⁻⁶, a little bit less on the less side, but still 50-60% going in the 40s in some of the trials. So, and some of the trials are not evaluable because they didn't have the same level of sensitivity when testing for MRD. But as you can see, many of these patients, more than half of these patients are achieving MRD negativity with quad regimen. And the estimated PFS, 4-year PFS, and we are talking about 4-year PFS, it's almost 70-80% in almost all of these studies. So let me talk to you about one of the important study that brings that comes into light, especially when talking about deep remissions and maintenance therapy, discontinuation maintenance therapy. And you could see about this study, which just really mastered the art of MRD, and that's called the master trial, right? And you could see the induction regimen and the schema is DARA-KRD. Sorry. Okay, I don't know. So DARA-KRD 4 cycles of induction, and then there was MRD assessment by clonoSEQ, and then followed by consolidation with auto transplant, or KRD 4 cycles, and then if there is MRD negativity, then the patients basically went into observation. Now, if there was MRD positive, then they again went into DARA-KRD for 4 cycles, and then again were put in observation if they were MRD negative. So and then it goes on, right? And then it's in the observation phase, once the confirmed MRD negativity, you have observation every 24 weeks. You do another clonoSEQ and see, if there is persistent MRD negativity. Now, if there becomes MRD positive, then they go into land maintenance. So we are evaluating MRD at literally every point in myeloma treatment schema here. And one of the interesting findings that comes out of this study is this. And in the long-term setting, what happens is patients who have had high-risk cytogenetic abnormalities actually tend to do poorly when when we are stopping treatment once they become MRD negative, compared to those who have just 1 or 0 high-risk cytogenetic abnormality. So if they are 0 or 1, you could see the progression-free survival is almost 60%, 80, 70, 80%. Whereas if you have 2 high-risk cytogenetic abnormalities, then it becomes much worse. So, kind of giving an idea that MRD negativity, right, after, say, for example, this regimen, when we induced, did MRD assessment and then went on maintenance, and basically had observation period and not really have land maintenance, it may be beneficial for standard risk patients, but not so much for patients who have had 2 or more high-risk cytogenetic abnormalities. And MRD, by the way, in this study was 10 raised to minus 5, right? So it wasn't the super sensitive 10 raised to minus 6, but it was at least 10 raised to minus 5. So, and then let me talk about another trial, and that's MRD to stop trial, where the inclusion criteria was the patients with myeloma who've had a complete response for about 2 years, or are MRD and or are MRD negative at 10 raised to minus 5, are PET negative, and they've had 1 year of maintenance therapy, right? So these are basically, simply put, 1 year maintenance, at least 1 year maintenance therapy patients who are MRD negative, right? And now once they are, and then when we basically did another MRD assessment before registering them on a trial, PET-CT negative, then we basically discontinue maintenance, and then we follow them, and every year with an MRD assessment. And in the other side, if they become MRD positive, then we continue maintenance and put them off the protocol, right? So it's kind of a single-arm trial where we are following patients who are MRD negative, have maintenance for about a year, and seeing what happens when they are not getting land maintenance. And there is an exploratory endpoint that is MRD negativity 10 raised to minus 7. What it involves a complicated process of enrichment of plasma cells before sending it for clonoSEQ, and that gives even more sensitivity. So it's kind of an interesting endpoint, and they're going to look at it in this trial as an exploratory endpoint and not really primary endpoint. Now let's so what happens is that MRD free survival, which is MRDFS, in these patients is about 60% at 24 or 30 months, which is quite impressive. And if you think about progression-free survival, which is what we have been talking about in most of the trials these days, it's actually almost 80%. So only 20% of patients who did not take land maintenance and were MRD negative and took only for about 1 year of land maintenance did actually quite well without progressing for about 36 months, right? 80% of the patients. Now, if the exploratory endpoint actually was very interesting result. If it's 10 raised to minus 7 negativity, and you could look at the PFS curves with 10 raised to minus 7, which is the blue line here, it's almost flat. It's like even more than that. It's like, it's not just 80% PFS, it's more than 80%. It's 90, almost going 90% of PFS at about 36 months. So quite impressive results, especially with 10 raised to minus 7. And this is another slide of how the cumulative incidence of progression, and you could see the incident progression is much, much less common if you have a 10 raised to minus 7 MRD negativity. Looking at some of the other trials that looked at kind of the same question, we talked about the master trial. We looked at data KRD 4 cycles, ASTCT, that is transplant, and up to eight cycles of data KRD, and patients basically had 36 months PFS was quite impressive at 73%. We talked about the MRDs to stop trial. There are other few trials where IFM 2009 maintenance cessation after 1 year of maintenance land for both the arms actually still had 4-year PFS of 75% in MRD negative patients. And there are some other trials. So basically, which kind of supported the other trials. So basically, if after 1 year of maintenance in MRD negative setting, sustained MRD negativity after 1 year of maintenance, it appears that about 80% of patients have really long-term remission. And let's talk about the other question, right? The other question is, what is the risk with secondary primary malignancies with LEN maintenance? So that's what this patient is worried about. And we talk about this. This is a table that I've pictured from the determination trial supplements, and you can look at the determination trial which evaluated for RVD versus RVD and early transplant. We could look at it and see, there are about 10% of these patients have gotten secondary primary malignancy, of variety of secondary primary malignancy. And on the next half of the slide, you could see the results from a retrospective MD Anderson experience that suggested that longer LEN maintenance significantly increases the risk of secondary primary malignancy, which is SPM. So patients who have had SPM receive LEN maintenance for a longer duration. So if you think about it, if they did subgroup analysis where they looked at it for patients who received a maintenance of about greater than 1 year, the odds ratio was 1.59, which is not achieving significance, but almost achieving significance. But for patients who received 2 years of maintenance, the odds ratio was actually even higher. So there is some data which suggests that shorter LEN may actually reduce the risk or is at least associated with the reduction of risk in development of secondary primary malignancy. So what we do for this patient is stop maintenance LEN and remains on in observation and with 10⁻⁶ MRD negativity 2 years post discontinuation. Let me talk about another question, right, which MRD is being used for. A question that is sort of still not, the data is not as mature as the maintenance data is, which we talked about, but it's still an emerging data in this question that suggests MRD can be used. Is in this patient, say for an example patient of 69-year-old woman with standard risk, newly diagnosed IgG-kappa multiple myeloma, receives ISA-KRD induction. After 6 cycles, her M protein is unmeasurable, PET-CT is negative, bone marrow NGS is negative, stem cells are collected, but given standard risk biology, deep early response, she's being evaluated for autologous transplant. She's fit for autologous transplant, but what is the risk-benefit ratio in the context of this early MRD negativity with ISA-KRD? And this is right in the heart of this trial called MIDAS trial. And in this trial, they evaluated ISA-KRD, the patients who have received ISA-KRD 6 cycles. And then based on the MRD, we stratified them into 2 different randomizations. If they are MRD, if they are MRD negative and standard risk, they are put into this arm where they would go to ISA-KRD 6 cycles and then have LEN maintenance. Whereas if they are, or they will be randomized to transplant and ISA-KRD 2 cycles and then LEN maintenance. So evaluating transplant in standard risk group in MRD negative setting. Whereas in MRD positive patients, then they will undergo either a tandem transplant or a transplant with ISA-KRD of 2 cycles and then ISA-iberdomide maintenance. Now our question is about this particular arm of the study, and that's what we will talk about, right? So you could see that MRD negativity at 10⁻⁶ sensitivity, how you could see the ISA-KRD arm, which is basically this arm A, is 76% after induction, right? That's just quite impressive. 73% for the transplant arm, which ends up getting transplant. But you could see the conversion rate, 73% only going to 86% with transplant, whereas this with ISA-KRD arm, 76% of patients, then 84% before maintenance. So let's talk about this in the context here. So the patients who went to arm A, ISA-KRD induction, patients who went to arm A actually had 76% MRD negativity before they went into just after induction. And then before maintenance, which is this area, their negativity increased to 84%. Whereas in transplant patients, this area, which is just after transplant, their negativity increased to 86%, 84, 86. It's very similar, right? And this is what it talks about in this slide, that the transplant patients, were from after induction really, didn't really change a whole lot in terms of the MRD negativity rate after getting it auto transplanted. So and then there is this analysis of MRD negative status before maintenance, right? At transplant ISA-KRD, and you could see the risk is really there isn't much difference in terms of how the transplant benefited these patients in conversion. So that's it's conversion to MRD negativity and sustained MRD. So but the main question here though is that is there going to be long-term relapse-free survival or PFS benefit with transplant or not? And that question kind of remains open. Now, and there is this subgroup analysis where effect of transplant versus ISA-KRD consolidation on MRD negativity rate, and it's right here. And you could see the MRD post-induction setting, right? If they're MRD post-induction positive, sorry, no, not this. If you look at if they're high-risk cytogenetics, you could see that it is actually favoring arm B, but it's still not crossing the midline, and therefore we cannot say it conclusively. But you could see the difference, and there is some difference in these triads. So arm B is right here, just to get you this is this arm. Arm B favors arm B, which is favors transplant, versus favors arm A, which is the ISA-KRD consolidation. So I'm not too sure if I could say that high-risk cytogenetics does not benefit from transplant, even despite MRD negativity. But for patients who are standard risk, if they are MRD negative after induction, they may actually be able to safely defer transplant, at least based on current data. And we are still awaiting the long-term data. And Manhattan trial kind of talks about the same thing, but it was done at MSK. It doesn't directly address the question of transplant, but these were the patients who got data KRD 8 cycles. And if they were having response, they got another 8 cycles of data KRD. And you could see, like, in the schema, in the grand scheme of things of what happened with these patients. So after 5 cycles of data KRD, they become MRD negative, which is the dark green, and there is sustained MRD negativity for a lot of these patients. And patients who actually ended up getting transplanted, a few of those here didn't really have a much better outcome, at least right now, or MRD conversion, so to speak, in this trial. And this is not this is not addressing the question of transplant, but it kind of gives an idea about how the transplant benefited these patients, or what are the pitfalls of it. And just talking about how in the interest of time, I would probably not go into details of this slide, but Perseus trial and GMMG HD7 had a similar MRD negativity just after induction, and not much conversion or benefit in sustained MRD negativity after getting transplant. So going back to the question, this 69-year-old standard risk newly diagnosed myeloma patient who is transplant eligible, I think if the patient is standard risk, which this patient is, we may be able to omit transplant. However, the long-term data are unclear, but it seems that they would likely be favorable. Whereas in high-risk disease, early signal from MIDAS is, I think, indicating that there is a possible higher risk of relapse and reduced PFS in patients who omit transplant. So those patients, I would probably have them undergo autologous transplant. So those are the two important questions in MRD. And there are more and more trials coming out with MRD status. And in the interest of time, we will not be discussing all the possible implications of therapeutic implications and treatment refinements in myeloma with MRD status. But I think these are the two important ones that I discussed today. Thank you so much. And I'm here open to questions.
Okay. Thanks, Dr. Mehta, for your presentation.
Thank you.
Thank you so much. Thanks.
Yeah, thank you.
And now we will go on short break and return after a few minutes. Stay with us. Thank you all.
My name is Jenny Alstrom, and I am a multiple myeloma patient and CEO My name is Jenny Alstrom, and I am a multiple myeloma patient and CEO and founder of HealthTree Foundation. Thank you for the opportunity to share our story. I'm delighted to share a tech-forward approach to faster cancer cures by giving patients the tools they need to become active and valuable contributors to research. I'd love to share how we've done that by first building trust with the patient community, building an exciting data portal for patients where they can connect their EHR records into a single patient health record, and creating tools for researchers to use that data to develop new hypotheses and insights while using AI every step of the way. We believe that together we care and together we cure. We provide education, community, and research support for blood cancer patients. We started in multiple myeloma, expanded to lymphoma, leukemia, and MPNs, and in 2026, look forward to launching new programs in solid tumors. As I said, I'm a multiple myeloma patient. I was diagnosed in 2010, and I'm the HealthTree founder and CEO. We started the foundation in 2012. And at the time I was diagnosed, I was very young for my diagnosis. I was 43, and I was happily married with 6 children, ages 3 to 15. I started therapy by doing tandem stem cell transplants. And then when I relapsed almost 10 years later, I did CAR T therapy and am about 4.5 years out from that and continue to be MRD negative. So I've had a great outcome, and I've been blessed to work on this foundation and provide support services and a really new approach to research because of that blessing. We believe that information is very empowering for patients. So we provide a vast array of educational programs like guided webinars, online video courses, live events, podcasts, specialist directories, and personalized support tools based on the patient's data. We also know that community brings comfort. We provide social media condition-specific discussion groups. We have one-on-one peer coaching. We have over 300 coaches that provide one-on-one support and mentoring for other patients and caregivers. We have regional volunteer groups who help spread the word about what we have to offer. We have interactive live programs where we reach out into the community and invite patients to come and get to know one another. And we have Black community support. We also provide tools for patients to take control of their own outcomes. We want to empower patients with as much information as possible so they can get their best outcome and they can work with you as physicians, but in a really educated way. So we provide tools that enable patients to track their labs, find treatment options, explore clinical trials, find side effect solutions, match with their cancer twins, and stay organized with a personalized health dashboard. Now, we know that patients can advance cures together with the research community. So we invite patients to put their data to work. Instead of just having it sit in their MyChart or their EHR somewhere, they likely have multiple EHRs that can be tied together to aggregate their data into a single location. Now, with that data in their location, the data is anonymized, it's secure, and it's entirely under the patient's control. The patients own their data. We know that we can then allow approved researchers to securely access that data to drive faster cures, develop new hypotheses, and then work with the patients on research projects together. We invite patients to contribute to surveys and studies. They do so very regularly, and they are very happy to give back. Together we care, and together we cure. We know that patient trust is the foundation of everything that we do. So as we build our programming, we want to ensure that it is a trusted, valid resource. With that trust, we want patients and providers to support data-driven decisions and services. So we provide an electronic health record integrated patient data portal We invite patients to connect their medical records from one or multiple facilities into a single patient health record. We, in fact, have integrations with over 7,900 hospitals across the United States with our FHIR-related connections to Epic, Cerner, the VA, CareSpace, and we're working on our Navigating Care. That represents about 80% of all EHR systems across the United States. Now, with those records connections and founded on that layer of trust with patients, now we can provide services back to the patients and to the researchers. On the patient side, the patient now has all of their data stored in one place. We validate that data and we even add additional variables to that, like lines of therapy or clinical outcome data. So we can match patients to personalized clinical trials in minutes instead of a long slog to try to get through clinicaltrials.gov, which just does not work for patients. So we can provide those clinical trials to patients in minutes and matched against all of the eligibility criteria that are there. We can also show them personalized treatment options. We can help them track their labs. We can provide a conversational AI agent to help them understand their medical records. We can also provide a personalized dashboard so they can keep track of everything, and things like finding their twins or side effect solutions. There are many personalized services that we can offer to patients because we better understand their situation, whether they're newly diagnosed or relapsed and refractory patients. On the researcher side, we can provide services to the researchers. We can provide that data cleaning and validation service on the data. So instead of trying to do a research project every single time and putting the data in a REDCap database that's validated that one time, it's validated once and can be repeated with different research type work. That is, then the data is really research grade ready. We can promote surveys and studies and host those on our platform and build those in partnership with the researchers for these diseases so they can better understand the patient experience and connect directly with patients. We can be a data vendor. We have done this for several academic centers, and we can act as a data vendor because our technology is pulling that data together. So if you can imagine a distributed study or a survey, that's not a problem for us. We can reach outside of a single academic center to put all that together and do cross-national studies and surveys. We can provide data access to this data to the researchers, and we can use AI, and we're starting to do that to build data analytics tools and predictive models using AI on the data. We can also add in tissue sample type data like whole genome sequencing or bone marrow slides or other things like that to the data set to add tissue sample type data with clinical data. I'm going to be sharing results that we've achieved in the multiple myeloma space because this is where we started. We've performed over 250 surveys and studies and published on those results at major academic meetings and in publications in partnership with over 150 research investigators. We've had over 124,000 patient participations. Now that does represent patients that have participated in more than one of our programs. Our recruitment time is quick because we built the relationship with the patient community and they know we're going to come back to them over and over again to ask them survey questions or participate in different projects. They know we're coming. So it's 6 to 8 weeks on average recruitment time, depending on the topic or the subset of patient that you're looking for. And we have those results completed in 9 to 18 months on average. We have collected over 80 million data points on patients. As an example, we perform studies and surveys like this on a regular basis. This one in particular is a bispecific antibody study, inviting patients who have received bispecific antibodies to better understand their care experience, their caregiver experience, And so we invite them to not only connect their medical records, but to complete many survey questions to ask about that experience. And then we combine that data together to provide that with the oversight and participation of myeloma experts in the field. This is a study that's an example of tissue samples combined with clinical data. So we invite patients to sign a consent. We go and get the original blocks of the bone marrow slide, original bone marrow slides, from the facility where the patient has had an initiating bone marrow sample. And then we take that and we send it to the University of Miami, and they run genomic profiling on that sample. Now we can combine the genetic profiling data with the clinical data that we have that the patient has consented to. And this group is building a computational model based on those outcomes. So now they can see, compared to the genetics that that individual patient has across different treatments that those patients have received, to really identify the best possible treatment options for newly diagnosed myeloma patients. We think this is one of the most important things we could be working on with this data, and patients are delighted to participate. Now, as an example of the research that we have performed, you can scan this QR code. This is a link to our new Care and Cure magazine that we came out with in September of 2025. And this is a showcase of the research projects that we have done. Now I'd like to show you a demo of this system. This is the health tree system. So when a patient logs in, this is my account, and you can see that if I want to connect my medical records, I click here. You can see that I've been to several different treatment facilities, but if I want to add a new connection, I search for that connection, and I try to find my facility. This is where our integrations take place. So I select Huntsman Cancer Institute. I continue. And what it's doing is it's taking me to my actual MyChart portal. So I log in with my portal, and it tells me HealthTree will and won't do certain things with my data. The patient can uncheck things they don't want to share, and then the patient selects how long they want to share. So now what this is doing is connecting my medical records for the past 16 years with the HealthTree system. It will stay connected to that system. And if the connection breaks for any reason, the patient can go in and sync the system again. So now you can see that I have these, and now I'll go into track my disease. If I want to track my labs, for example, I can go in and see a view of all of my labs in chart form over the last 16 years. So if I take a look at my monoclonal protein, which is what I'm looking at to track my multiple myeloma, I can see that it started high and went down over time. I can see values. If I click on this, I can see a little more detail about it. And I can see things in either chart form or graph form. And here's the chart form. So you can see that I have multiple iterations of this data. I can also see my treatment history. And we have created, as I mentioned, lines of therapy as some new derived variables from the data. So we have a medical team that will go in and clean and validate each patient's profile so that the lines of therapy are validated, the genetics are validated. We are using AI on this to extract lines of therapy from the chart and extract information about observations and outcome data from the chart to make that validation process easier. A manual review per patient might take 9 hours, and an AI-enabled version is cutting that time more than in half. We hope to get that time down to just minutes, but we're busy training the models in order to do that. You can see that I also have a list of my genetics. So we can include genetic testing like FISH testing, next generation sequencing testing, MRD testing, and that can all be part of my genetics section. So you can see some of that. Now, this can include imaging, which is relevant in myeloma as well. It can pull the diagnosis from my chart. And then I have a set of questions that I can answer that we call a full health profile. And that's over 230 demographic kinds of questions, social determinants kinds of questions. Now, with that data, because I have that data completed, now I can do certain things like I can see treatment options that might be FDA approved. I can find clinical trials that I match against. So this is what I mentioned as one of the personalized services that we can offer to patients. So what it's doing in the background is it's matching all of my inclusion criteria, my creatinine level, my platelet count, my prior lines of therapy against all the possible studies that are open on clinicaltrials.gov. Now, if I did this manually as a patient, it would probably take me, even if I knew where to look for all my labs, it would probably take me about an hour per clinical trial. And there are over 500 clinical trials in multiple myeloma. So I can choose trials. If I were in remission, I would see a certain list of trials that I might be eligible to join, but I don't have excellent matches because I'm in remission and there are not a lot of trials open for me right now. But if I relapsed, you can see that I might select an excellent match, and I can tell it's an excellent match because I fit all the inclusion criteria for this. So you can see the locations where the trial is recruiting. You can see what drugs are being included in the intervention, study information. And if I want to join this, we have a set of patient navigators, and I can click begin now, and that will transfer me to one of our patient navigators who knows how to help me get into an actual trial at a treatment center. Similarly, I can see all of my treatment options that are FDA approved. So if I've had 3 lines of therapy, for example, it will show me all the FDA approved products that I could select or use potentially. So let's say I wanted to take a look at one of these and I wanted to look at talquetamab. I could see based on the clinical trial, the label, the FDA label, how it was approved. I can expand this to understand the outcome data from that clinical trial, and I can expand to see side effects grade 3 or higher from the clinical trial. So now I'm making a more educated decision as a patient with what I might want to consider and take that data to my doctor and have a conversation about that. We had a patient who was on a triplet therapy in multiple myeloma, and they saw the data out of the quad therapies and were armed with the right information to be able to go have a conversation with their doctor about why they might want to include an extra maybe CD38 monoclonal antibody to their treatment. We also have tools to crowdsource side effect solutions from the patient community and to match to their twins. But what I'll show you here is how we accelerate research. This is where patients join surveys and studies on our platform. And as you can see, we have several open surveys. We have completed surveys over here, and I've completed many of these. But as an example, we work with investigators, and they will help. We can do the whole process, basically, from question creation to review by an expert advisory board, review by a patient advisory board, marketing of the survey and study, aggregation of the data, because patients are now joining this and answering these questions, and then the data aggregation on the back end and the publication. So we can do all of those pieces in partnership with experts in blood cancers. In blood cancers currently, and hopefully additional diseases later on. So this is how we engage patients. They are generous with their data. They're generous with their time in helping to accelerate research. And we're just thrilled that they are willing and able to do it. This is the first time that patients have been equipped with the right tools and the right technologies to be able to be actively contributing members to research in addition to clinical trial participation. Now, we know how important clinical trial participation is for patients, whether they're newly diagnosed or relapse refractory or even with precursor conditions. And we know that's how science advances. But science can advance in so many new and different ways with technologies. We are using all of the technologies. And recently, we were very proud to have been one of 20 apps to be selected in the MVP, which is the minimal viable product of CMS, so Center for Medicaid Services, in a program they call Kill the Clipboard. And Kill the Clipboard, the vision of that is to be able to have a patient come to the hospital with their phone and be able to select what data they want to share from their medical records with the facility so that that data never needs to be faxed again. And having that be possible is just a breakthrough in technology. And because we're so leading edge on the tech in patient data, we were able to participate in that. And I'm very proud of that opportunity. I want to thank you so much for watching. We're excited to bring our tools and services to a larger cancer community over the next few years. We're all in this together because with you, together we care and together we cure. And with that, we appreciate you so much.
Hello, everybody. Can you hear me? Just want to make sure everybody hear me. Okay, excellent. Thank you very much for OncoDaily to invite me today to talk about a very important subject. So my name is Dr. Alola Abdallah. I'm one of the associate professor at Kansas University Medical Center and the director of the Plasma Cell Disorder Program. And today I'm going to talk about the updates in the bispecific, which is a very critical and very important subject that I would like to highlight today. I have no financial relationship to disclose. And I'd like to start with actually the cellular therapies in general and the evolution by time that we have two approval CAR T cell, BCMA CAR T cell that approved back in 2021 and 22, the ide-cel and cilta-cel. We have three different BCMA bispecifics that got approved, the teclistamab, erlotinib, and linvoseltamab, and one different GPRC5D bispecific that got approved in August 2023. And these are exciting times about these treatments that play a big role in treatment and management of relapsed refractory myeloma. And the reason I think we need to talk about it is going back a little bit about the history. Why do we need these cellular therapies treatment? And it's really actually because we have really great treatments like immunomodulatory drugs, Revlimid and pomalidomide, proteasome inhibitors like Velcade and carfilzomab, and also we have the anti-CD38 such as daratumumab and isatuximab. But unfortunately, as we all know, that myeloma consistently have a tendency to relapse multiple times. We developed the updates that there is what we call triple class or pentaclass refractory myeloma, and these patients unfortunately have a poor survival. And as you can see, this is one of the studies that actually showed us that patients can have a survival if they're triple refractory myeloma of 9 months, and if they're penta refractory to 5 different drugs of the 3 classes, 5 to 6 months, which makes us need a newer class of therapy to help improve the survival for these myeloma patients. Now, I think the biggest question here is that why do we need a different class? And I think that we have seen multiple classes of therapies that was actually kind of advised. One of them is the BCMA-directed therapy, or what we call B-cell maturation antigen. And the reason I think comes from our fact this is a single a retrospective study that one of our colleagues actually from the U.S. Merck conducted, and you can see that in the left in the figure 1 was talking about those patients who we focus on pinta-refractory myeloma, as we know that the survival was about 5 to 6 months. Here we saw that the survival was only 12 months, which was double what we expected. But when we evaluated these patients who are pinta-refractory, we found out that the patients who got BCMA-directed therapy, whether it's a CAR T cell, a bispecific, or an ADC like belantamab, they actually have a better survival of 17 months versus those who are only pinta-refractory without BCMA treatment. They got a 6 months, which is consistent with Mammoth study. So the need of the BCMA drugs is that this is one of the first retrospective studies that we know that prove there is a survival benefit of using BCMA in those patients who are pinta-refractory specifically. So to go more specific about the BCMA, the bispecific antibodies have been interested to know about it. As we know, the mechanism of action that they have two arms. One arm focus on the targeted therapy, which in this case, either the BCMA, that we have the three bispecific treatments, the teclistamab, erlantamab, linvoseltamab, and also the GPRC5D, which is another bispecific target by talquetamab. And the other arm, target the CD3, which actually kind of like trigger the T cells to attack the myeloma cells by producing cytokines and causing myeloma death. So this kind of like a mechanism of action produces a very effective treatment, kind of similar what the CAR T cell, except that you have a direct off-the-shelf treatment that helps to get the myeloma under control. Now, moving directly to all the treatments that we have three major clinical trials that led to approval of these treatments. The Majestic 1 trial through the teclistamab, the Magnetis MM3 trial, erlantamab, the linker MM1, the linvoseltamab, and these three actually focus on patients who are triple exposed or triple refractory at least to IMiDs, proteasome inhibitor, anti-CD38. So most likely these are the patients that we see in that have a very poor survival, less than a year after they are well known that they have a triple refractory to these three agents. So it kind of makes sense to find out if the BCMA directed therapy, especially the bispecific, have the tendency to improve the survival. Now, historically, for a lot of our audience to know that prior to the BCMA, there were many attempts to use other treatments to see if there is any response rate that exceeds more than 30% or 40%. Unfortunately, most of these treatments did not show a really impressive results. 25, maybe less than that was the response rate that we saw, but even the progression-free survival was less than 3 months. However, during the studies, the Majestic and the Magnetis and the Linker studies, you can see that the response rate was averaged between 63% up to 71%. And you can see that the progression-free survival in this slide is not meant to actually make a comparison between the three bispecific. It's just to show you how much impressive and how much results we can see in those patients who are triple exposed or triple refractory myeloma. So you can see the teclistamab, the progression-free survival was about 11.4 months, while the erlantamab was about 17 months, while the linvoseltamab was about 18 months. So these results really actually showing that how much the bispecific can play a big role in treatment of the multiple myeloma, especially triple class refractory and triple class exposed. Now, we all understand also that the way and the step-up dose and how we actually give these treatments is different. We're trying to kind of learn about it more and more. We're actually moving to the right direction. Most of our patients are doing used to be inpatient to get the step-up dose. However, now we're trying to move by understanding that the risk of the cytokine release syndrome and the ICANS is minimum, and using some more techniques that we can decrease the risk. We are actually able to start moving these patients from doing it inpatient to outpatient, and that will hopefully in the future be available to our community oncologist colleague. So we know that teclistamab, erlantamab, both of them are subcutaneous treatments using the days 1, 3, and 5, and sometimes 1, 4 or 5, and 7 and 8 that these patients are given. Some institutions use the protocol exactly by keeping the patient in the hospital for 48 hours in the first day and the second step-up dose 48 hours. But now most of our institutions are actually trying to actually perform the teclistamab and erlantamab as an outpatient. However, actually the biggest question is that after we achieve the targeted dose, we're trying to move, instead of continuing weekly, is to move it to every other week week after 6 months, but some institutions are using what we call response adapted treatment, like that will allow us to redefine about how we schedule it. So some use, like, if you achieve MRD negativity or very complete response, and some institutions very good partial response, that you can move it to every 4 weeks instead of every 2 weeks immediately, and not waiting for 6 months. Their Lantinib have a different step up dose as well, like, use 1, 4, and 8, for the step up dose and until reach the targeted dose. And then it tries to actually move to every 2 weeks after 25 weeks, and then after 49 weeks is to every 4 weeks. The linvoseltamab, it's an IV, it's the only IV bispecific that we use, and it has a dosage that's one step up dose 1, 8, and 15. From what we know is that our community oncologist colleague believe this is a very good and more reasonable options for them, especially that they have to stay in the hospital in the first step up and first and second step up dose for 24 hours. Moving forward, the talquetamab, which is not a BCMA-directed therapy, it's a GPRC5D. We also have noticed that, unfortunately, as much as we are seeing a great response, patients are still progressing after the BCMA bispecific. So the GPRC5D, which is a different targeted therapy with the talquetamab, has shown a really great promising through the Momental study. And in these patients who are relapsed refractory myeloma, you can see that there was two tested dose, 0.4 milligram weekly versus 0.8 milligram every other week, which we choose it due to the fact that these patients have a better progression-free survival, about 11 months, and a better duration of response, about 17 months. And the survival of 24-hour survival was about 67 months. So you can see the response rate for these patients was close to 70%, 74%. However, the question about the impact of these treatments, the talquetamab, after patients receive a BCMA-directed therapy or CAR T cell, and you can see 66% of these patients still responded to the treatment, showing that really effective treatment to use, and the standard of using this treatment, talquetamab, after the patient progress on the triple drugs, IMiD, proteasome inhibitors, and CD38, and to use the BCMA as well if they progress on it. Now, the most important thing is that, as we understand, the effectiveness of these bispecific is well known. Now, the question about the adverse events, and I like to always to mention about the adverse events and compare it to the CAR T cell. So you will see a mix of the bispecific treatment and the CAR T cell side effects. And one of the things I always say, the commonest, is the CRS, cytokine release syndrome, the neurological toxicity, the ICANS, the higher risk of infection, the cytopenia. The GPRC5D considered to have a special toxicity that we will talk about that. Also, we have the cell-to-cell that shows movement and neurological toxicities like Parkinsonism features, which will make a small comparison between the CAR T cell and the bispecific. Now, as we saw, a lot of our community oncologists and many of our oncologists initially were worried about the CRS. And as we talk about that, if you see the comparison between the bispecifics, the BCMA bispecifics and talquetamab, you can see that the average is for all grades was between 45 to 72%. However, the grade 3 and above was very minimum in all bispecific, even the talquetamab, which is close to either 0 to less than 1%. And that's very critical and important because it shows a very important safety compared to the cell-to-cell and ide-cel, like was a little bit higher, 4 to 5%, than the risk of the CRS. So that's the reason why we believe that this is a potential treatment that we can use it in the future as an outpatient. Not only that, also we're learning about how we also can, if we feel like the patients, whether it's 40, 50%, up to 70%, when these patients have a median onset of the CRS, that you can see it's between 1 day to 2 days. Looking at that, that will give us a great a prediction to about how to treat and manage these patients' expectation about how to prevent these treatments, these side effects in the future. Now, the CRS breakdown of the bispecific is also important, especially with the step-up dose. As you can see that the higher percentage of these patients getting the CRS is the first step-up dose, except the talquetamab, it's the second step-up dose. And you can see that is also very important, is that sometimes many of oncologists, if they feel comfortable that the patient has less CRS, they might do, instead of doing it inpatient, they might do the second step-up dose outpatient, especially if they have if they tolerate the first step up dose well. Now, the CRS management is very critical for us, as we talked about it here, is that how we manage these patients. And as you can see, for the bispecific, we feel very confident that these patients can be well, they have most of the time grade 1 or grade 2 CRS, rarely grade 3. And mostly these patients receive supportive care treatment, whether they receive antibiotic, fluid resuscitation, if they have grade 2 with a low blood pressure. Sometimes supplemental oxygen depends on the grade. If they're grade 2, grade 3, they need a high supplemental oxygen. Of course, if these patients are require that, they need to be admitted to the hospital. Now, the question about using tocilizumab, it's not necessary to use grade 1 for grade 1. Usually, we defer that to the oncologist, but most of the time, these patients, who have fever, they receive antibiotic like Tylenol, and sometimes, they do blood culture and start on antibiotics for these patients. Some institutions tend to give these patients dexamethasone, feel comfortable that it has the same efficacy as tocilizumab, so no, and doesn't have any impact on the efficacy of the bispecific. Now, what about the biggest question about using prophylaxis tocilizumab, if that is applicable or not? Of course, there are some studies, and we're hoping that we'll start seeing more and more of these studies. This is actually written in the NCCN guidelines. So some of the oncologists who feel confident that they can do the bispecific outpatient, they're using more tocilizumab as a prophylaxis. There's a lot of question about that in the CAR-T. Studies showed that the overall rate of the CRS has dropped down, even in some single centers that use also bispecific, that dropped down to 10%, comparing to what we know that it was 70%. So using prophylactic tocilizumab could be another mechanism or another strategy that we can use to decrease the risk of CRS and increase the potential use of the bispecific outpatient. Now, what about the ICANS? Of course, this is a very critical scenario that patients have neurological side effects. As we can see here is that comparing, and the reason I put the cilta-cel ide-cel, which is CAR T-cell, with the bispecific is to compare the grades. I know I don't like to kind of to make that comparison, but to see is that like more than 17 or 18% patients will have any grade of ICANS versus between 3 to 10% will have ICANS any grade in the bispecific arms. But you can see the grade 3 is very minimum, except the linvoseltamab was about 2.6%, but most of the time, the bispecific less than 1%, they will have a grade 3 or more of the ICANS. And of course, what we usually do if the patient develop it, we tend to hold off the treatment, in case and give these patients some steroids and anti-seizure medications. Of course, these patients will need to be admitted to the hospital and evaluated based on their grade. We always use the ICE score in order to kind of like grade these patients in order to evaluate what type, what's grade of ICANS they have. Now, I don't want to mention the delayed neurotoxicity just to kind of put it, it's an additional side effect that we see it in the CAR-T2 studies, which is including the cilta-cel that include Parkinsonism features, tremors, memory loss, encephalopathy, sometimes personality changes. I have seen also cranial nerve palsies in some patients, like, facial paralysis and diplopia. I don't think we saw these cases in our bispecific patients, but it's kind of like we see these cases in the cilta-cel case. Cytopenia have been actually reported extensively in both CAR-T and bispecific. As you can see for the numbers, it shows that the cilta-cel and ide-cel have more likely to cause neutropenia, anemia, and thrombocytopenia, to the point that some of the patients will need not only growth factor shots, but will need a stem cell boost in order to further counts to recover. However, comparing to teclistamab, relatlimab, linvo, and talquetamab, you can see there is a grade 3 of neutropenia, but growth factor shots is more than often sufficient to keep these patients to recover. Sometimes dose adjustment, or I will say the word changing the dose frequency, can help as well if the patient achieve a complete remission, and that can be one of the strategies that we use for these patients. Now, talking about a very specific case of talquetamab, we all know that patients with talquetamab have some special side effects, that could be a taste change like dysgeusia. Sometimes they will have loss of appetite, dysphagia, dry mouth. Unfortunately, these side effects, the only way we can see these side effects improving is changing the dosage, the frequency. That's the only way. Rash and nail, sometimes we use some type of ointment, that will help to decrease that and improve it a lot in these patients. However, the efficacy of the talquetamab is really well known, especially if patients who progress on a BCMA-directed therapy. Now, the onset of these patients, we see it sometimes in the step-up dose. Unfortunately, some of these side effects like dysgeusia and dysphagia can last for a while, even after stopping the talquetamab. And sometimes I see it last after months of stopping it due to the side effects, and it takes time for it to recover, for patients to get their taste back. And as I mentioned prior to that, the strategies, the only strategy we have used for dysgeusia and most of the side effects, which weight loss is to decrease the dosage or change the frequency, which we play a big role. Unfortunately, sometimes we ended up stopping the treatment if the patient cannot tolerate that to these side effects. A very important topic for a lot of our colleagues is to understand about the bispecific has a high risk to develop, unfortunately, infection comparing to the CAR T cell. And we can say that grade 3 and more have been actually noticed about these bispecific due to the cause of aplasia of the plasma cells and the B cells in these patients, comparing to talquetamab, which is less likely to cause these risks. However, the strategies that we advise our colleagues is to do not only to treat their neutropenia with growth factor shot, but also to keep them on IVIG. And sometimes we start the IVIG in the step-up dose in order that we see that these patients respond really quickly to the treatment. We always recommend to have a low threshold to treat these patients and not to ignore it, and hold the treatment if they have any signs of respiratory infections, which is very common that we see in these patients. This is actually a major comparison between the CAR T cell and the bispecific. I talked through it, all that. And now I want to talk a little bit specifically about the new updates about the bispecific and why we're using it for our randomized trial. That this was the Majestic 3 study. This was presented at ASH 2025. And this was a major comparison between teclistamab with daratumumab, another anti-myeloma drug, with standard of care in relapsed myeloma, daratumumab Pomdex or daratumumab Velcade-Dex. The study was actually focusing on the progression-free survival and overall survival as secondary endpoint, and the response rate and the MRD negativity. In addition to that, the very important thing is the safety. Now, I want to go through a lot of these details, but one of the major things I want to talk about is the characteristics for these patients. Most of these patients were relapsed myeloma. The majority of these patients, median age was about 60, 64, 63-year-old. The majority of patients will have performance status that was, between 0 to 1. You can see that extramedullary disease was present about 14% in these cases. Stage 3 was only in 8% in both of the groups. The high-risk cytogenetics was in 35 to 36%, which is typically what we see in real-world data. As you can see, that the treatment history for these patients was very important, especially with our standard of treatment that we use teclistamab as a monotherapy after 4 lines of therapy. Here the median lines of therapy was about 2 lines. As you can see, the majority of these patients were either exposed to proteasome inhibitor or immune modulatory drugs, but they were not exposed to anti-CD38. Now we know that CD38 monoclonal antibody is the standard of care for earlier newly diagnosed myeloma patients. So we're talking about a different population patient. Only 5% receive either daratumumab or isatuximab. However, the refractory status, only 40% of these patients, 35 to 40%, were refractory to a proteasome inhibitor, while 85% was refractory to immune modulatory drugs. Now, this is a very impressive slide, and I like to always look at that slide from a different aspect, that how much the teclistamab daratumumab, after 3 years, showing a progression-free survival of 83% versus the standard of care that we use, darapomdex, was only 30%. So there's a big differences using the newer treatment like a bispecific, BCMA bispecific, using teclistamab, daratumumab, that shows a very impressive results. And of course, just kind of for our audience to know that this is not a fixed or finite treatment. This is a continuous treatment for these patients, and we're hoping to see what we see in CAR T cell, that a finite treatment to show an ongoing response for these patients in the future. The overall survival showed also that there was a difference in the teclistamab daratumumab. 3 years was 83% versus 65% in the darpomdix, darvelkit-dix. So it shows exactly how important this is, kind of like a major change in the treatment landscape for multiple myeloma. So we always have to remember that reason why we use teclistamab daratumumab in this case is because that also we're seeing a survival benefit. Now, I want to also point out for a lot of our audience that there's a big question about why there was a small overlap here. Don't forget that these patients with daratumumab, they are higher risk of grade 3 infections, as we talked about that, comparing to the CAR T cell that we saw. So this got actually be caught earlier. The reason why we want to be very aggressive in mitigating the infection rate to prevent treatment-related mortality from drugs like teclistamab and daratumumab. Now, to move a little bit deep, the safety is a very important concern. And I know a lot of questions about the COVID-19 might play a role because we saw a lot of patients having infection rate higher due to that fact. I don't think that's the only reason, because even in our real world with with the COVID vaccine available, we are still seeing a severity of the infection for these patients. And we can tell you that the upper respiratory infection play a big role in these patients. Pneumonia, other infections, including sinusitis, rhinovirus, bronchitis, influenza. I don't know if there's any reports about fungal infections. We have initially reported that in real world data about these patients getting teclistamab monotherapy, that they have some atypical infections, whether it's PCP pneumonia or also other fungal infections that actually occurred for these patients. But as always, we say that, with the comparison, you can see that patients who got upper respiratory tract infection grade 3 and more was comparable to the darpomdix. It was kind of like 4.2 versus 2.4%. And the patient who got COVID pneumonia was 11% versus 2.4, those who got grade 3 and 4. I think, using the IVIG initially in the step up dose is a very critical, very good strategy. Being very thoughtful about these patients are a higher risk for developing neutropenia and cytopenia, and to make sure that these patients receive appropriate supportive care treatments. Now, other side effects that we talked about, that is the hematological, that, of course, when you have a combination therapy of a drug that well known that it can cause severe cytopenia, it will increase that risk. So you can see 75% of the patients have grade 3 and 4. However, also, if you can look at the other arm, the darpomdix and the darvelkit-dix also have the same thing, 78%. So, in terms of the hematological, we, expect that. However, don't forget that the teclistamab daratumumab arm have a disadvantage about that it directed itself to the B cells, have a very high tendency as a single agent teclistamab to cause B cell aplasia. So that's why these patients with the neutropenia and the and you can see the lymphopenia, like 20% versus 11%, these patients have a higher risk for developing viral infections as well. Of course, anemia, and thrombocytopenia was kind of similar for both groups. Now, the CRS, kind of like we know that these patients luckily have only 60% all grades, grade 1 and 2, grade 3 and 4 was a 0, which is very, very important for us to understand it. And the reason of that about these patients are, if we're going to move most of these patients to earlier treatment for earlier relapse myeloma, we want to make sure that we have we're confident to use this treatment as an outpatient, and trying to move most of these treatments from academic centers to community oncologists. Other side effects like diarrhea, cough, pyrexia. I think we also noticed about that. Of course, there's a phenomenon that we see, that cough in BCMA bispecific. It's more commonly, it's unrelated, by the way, to infection, that we see it commonly using a BCMA-directed therapy, unknown the mechanism of this drug. However, just to kind of make sure everybody understand, although these patients have 0 grade 3, none of these patients have a prophylactic tocilizumab per the protocol, but only 1.1% of these patients who got teclistamab daratumumab have ICANS, and all of these patients side effects resolved, showing that this is a very tolerable treatment. However, like being very thoughtful about the infection rate. And by that, I would like to thank our host for including me, and I'll thank our collaborator, and thank you very much for this.
Thank you so much, Dr. Abdullah, for that excellent presentation. Next, we have Dr. Shaina Sarosik, who is an assistant professor of medicine at Boston University School of Medicine, who will be speaking on Wallenderson macroglobulinemia, the current and developing therapies. Please go ahead. Thank you, Dr. Starosik, for that insightful presentation. Next, we have Dr. Heather Cooper-Ortner, who is the President and CEO of the International Myeloma Foundation, who will be speaking on Beyond Survival. Over to you, Dr. Ortner.
Hi, good afternoon, everyone. It's lovely to see you all here. Thank you for joining us today. Thank you to the organizers for inviting me to be here to talk to you about living beyond survival with myeloma. I'm going to share my screen and hopefully this will work. Hang on with me just for a moment, please. So hopefully you can see my screen, and I will, okay, so I think you can see everything now. Can somebody and let me know if that's correct? I'm going to actually go to the very beginning. I'm sorry it's not set up that way. So again, I'm Heather Cooper-Ortner. I am the President and CEO of the International Myeloma Foundation, and it is my pleasure to be here with you all today. And I'm thrilled to be here talking with you about living with myeloma beyond survival. We talk a lot about being a survivor. I hear people using the term thriver. And I think it's time that we all begin to think about what life with myeloma is beyond treatment and surviving. So we are very excited because there's a lot that is moving really, really well in the myeloma field. This is a very exciting time if you're a researcher or if you're like I am working on the advocacy side of things, supporting patients and care partners. We've made extraordinary progress in myeloma care. People are living longer than ever before. But what we haven't fully addressed is what life actually feels like for people who have myeloma and for people who are caring for somebody who has myeloma and is living with it. Today, I want to talk about closing that gap for patients and care partners, for clinicians, and for industry. So let's see. So in a number of different cancers and across some of the larger healthcare fields, we talk about cancer becoming chronic. Myeloma, we talk about people being able to live significantly longer. We know, for example, that according to SEER, the 5-year survival rate for myeloma has dramatically increased over the last many decades. It's more than doubled since the 1970s. This is a success story. This is really something to be celebrated. And we have the scientists, the researchers, the clinicians, and our industry partners to thank for helping create this progress. But it transforms cancer into something ongoing, something that needs ongoing management and is not ever finished. Chronic is different than something like a flu. You have it and then you get over it. And so that changes how we should be thinking about care and how we should be thinking about living with myeloma. So with myeloma, as I'm sure you don't need me to tell you, we go through these cycles, right? So there's the cycle of active disease and treatments. We talk about first line, second line, multiple lines of treatment, and then maintenance, right? So eventually, most people, not all, but as we're seeing more and more, not all, but most people will have a relapse. And that means that it doesn't mean that it's over. It means that this is a constant cycle for people who are living with the disease and for their care partners. And these cycles are not just constantly evolving in terms of what treatment might be next, but it's constant cycles of uncertainty. This affects mental health, it affects ability to plan, it affects individual identity, and it affects your relationships, not just with your care partners or your life partner, with family, with friends, with parents, with children. And for clinicians in industry, we need to begin to think about this as part of the disease burden. This is not separate from it. This is part of the burden of having myeloma. And while we in the clinical space think of treating the disease, I like to think of how we create opportunity for people to live a full life beyond their current status as a patient. You're a patient when you're in the doctor's office. Everywhere else, you're a person with a full life who also has myeloma, or you're caring for a person with myeloma. So as we think about that, I want to begin to think about how we move from just surviving to living. I consistently hear people say things like, it's not just about how long I live, but how I live. And that's different than it used to be even 15, 20 years ago, where just being able to live more was the goal. Now it's not only the goal that people should be able to live longer lives and live their lives out till the end in which they die peacefully of old age, of something not related to myeloma, but that they should have the chance to live a good full life throughout that. So the IMF elevates this thought and elevates wanting to try to make this a reality through our patient-centered education, support, and advocacy. And I think it's time that we align what we do on the patient and family-focused side of things with our industry and our healthcare partners as well, so that lived reality becomes part of the endpoints that clinicians, as well as those of us who work on wraparound services, provide for people who have myeloma. And we now have tools to measure lived experience. They are lots of different ways of reporting lived experience. We hear a lot, PROs, patient-reported outcomes. I know sometimes scientists don't see them as reliable because they're not always used as according to a standard measure, but they are reliable, and there are validated measures that can truly measure lived experience. They're still underused in decision making, though. And so one of the things I think that's important is that patients have the opportunity to be a partner in decision making. That they be able to understand the system burden and the impact on their daily function that different treatments may have. This doesn't mean that you're going to reject that, but it means that you're informed about what life will be like when you agree to start a new treatment or a new protocol. And I think there's an opportunity for us to align clinical success, which we have an abundance of, and I see a lot more coming on the future, with what patient-defined or family-defined success looks like. And that's usually along the lines of, I want to be able to get up in the morning and do what I want. And we want to also make sure that we're aligning with emotional and cognitive health. And there's a lot that goes into emotional and cognitive health, and including social isolation, ability to maintain social relationships, to participate in daily activities, going to church, going to book groups, or doing things that add richness to our lives. And I also want to take a little bit of time to talk about care partners, because the care partners are critical to the daily care of a person with myeloma. And I really think that it's about time that we begin to think about care partners as part of the care team, not just a family member or a life partner, a spouse, a friend, a parent, a sibling. A care partner is somebody who is usually very, very involved in helping the patient make treatment decisions. And there's a huge burden on the care partner as well as on the patient. And I think it's time that we also do a lot more to support our care partners. They take a lot of responsibility on themselves, and an active and engaged care partner can truly contribute to better outcomes for the patient. In our healthcare system, care partners are often invisible. We don't see them, we don't often assess them, we don't often ask them how they're doing. They're seen as adjunct, as in addition to supporting the patient being the primary person. And that shouldn't change. The patient is the primary person in everything that has to do with myeloma. But more and more, the care partners need to be taken into consideration, especially as they have such a critical role to play in some of our newer immunotherapies. So one of the things I want to share is that the IMF provides direct support to not only the patients, but to care partners. We have a number of programs and we have support groups that specifically are designed to help care partners navigate their own experience of caring for somebody with myeloma. It is a very difficult process to be a care partner. And that cycle that I talked about at the beginning of my presentation of having active disease, being in treatment, then perhaps moving on to maintenance and assessing what next line of treatment might come about, also weighs very heavily and is a huge burden for care partners. There are care part for our scientists in the audience. There are care partner measures to help us understand how people are really doing. And we should also be assessing and evaluating the psychological, the emotional burden that sits on our care partners. They experience a great deal of anxiety themselves as they worry about the person that they're providing care for. So the cost of caring. So we talk about this a lot at the IMF, and the cost of caring is more than just what the copay might be. The cost of caring is not only financial, but also, as I was talking about, anxiety, depression, physical health declines. Needing to physically support a person who's in active treatment for myeloma can actually cause a care partner to have their own physical challenges. Strain is measurable and it's significant. There have been studies, and happy to share some sources with that if anybody is interested. But we do know that supporting care partners, improves adherence, outcomes, and system efficiency. So really taking care of the carer is something we should also be adding to our daily discussion of myeloma care. And here's a term that's, I think, grown in nomenclature in our vernacular over the last decade and a half: financial toxicity. Patients often have to make real trade-offs. Patients and their families have to make real trade-offs in how they navigate the finances of myeloma care. They make decisions between what treatment is available, what treatment might be best, and daily life. And sometimes those decisions can be very, very difficult. The IMF works very hard with our advocacy efforts, both in Washington, D.C. and in different states, to do whatever we can to reduce barriers and make sure that access is equitable for people whose physicians, whose treating clinicians actually recommend and prescribe a specific treatment. Our goal is to make sure that every myeloma patient is able to access the treatment that's best for them at any point in time during their disease experience. We don't feel that it's appropriate for people to have to make those financial trade-offs when you're considering what treatment might be right for you. We also know that when you are stressed financially, that it can lead to missed appointments, and it can directly impact different outcomes. And we know that this is a disease that is a very expensive disease to manage, and it can create long-term instability for families. And that's something we also need to address and make it better for people who are living with myeloma, so that it doesn't put their families' lives in jeopardy to be able to treat one person. So innovation is amazing. And for those of you who are joining us today, I know you're likely very, very aware of a lot of the new therapies that are available. Some of them are really, truly breakthroughs. And the ability to improve outcomes for people to live longer and live better is really very exciting. You've probably heard, if you're joining this kind of a call today, that there's already a discussion about what does cure mean for myeloma? How do we assess, how do we define what cure means? And that's really, really exciting and something we should be, again, celebrating. But that's not necessarily true for everyone who may be diagnosed with myeloma. And we're still seeing barriers to access across different populations. And so the IMF is also very committed to working on improving access for different populations. Our program Empower and a number of the global initiatives that we promote and run across the world work to address disparities in care and outcomes. We know, for example, that the African American and Black population gets myeloma at twice the rate of white people. However, they are often diagnosed much later in the disease, have heavier disease burden, and then also have poorer outcomes as a result. So we really feel that it doesn't matter where you live, what your background is, or where you may be coming from, or where you seek treatment. Everybody should have access to the same innovative therapies and to the same opportunities that have the potential to improve people's lives, no matter where they live. So I invite you all to reach out to the and get involved with us. There's a lot that we do that I think actually leads to helping people live longer and live better lives. We provide a number of education programs across the disease experience, from newly diagnosed to people who are experience a relapse or have become refractory to one of the treatments. We provide direct patient support and treatment support in terms of how to make decisions. We also have group opportunities, whether it's a patient and family seminar, whether it's a support group. We do a lot to connect people with each other and a lot to provide the education and tools that you need in order to be active in your own care. The IMF sits in a very interesting and special place in the myeloma world. We sit at an intersection of science and lived experience. And that translates complexity into clarity. It takes advocacy and moves it into action. And we are dedicated to making changes in access and equity for a number of more challenged populations. So we look at what progress for myeloma means and for people who are living with myeloma. The future of myeloma care is people living longer, living better, people being supported at every step of the way, and equal access for everybody, regardless of where you may live or where you may seek your care. This is the future of myeloma care. And anything else, anything less than this, is incomplete progress. So this is what we are dedicated to making sure happens. So if I go back to the beginning of my conversation and talk about cancer being chronic, myeloma becoming more chronic, it means that care must be continuous. That care must be not just person, but also family-centered. Myeloma doesn't affect just one person, it affects everybody in that person's life. And care must be equitable. Each of us has a role in making that real. And we invite everybody to participate in this process. This means that we have to expand psychosocial support, means that we have to integrate care partners into care teams completely so that they are acknowledged and that their needs are also addressed. We need to address financial toxicity at the public policy and legislative level, and we have to recognize it as a clinical issue. And we need to ensure equitable access across to every new innovation that comes down the pipe. We are very fortunate in the myeloma community to have so many current options and new choices coming in the next year or years. There's a lot of very exciting things happening, and we believe that everybody should have access to it. So our mission is to improve the quality of life for myeloma patients while working toward a prevention and a cure. And our vision is a world where every myeloma patient can live life to the fullest, unburdened by the disease. Thank you. That's the end of my chat. Is there anyone else still there? There we go. Hi, Anissa. So I'm not hearing you. Is that me?
Can you hear me now?
Now I hear you, yes.
I just wanted to extend my gratitude for the wonderful and valuable presentation. Now we'll take a short break and we'll come back up shortly for a panel discussion moderated by Dennis Picker, Dr. Dennis Picker. Thank you very much. Welcome back, everyone. We'll now move into our panel discussion. It is my pleasure to introduce our moderator, Dr. Dennis Cooper, who will guide this session. Dr. Cooper, the floor is yours. Jimmy Matcha.
Great. Hi, everyone. Hear me?
Yes. Yes.
Oh, perfect. That was a great meeting. I tried my best to follow everybody's talks as much as I could during my clinical work. But I would just like to open the panel and discuss any questions or any comments you have.
Yeah, I think maybe I can start.
Please.
Yeah, it's a great meeting. I think heard few talks in between the other meetings, but I think this meeting represent, I think, really where we are heading in myeloma, like all the current studies where we are using different CAR combinations, bispecific, and R combinations to really make a reality that myeloma can be cured. We are not there yet, but I think it seems in maybe coming decades we will be there. And like really nice mechanistic data presented how different therapies are working. So I think I'm really thankful to OncoDaily to organizing this meeting and inviting me, as well as the other speakers who are so talented and presented such a great data.
Thank you. Thank you very much. I agree. This was a great meeting, and we just learned a lot from individual research and clinical experiences from our experienced hematologist here. So, what do you see the next direction is in myeloma? What is the most exciting happenings right now, according to your experience?
I think I think few exciting avenues in myeloma happening right now. One is that we are already thinking that how can we really stop the conversion of progression of myeloma, like from MGUS to SMM to myeloma? Can we really like stop it even it become myeloma? We stop it at smoldering myeloma stage? And there is multiple studies which are currently undergoing have shown the results like that if you treat high risk smoldering myeloma, I think like they don't have long-term outcome data, but available data says that the outcomes are much better. They are able to eradicate all malignant plasma cells. So that I think is one interesting space where we are. And I think recent approval of MRD as a endpoint for the trial is the second, I think, major thing that happened is now we don't need to, I think, kind of wait for a decade to say like, oh, what is happening with this patient? Like with the sustained MRD, like we are able to like now say that the patient is responding or gonna maybe have a better PFS. That is, I think, the second thing. And third thing, I think, is like we are now like not only just focusing on myeloma tumor component, like the plasma cell biology, but we are like thinking deeply into the immune system because like our team, other teams are now showing that if your immune system is healthy, that can get you a long-term sustained remission. So I think we are now thinking how the immune system is playing a role at the first part, but then we're also thinking how can we add immune system along with like stromal component and the tumor biology to achieve long-term outcomes in myeloma. And then we are um, like I just recently come from meeting IW myeloma, where I think it's already becoming clear that a lot of people are thinking of using um, CAR Ts bispecific as a frontline therapy, not in relapse refractory setting. And I think that is a thing if that gives us like much better sustained remission and much better overall survival as a progression-free survival. And that seems to be true from the early studies, but I think let's wait and watch. But I think like mm, myeloma is kind of getting toward a cure. We are not there yet, but I think these are the exciting things I see based on my experience from this field.
Thank you, Dr. Bastin.
Yeah, just to add on what Dr. Bastin's already laid out, I think one of the most exciting results of the trial are Majestic 3, which has looked at in ASH 2025, the presentation. I think that is going to change how the myeloma landscape how the myeloma is being treated even in the community, right? So the dramatic results with bispecifics in just after first line of therapy is quite remarkable, and it almost reminds me of the trials where CAR T is being used in earlier lines of therapy. So it kind of it kind of builds on the framework that inherent immune response from the host can achieve just as good of a response and longer durability, perhaps, which we'll know in the future, just as a CAR T could. So, I think that's another avenue where you might see a lot of patients being treated in community in the future who are BCMA exposed, and that might change the treatment landscape of myeloma quite a bit.
Great, thank you. And I have one more question for our hematology colleagues. How is the myeloma management different in community and academic setting right now with MRD and all the molecular workup? And we know that we have a lot of clinical trials going on, mostly in the academia, but what's going on in the community?
Well, thank you for the invitation. I'm from Senegal, and as I mentioned earlier, there is royalty in terms of management of multiple myeloma worldwide. As we all know, in low-income countries and mild-income countries, sometimes there is no difference between what we do in what we did in academic or in real life, as first line therapeutics sometimes can pose a serious problem. As they mentioned it, first line, how can I say, they can use CAR cell therapy, but in reality, in some contexts, in some setting, even first line therapy using bortezomib regimen sometimes can pose a real problem due to the cost access treatment, and it is a reality. That's why there are different between results in terms of outcomes in the management and of multiple myeloma. The landscape is not the same on countries' experience and drugs availability.
Right.
Thank you for your input, Dr. Doda.
In the US, I would say the academic centers have sort of adapted the MRD testing quite a bit, mass fix MRD testing, and I usually would not see those done when I see patients from the community. Or the MRD adapted treatment strategies are generally not that in vogue in the community, I would say. I would mention that the quad is also not in vogue in the community in the past, but more recently I'm seeing quad all over the place, and so I think it's probably because of the NCCN guidelines have evolved and have adapted quad in the frontline setting. NCCN guidelines direct a lot of therapy that actually occurs, that actually is administered in community. So evolving NCCN guidelines is probably what's going to determine what happens in community more so than in academia. And I think Dr. Cooper has some comments.
Yeah. So I would like to just add that I think that it's a very broad experience for what people have in community, and we actually see that especially in some communities. For example, the African American community is less likely to be treated with a tri-specific for the bispecific up front anyway. Like, we just know that they're not getting access and they're not getting the triple therapies, let alone the quads. So, an MRD it really depends. Are you seeing a hemonc in community, or are you seeing a general oncologist? And if you're seeing a general oncologist, you have yet to get to a myeloma specialist, then the treatments that that people may be receiving some of the further away from academic centers is really not keeping pace, even with NCCN guidelines. And that's true for rural settings as well. So we think there's still a lot that needs to be done in terms of educating community oncologists, community setting hematologist oncologists as well. We think that it's important that myeloma patients all be referred to a specialist for a consult, at least for a consult, even a video consult if they're not able to travel to an academic center. I think the range of what a patient experiences is really, really broad. And it's one of those things that we think that there's incredible movement for those patients who are able to seek care with a myeloma specialist at an academic center or at a major health system. But for those who are not seeking treatment in that setting, it's the treatment that they receive is just, it can vary quite a bit. And no, I don't think that MRD it's not being measured. It's not, and you're right, Dr. Mehta, that they're not usually using those protocols in community settings either. So that aligns with what we're seeing as well.
Right.
Thank you. And I have one question for Dr. Doda. You're joining from Senegal. Thank you very much. We really appreciate your presence and the information you provide. What is the biggest challenge in your practice in Senegal managing myeloma patients?
Yes,
I
in
know that
Senegal.
you mentioned the access to drugs.
Mm, mm. Yes, yes. There are several challenges we face right now regarding the management of multiple myeloma, and the first one is the availability of hematology department. As we know, currently there are only two major hematology services in Senegal, and a fewer hematology units which are in medical service or medical department. And this situation leads sometimes to delayed diagnosis. The onset of symptoms and the distance between the patient see a specialist sometimes could be very long. And also the situation might lead to misdiagnosis. As you know, if we don't have many hematology departments, they prefer to see a specialist. And the other challenge, as I mentioned it earlier, is availability, the restricted drugs in our context, because the assurance systems is not so spread, and patients must pay directly drugs. And we all know this molecule is too expensive, such as inhibitor, proteasome inhibitor, regimen, and lenalidomide. Even in first line therapy, sometimes it could be difficult. That's why in my presentation, the common therapeutic protocol which are used in our context is the protocol associated cyclophosphamide IV, thalidomide, and dexamethasone. And there are some patients who underwent the protocol associated bortezomib, lenalidomide, and dexamethasone. And recently, we started to perform bone marrow transplantation, and currently we have performed only two patients suffering from multiple myeloma. And also the availability of some tools of diagnosis, such as cytogenetic molecular analyses, which are not available in public hospital. And to perform those analyses, we require private facilities where they are too expensive. There are major challenges, but we are committed to do our best to providing our patients the best possible care they require.
Thank you. Thank you very much. So I have one more question. We we listened to great talks today, and one particular talk that was very interesting by Dr. Francesco Mora about the mechanisms of resistance to immunotherapy. Where do you see the direction in overcoming, because immunotherapy is very important for us for many malignancies right now, and in myeloma particularly. Where do you see the science and clinical practice is going with resistant patients?
I think, like, based on, I think, the data that is emerging from Francesco's group, or Nizar from Calgary. So I think the acquired resistance to all CARs and bispecifics is mainly driven by, like, point mutations in the binding domain of BCMA. So I think one of the strategies, I think multiple groups, I think, are trying is, can we use multiple different modalities? Like, can we use BCMA CAR for some time, then we use, like, GPCR5D CAR basically, and keep on changing them. But availability, I think, is a major deal. And then second, I think they are thinking is, can upfront we use, like, trispecific CAR or bispecific CAR that is binding the two targets so that like it can take care of all heterogeneous plasma cells. Like if the plasma cell have low expression of BCMA, then it is going to escape. So I think uh, that I think is the strategy I think people implementing in some of the studies I think are being planned basically like where they are saying like, oh, give frontline CAR, take care of bulk of the disease, then give you a standard quad or triplet therapy followed by that. So I think that are the emerging concepts in the field, uh, and like uh, sometimes we are also thinking basically like, is this acquired resistance to these cars is emerging that we are putting too much pressure on BCMA. So like BCMA acquire the resistance because like uh, we are directing too much therapy against them. So I think in coming time, I think you will see like a lot of studies where the dosing as well as combination of different CAR and BiTEs will be evaluated to reach at an optimal place so that we don't have acquired resistance that we are observing right now due to mutation in like binding domain of BCMA. And I think a lot of people are also trying to uh, develop new CAR modalities, new bispecific modalities, which they think might be not going to be as prone to getting acquired resistance as BCMA. So those are all the strategies I think being evaluated right now. But this field is quite new, so the data is in very early stages. Yeah.
Thank you. Any other comments or questions? And I have one more question. I always have questions. So, did I interrupt someone?
No, so I would just want to add, I think that myeloma is very innovative field. I think uh, like all like the academic investigator, all the community physicians, they participate in some of the innovative trials, I think, where they are using like are like modified dosing basically for the therapy, as well as combination of CAR and BiTE, or like two CARs and using bridge therapy. So I think all of these innovations, I think, put myeloma, I think, in limelight in hematological malignancies, and I think genomics in myeloma is pretty well defined. I think there are the teams like Francesco Mora, there is a team from Dana-Farber, there is a team from Mayo Clinic, Washu, Emory, which are like doing great amount of work in the field, like define myeloma genomics and even myeloma immune microenvironment. And I don't want to exclude anyone. I like Miami team also doing a great work, Wisconsin team. I think everyone is, I think, like really working toward defining what is causing the resistance, both on the part from myeloma cells itself, as well as from the immune component itself. So we have much better understanding on myeloma side, basically like what is causing the resistance, but now the immune uh, side is also emerging, where like multiple groups are showing that like accumulation of these late effector T cells or the tired immune system, inflammaging is causing all the acquired resistance here. So I think um, future is looks pretty bright for myeloma field. That's my understanding.
Also, as a follow-up to that, I have a question regarding the health disparities in myeloma. And we know that emerging data in quite the large cohorts are showing that not only epidemiology, but also mutation and response to treatment and resistant rates are different between racial groups, right? So is there any difference in the practice when it comes to the patient groups with the prediction models?
I don't think we're there yet. I think we know that there's discrepancies, but we don't really understand the underlying biology and kind of call it genomic really disparities between groups. I think it's definitely not an issue of access to care or other sort of peripheral issues, but a true sort of biologic difference. I think the key is, you may see subgroup or post hoc analyses on different trials that show one thing or another, but the issue is not that there is or there isn't a difference. I don't think we haven't systematically really looked at it in any prospective way. And at least in the US, I mean, I think that's one of the concerns, right? Especially with the US regulators, right? Because we, as it is, have a hard time getting sort of minority subgroups on our studies. And then more and more, because of the regulatory burden, a lot of, pharma and industry, they do their studies ex-US, and actually usually that makes it even more homogeneous instead of heterogeneous in terms of racial groups.
Yeah.
But I think the general trends, I mean, there's nothing magical about any racial subgroup. I think they all probably benefit, but how much and what the delta magnitude is, we don't know.
Yeah. And I think I fully agree with like Dr. Dikran, what is basically that we don't see a huge difference. I think, and like we, if you look at the COMPASS trial done by Multiple Myeloma Research Foundation, there we do see basically that like patients of color, basically they received less transplant. But do that alter the overall outcome? It doesn't seem like to us, basically. And we just finished a study where we mapped the immune microenvironment of and compared people of color as compared to Caucasians, and we see some differences, and they are maybe driven by germline. We do see some differences in NK cell biology in these two groups, but is really going to translate into outcome? That I think we are not sure of. But even looking into like the COMPASS trial that is done a decade back, study, like there's no difference in the outcome. So I think there may be different way of biology to outcome the to take care of the disease in like people of color as compared to whites. But I think we are still in very early stages, and most of the studies, I think they're like very small number of people of color are being enrolled in those studies. So I think we need to maybe like, if we really want to understand it, we need to do studies which are focused on diversity focus. And based on my understanding, there is no large studies which are doing it. Yeah.
Yeah. I mean, I would concur with the prospective analysis as being the right method of measurement in this particular question. However, I would point out a few retrospective studies, and actually it's one of them I was involved with, where we analyzed a large VA database and actually African American, and the main core of this study was that the VA has equal access and equal insurance. So that really adjusted for access to care. And it seemed like the African Americans did quite well in that particular context. So the biology was actually better in African Americans compared to whites. And their response rates were actually improved compared to other racial groups, subgroups.
Yeah.
Thank you. Anything else you would like to add?
maybe I would like to ask the question to hematology colleagues, basically, like, so what you see maybe next 5 years will be an ideal therapy for a myeloma patient, and that is maybe not in academic center, maybe in a community setting. Like, what will it be? Like, it will be a frontline immune focused therapy, or it will still gonna be our normal traditional route?
I don't know if in next 5 years, but I would say in however many next years, an ideal therapy would be an allogeneic CAR T that has no CRS, ICANS, or any of the other side effects, is TCR knockdown, is being administered to all smoldering myeloma patients, has no very concerning adverse events like we have seen with BCMA cards, some of the BCMA cards, right? So, I mean, that would be the ideal scenario, which is, I don't know how likely it is to happen, but that would be the ideal scenario, I would say.
Fantastic.
I think in the next 5 years, like in the community, you said, I think there will be sort of this gradual, slow uptake of quadruplet-based combination therapies. I think the community, on average, takes about 5 to 10 years to sort of catch up to the academic centers in the U.S. I think in the centers that are, leading myeloma centers, I think really what's going to be developing is, I don't have a solid answer for you, but I think you hit the nail, the nail on its head, where it's really going to be this combination, this competition between, I think, quadruplet versus an immunotherapy. And I think immunotherapies have definitely moved up to earlier lines, but whether that benefit and risk threshold is very different in relapse refractory, fourth line, third line, second line, to newly diagnosed, right? I think quadruplet based therapies, right, there's a pretty high bar in terms of MRD negativity and time to event endpoint. And so I think it's going to be difficult to know. Maybe it'll be patient dependent once we understand the biology more, and which patients, do better with one class of therapies or the other. But I personally feel, I have my own bias because we have a study that I've written, and this is what I'm thinking patients in the next 5 years, 10 years will get quadruplets. And for those who are at least functionally high risk, meaning they remain with MRD positivity, then I think some kind of like immunoconsolidation with CAR T treatment or bispecific T cell redirecting therapies, fixed, not forever though, but fixed duration, will be the way to go. I think autologous transplant in the next 5-10 years will continue to be less and less popular. Although my opinion may be not popular right now, but it's a little more popular than it was 5-10 years ago when I used to say this. But I almost feel like at least the current state of science with our CAR T treatments like cilta-cel, and given the benefit risk, I think it's going to go later lines of treatment. And I feel like it may be like sort of the new autologous transplant in terms of the first thing that you would grab up when you need something for immediate salvage therapy in an earlier line, maybe with the first relapse or second.
Fantastic. Thank you.
Of course, I should just add, everything I'm saying is really based on, what we're doing in the US. I think it's very different. I mean, but it's not only just different in, it's different even in Western Europe. I mean, outside of clinical trials, many patients don't get like all the things available that in America that standard of care patients. That's why a lot of times they enroll so well in Europe, is because it's just so much better, the treatment's available than on standard of care. It's not a third world phenomenon either. I mean, I'm talking about Western Europe,
Yeah.
And do you guys have any message for the research teams who are working in myeloma, where they should be focusing on?
I think the more translational scientists are really focusing on those, which is like sort of to dissect down, I mean, why are there 60 lymphomas and only one myeloma? Well, it's not just like one myeloma. In fact, it's because there's like 1,000 myelomas. It's too complicated. And that's why we can't do like 60 different or whatever it is, not for lymphomas. I don't even know in the WHO. But I think as we dissect those, there's clearly patients who do really well with the typical novel therapies, meaning like the proteasome inhibitors, immunomodulatory, etc. Then there's like a class of patients who don't do well even with those, but do well like with CAR T or bispecific. And then there's actually really a class that really do well with more cytotoxic chemotherapy, and I think a lot of the resistant and those groups that are responding or not, I think the translational researchers are really focusing on it. And I think as we narrow those things down, I think the community is doing what they need to. I think as clinically we need to get like past this, like a lot of these traditional ways to characterize high risk disease, which is like kind of antiquated, like with fish and stuff. And then we like really need to sort of understand, we don't know, but really kind of work in how risk is really iterative, depending on the treatment you use, based on the subtype of myeloma you have, right?
Correct.
I mean, that's why, like, the simple example is like the 11-14 translocation. Traditionally, it's always been sort of low or normal risk. And then, but in some papers show that it's actually a high risk, but it really has to do with what therapies they're getting. And not all 11-14 is the same either. We know that. And I think, a subset of 11-14s probably have more lymphoma-like biology. And those are the ones who are probably not doing as well, on the myeloma, novel myeloma treatments. Actually, maybe the ones that should get, melphalan or maybe more cytotoxic therapy. But this is all speculation, everything I'm saying. And I think the next decade or so is like this stuff has to just all be mapped out eventually.
Yeah. And I 100% agree, because we just published a study like where we looked at the immune microenvironment of each major cytogenetic subtype of myeloma. And if we take T414, and that is a high risk, and compare it with like P53 mutated subtype, they have very different kind of immune microenvironment. Like if we look at T414, we see less interferon 1 production, more T cell senescence, more kind of exhaustion, more accumulation of these late effector T cells. But a very opposite picture of that seems to be there in P53 mutated subtype, basically, where we see there is no much exhausted T cells, basically. So there is like something else going on in that subtype. So I think I think we are on that road, basically, that we are going to be further define them based on cytogenetics, based on like all genomics techniques that are becoming available, and now the spatial genomics is also becoming available for the field. So I think we're going to have much better characterization down the line, and that might guide us to choose what is the optimal therapy should be there. So yeah,
you're right.
maybe exciting times. Yeah.
It is. And I agree with that. And we have such an advancing technology in front of us. Not only just the medicine, just the biomedical science is advancing so fast. We can't even look at and measure the activities of cancer cells in organelle level, and just tell how the cancer cells are going to survive immune system or drugs and everything. And one question I have, for instance, for acute myeloid leukemia, every time there is a patient, a new diagnosis, we start with a large menu of tests for acute myeloid leukemia. And You have STAT testing for FLT3 and NPM1 mutation with a lot of options for targeted treatments for those patients, APL aside. So do you see a future for myeloma patients like this? Because we don't necessarily employ NGS or whole genome sequencing for diagnostic purposes in myeloma. We do MRD, but that's a whole different concept than the regular large gene panels. So what are your thoughts about that?
I think eventually we will. I think we're not there yet. I think myeloma, we don't, outside of the BRAF V600E, we don't really have targetable like point mutations, which are relatively easy to create a device that can go commercially and et cetera, be used by like anyone. Outside of that, they're like, larger genetic, alterations. And things like the IGH translocations, you guys probably know better than me, but are a lot more difficult to do on a NGS capture like
Yes.
panel, and for commercial high throughput use. I mean, so many groups have tried it. It's been like a decade yet, but I guess it just hasn't. We're just not there yet in a scale and perfected where it would only just make sense to replace it with fish, which I'm a little bit shocked about, because it's not like fish is a cheap study itself. I mean, it's like laborious and I mean, I don't even know why we still do cytogenetics and karyotyping. I mean, it doesn't even work in myeloma. But I think the technology, it's the problem is these cells, the plasma cells are in the bone marrow, right? And our tools right now, their resolution, we can't, like in leukemia, use the blood, right? And then you need to sort of isolate CD38 cells, right? Or else you can't just like get a marrow sample and run the NGS. It's like very challenging. So there's all these like steps that are laborious and need to be set up, and in a clinical hospital lab, which is not dedicated to sort of myeloma. I think it's like hard, but eventually, just like anything else, we'll get there. We'll do it.
100% agree.
Great. It's 3:45 my time, Eastern time. I don't know how much time we have allocated for this panel discussion, but if nobody has additional comments or questions, we can conjure and move on with our rest of the days.
Yeah.
It's great to have you. Thank you, everyone.
Thank
you,
everyone.
everyone.
Thank
This
you.
was a great
Thank
meeting.
you all so much.
Thank you.
Bye-bye.
Bye-bye.
Thank you.
Thank you, Dr. Packer, for your wonderful moderation. And my sincere thanks to our panelists. It has been a privilege to have you with us to hear our perspectives on multiple myeloma. I would also like to thank our global audience for joining us today. Your presence and engagement are what makes these conversations truly meaningful. At OncoDaily, our mission is to give a voice to everyone, and today's discussion is a reflection of that shared purpose, bringing voices together across borders to advance knowledge and care. It has been a pleasure hosting you, and we look forward to welcoming you again on April 30 for our next session in the series of How I Treat Head and Neck Cancers. I hope everyone has a wonderful day. Thank you once again.